मेरे ख्याल से आप सब लोग इतने एफर्ट्स करके आ गए हैं, तो लेट्स डिस्कस. मेरे ख्याल से विद इन 5 minutes विल स्टार्ट. आई एम रेडी, बट इफ़ द पीपल आर ऑन द वे. अच्छा, आप सब में से कौन कौन एलर्जी प्रैक्टिस कर रहा है? आई मीन टू से पर्सनली एलर्जी टेस्ट एंड इम्यूनोथेरापी. ठीक है, ऑल राइट, ओके, वंडरफुल. अभी जो ऑल राइट, ग्रेट ग्रेट ग्रेट. आई एम इन टू दिस सिंस लास्ट 20 years, और it's a really wonderful branch, super specialty of ENT. Or now in upcoming days, allergy will be more and more important, because already in developed countries, allergy is really too much. The incidence and prevalence is around 35 to 40, touching 45% in developed countries. And in India, we are moving fast towards developed countries, to become into the category of developed countries. अच्छा, आप लोगों में से कौन कौन, आप जैसे दोनों करते हैं प्रैक्टिस, कितने एलर्जन से टेस्ट करते हैं? हम जस्ट इनफॉर्मल, जस्ट लाइक ए फैमिली, वी आर जस्ट इंटरेक्टिंग. ऑल राइट. आप लोग कहाँ रहते हैं? अच्छा, ओके. अभी वैसे प्रैक्टिकल डेमो भी सारा सब लेके आए हैं, वो भी सब होगा. और आई स्टार्टेड विथ 166, देन आई केम टू 140. वो मैंने 140 वाला मैंने यूरोपियन एकेडमी में भी प्रेजेंट किया था. और देन नाउ इट्स 127. क्योंकि क्या है, लाइफ इज़ अ कांस्टेंट लर्निंग प्रोसेस. एवरी डे यू लर्न सम और द अदर थिंग. जस्ट एक मेरा अनुभव शेयर कर रहा हूँ आपसे. एक पेशेंट पिछले महीने आया. आई एम इनटू सबलिंगुअल इम्यूनोथेरापी. 3rd बॉटल थी 1:500 वाली, 1:150, दैन 1:100, 1:50. ये सब 1 a week वाली होती है. बोले, और अगर 1 a week 5 drops 1 a week सबलिंगुअली डालते हैं, तो ये करीब करीब इट लास्ट फॉर अराउंड 6 months, 5 से 6 महीने तक वो चलती है. बोले, डॉक्टर साहब ये बॉटल तो 2.5 से 3 महीने में ही ख़त्म हो गई. आई वॉज सरप्राइज्ड. मैंने कहा या तो कहीं मैन्युफैक्चरर से, जहाँ से हमारे पास इम्यूनोथेरेपी बन के आती है, वहाँ से क्वांटिटी में गड़बड़. फिर हमने सोचा कि अदर वे राउंड. मैंने कहा यार कुछ न कुछ गड़बड़ है, क्या करना चाहिए? देन आई थॉट, मैंने कहा नाउ बेटर. मैंने कहा कैसे ले रहे थे? बोले बस डॉक्टर साहब ज़ुबान के नीचे डाल रहे थे. मैंने कहा आप काउंट कैसे कर रहे थे 5 बूंद? बोले अंदाज से. देन आई रेक्टिफाइड माई थिंग्स इन अ वे कि जब आपको सबलिंगुअल ड्रॉप्स डालना है, मिरर शुड बी इन फ्रंट ऑफ यू, सो दैट आप देख पाओ कि 5-5 ड्रॉप ही जा रहे हैं. हो सकता है उसने 5 ड्रॉप की जगह 6 ड्रॉप, 7 ड्रॉप, 8 ड्रॉप डाल लिए हों. तो दिस वे वी लर्न. जी सर. सर इट्स a sublingual one. You have to keep it sublingually. Even, yeah, under the tongue. That is also very correct. Yes, yes. She's another faculty. Pardon, sir? No, no, sir. It's sublingual. Reason क्या है सर इसका? Sublingually there is a submandibular lymph channels, and from there, from lymphatics, it goes to the submandibular lymph nodes, and from here it is absorbed. Basically, immunotherapy is absorbed via lymphatic route. अभी जो लेटेस्ट भी आ रहा है वर्ल्ड ओवर, दैट इज़ अ इंट्रा लिम्फेटिक, दैट इज़ अंडर ट्रायल. हमारे साथ क्या रहता है, सबलिंगुअल इम्यूनोथेरेपी हम देते हैं. इट इज वी हैव टू गिव मिनिमम फॉर 2 years. रश और क्लस्टर इम्यूनोथेरेपी चल रहा है, बट मिनिमम 2 साल हमको देना पड़ता है. और कई बार पेशेंट्स प्रैक्टिकली इट बिकम्स डिफ़िकल्ट टू आस्क देम कि नहीं यू हैव टू टेक इट, और फॉर द बेस्ट रिजल्ट इट्स 3 to 5 years. तो पेशेंट उस पर कायम रहे, लेता रहे, इट बिकम्स लिटिल बिट डिफ़िकल्ट समटाइम्स. इंट्रा लिम्फेटिक only 3 doses. आज एक, after 1 month, and then after 1 month. 3 doses. Ultrasound guided inguinal lymph nodes में you have to inject. So that is like that. Dr. Sunita? Sir, 80%. 80%. I got 80% around. और सर इसमें क्या है, multiple things are there. Patient's own immune system, how regular he is, allergen selection, all things, they matters.
Sir, out of this thing, regarding allergy we are talking, few months back my wife suffered severe idiopathic skin allergy. Skin, she had rashes and this thing. And she used all medicines, from Avil to all non-sedative antihistaminics, sedative antihistaminics, all types of medicine. It was getting severe. Then they started steroids, no relief. Then they started this immunotherapy drugs, methotrexate or something, and she was not at all getting any relief. Then suddenly we had an idea that we went to a homeo doctor who is a MBBS doctor also, and in Gudiwada, principal, he retired. And for my surprise, he gave for 3 days. Till today, she has not got again a rash.
Wonderful.
And
That's really
same
great.
thing happened to one dentist. After my wife suffered, we were talking in a group. Then he suffered. He suffered for about 1.5 months. And later, no relief at all. Then we referred him. He had an excellent result. Within 3 days, stopped. For the last 9 months, I think, she is not getting any rash at all.
Only 3 days treatment.
Only 3 days treatment, sir.
That's wonderful, really wonderful.
That's what, I mean, for allergy, I usually refer that my patients of papilloma to that homeo doctor.
Okay.
I removed one papilloma around 25 years back, extensive papillomas of vocal cords for adult. And he gave only dose for about 1 week or 10 days. Till today, he is my good family friend. He never recurred at all papillomas.
That's really wonderful.
But not for everybody. But
Yeah.
for some patients, that result is not so good. The patients are coming back to me and I am doing surgery and again sending them, they are using treatment.
All right, all right. Wonderful experience. Whatever pathy works, we respect it.
It is out of disgust, sir, not just working. Yeah, that's what. See, it's only knowledge sharing. I am not promoting another homeopathy. Actually, I want to start allergy clinic in my hospital. So I thought we can.
Should we start?
Yes, sir.
I think already Indian Standard Time. Waiting period is there. Right. I'm Dr. Subir Jain from Indore, practicing since 1988 and into allergy practice since more than 20 years now. And just we are together. It will be a practically an interactive session. So at any point of time you feel like, please ask me. I'll be more than happy to answer. Why and how to set up an allergy clinic? This is the condition of a patient suffering from allergic rhinitis. The condition is definitely miserable. You all have seen such kind of patients. Going ahead, allergic rhinitis is clinically defined as a symptomatic disorder of the nose induced by an IgE-mediated inflammation after allergen exposure of the membranes lining the nose. Main symptoms you all are very well aware: sneezing, rhinorrhea, nasal itching, nasal congestion. Eye symptoms are there, ear symptoms are there, post-nasal discharge is there. Won't go into much detail of all this because you all are very well aware of all these things and why we want to set up an allergy clinic. This is the condition which is really miserable one, and because allergic rhinitis is an extremely common disease worldwide affecting 26% of the population. But as we were just discussing, now India is going towards a developed country. Definitely here incidence is much more increasing. And the biggest point is that we all are ENT surgeons. Amongst all kind of allergies, allergic conjunctivitis, allergic rhinitis, allergic dermatitis, and allergic bronchitis. Amongst all these 4 kind of allergies, 50% is allergic rhinitis. So we have got a very big chunk of patients and good amount of scope to work for allergic rhinitis. And it is included in the top 10 causes of chronic disability. The natural course of allergy, when a child is born, we see dermatitis, neonate suffering from dermatitis, finally leading to allergic rhinitis, and till the age of 7 to 8 years or 10 years, that patient, that kid develops allergic asthma. This is the natural course of allergy. This is known as allergic march or atopic march. Because why we want to open an allergy clinic? This is the family suffering from allergic rhinitis, and we all are very well aware that allergy runs in family. It has got a hereditary predisposition. Whenever a patient comes and we ask, anybody from your family suffers, mother, father, brother, sister, yes, then it's a very, very important point, and we must go ahead with allergy testing and help that patient. And why we want to set up an allergy clinic? Because we want all these family members like this. What else we want? We are more than happy to see family like this. The comorbid conditions of allergic rhinitis doesn't exist alone. 35 to 40% they get asthma, 20 to 25% sinusitis, nasal polyposis, miserable condition, patient suffers a lot and a real problem, obstructive sleep apnea, recurrent upper respiratory infection, conjunctivitis, and otitis media with effusion. Remember, a neglected sneeze can lead to a wheeze. Now coming to the drugs for the treatment of allergic rhinitis, because whatever drugs you use starting from cetirizine, as levoisomer, levocetirizine, fexofenadine, belastin, montelukast, whatever, they doesn't have any permanent relief and they don't cure the allergic rhinitis. Amongst the intranasal corticosteroids starting from budesonide days to now, the latest is fluticasone furoate and intranasal antihistaminic, along with the combination of intranasal corticosteroids, whatever you use, absolutely they don't cure. And even the avoidance strategies are there, avoidance measures are there, whatever, it's practically sometimes not possible to avoid an allergen because the allergen particles are so tiny and they are in the air. It becomes very difficult. You see the facts. Average pollen particle is under 50 microns in size, smaller than width of an average human hair. Some pollens can travel 2 to 4 miles. So many times what happens, patient gets sensitivity, allergy to this pollens. We discuss with them, we show them the photograph of the plants and flowers also, and we discuss with them. But practically it is not possible to keep that patient away from exposure to that pollens. Animal dander, about the cat dander allergy, dog dander allergy, so many times when we discuss with the patient is sensitive to dog dander. We ask them, do you have dog? Yes, doctor, we have got dog in our home, but it is since 1 year, 2 year, something like that. It doesn't matter. It may require 2 years to develop that sensitization. And the particles of the dust floating in the sunlight, it includes dead dust mites and their waste products. Whatever you do, this is the condition of the patient who suffers from allergic rhinitis. Really problematic, miserable condition. And we have used everything. We have used avoidance measure first. We have used antihistaminic. We have used anti-leukotrienes. We have used intranasal corticosteroid nasal sprays, antihistaminic nasal spray. But what happens when a patient comes to us? Fexofenadine, belastin, cetirizine, and sometimes what happens, even we feel a little bit uncomfortable in prescribing because patient says, already you prescribed me this drug, because it is not possible for even us to remember that what we have prescribed. And the patient doesn't keep that all record with them. And this is the condition. Enough, doctor. I want relief. And where allergen detection and avoidance is not practical, there comes the role of allergy testing and allergen immunotherapy. Guidelines advocates allergy testing. All European Academy allergic rhinitis and its impact on asthma, ARIA guideline, World Allergy Organization. Everywhere, the final answer for allergy is allergy testing and immunotherapy. And very few ENT specialists are running allergy clinic. That's why we should start allergy clinic. My very humble request, before starting allergy clinic, please acquire knowledge. That's very, very essential. Now, how to set up allergy clinic? The basics: well ventilated room or air conditioned room, refrigerator. Why refrigerator? You have to keep allergen kit, allergens between 2 to 8 degree centigrade. Lancet and measuring scale, table lamp. Why table lamp? I'll come to it. Spirometry, pulmonary function test. As you just saw the slide, if you can recollect, the patients who suffer from allergic rhinitis, out of those patients, 35 to 40% they develop allergic asthma. And so many times when we ask them, do you have asthma? Oh no, it's a social stigma. Then with a very smart approach we ask, do you get breathless when you climb a staircase? Do you get breathless when you walk little fast? Sometimes this, that. So, what I have acquired, what I am practicing, I am keeping spirometry, pulmonary function test and nebulization. We being ENT, so many chest physicians are practicing allergy. They are prescribing lot of nasal sprays. Why not ENT should go to that extent? All right. I don't mean that you start treating COPD or something like that, but at least this basic allergic asthma, pulmonary function test, nebulization, post-nebulization, again pulmonary function test, whether it's an obstruction, whether it's a restriction, and what is the degree, that can be known by doing pulmonary function test. Emergency drugs and oxygen cylinder should be there because you never know. Just sharing one experience. Whenever you are doing allergy test, always do patient in lying position. As initially we were discussing, you learn by experience. This is my experience. A young boy of around 16-18 years, I was doing allergy test and he was constantly staring at the lancet and he started getting fainting attack. What was that? It was vasovagal. Always ask patient to lie down, then do the allergy test. If it's a 5, 6 years, 7 years kid, what I do, I cover the eyes with a mask and give a dairy milk, have it. You go on, take the dairy milk, we will do the allergy test. And trust me, absolutely no issue. I've done allergy test, skin prick test, 5 years, 6 years, 7 years guys and girls, no problem at all. Emergency drugs should be there. We should be safe. Adrenaline, steroids, everything should be there. Record keeping, computer and color printer. Now computer is with each and everybody. You should keep record. Most important, don't do any allergy test without consent. Trust me, at my center, few patients, they went away. Doesn't matter. I don't want. Let's be 100% safe. You explain each and everything. If they are ready, well and good. But don't take any risk. Always should have a written consent of allergy test and immunotherapy. This is the detailed history, most important. Trust me, now as I am into it since years together, what happens? A patient comes to my reception counter. My receptionist asks him or her, what are your problems? What are the complaints? Why you are here? And the patient start telling this sneezing, rhinorrhea, itching, allergic rhinitis symptoms. As soon as the patient says, My receptionist starts a video about awareness. This video is available on YouTube channel. My name Dr. Subir Jain and YouTube channel. Number 1, awareness about allergic rhinitis. Number 2, how to use intranasal corticosteroid nasal spray. Number 3, sublingual immunotherapy. And the moment you can understand, we are doctors, we are consultants. If a receptionist can understand allergic rhinitis symptoms, why not we? The patient comes in front of us, just few lines from him or her, and we conclude, yes. But the detailed history is very, very important. Specific allergy workup objectives: presence or absence of atopy and to confirm causative allergens and the degree of their allergenicity. Total IgE estimation, not compulsory, not mandatory in each and every case. When skin tests are negative and total Ig is lower than 50 Ku per liter, it rules out allergy. And to monitor therapeutic effect of immunotherapy and allergen specific IgE. Going ahead, the diagnostic tests, multitude of tests are available, but at this point of time, all over the world, this is the final answer. Skin prick test. This is the final and the ultimate. Going ahead, the basis of allergy skin testing is to detect the wheal and flare response in the skin from histamine release after allergen bind specific IgE affixed to the cutaneous mast cells. Very important. What do you do by pricking the skin? The cutaneous mast cells are there, and that gives a perfect result. How to go ahead? As soon as the patient enters, can you do allergy test? No. Patient should be without short-acting bronchodilators and beta blockers for 12 hours, long-acting bronchodilators for 24 hours, theophylline for 3 days, chlorpheniramine maleate for 48 hours, cetirizine, fexofenadine, desloratadine, terfenadine, levocetirizine, mesolastin. They say around 4 to 5 days, but trust me, I ask patient minimum 7 days. Let's be safe, because when a patient comes to you, 1 hour to 1.5 hours you have to devote with that patient. He has to spend good amount of money, and after completing the allergy test, after completing the prick, if you feel like that the response is not good, no, it's not fair. You don't do justice with the patient. So it's better to do it after 7 days. If patient is in hurry, what to do? You can have histamine and saline, that is a test dose. If the histamine response is more than 3 to 4 millimeter, you can go ahead. Common allergen groups: food allergens, aero allergens. We are mostly concerned about aero allergens, and what you are seeing, the dust mite, the most common, most notorious allergen. Majority of the patient of nasobronchial allergy, they suffer from dust mite sensitivity allergy, cockroach, animal danders, molds. Now coming to the allergy testing, color-coded vials are there for different allergens: pollen, animal dander, food, histamine, dust mite, fungal molds. Once upon a time, when there was a evolution of, I'm talking about evolution of allergy test, there the 26 gauge needle was used. Then came 3 mm lancet, and now the latest is 1 mm lancet. Absolutely painless procedure. Patients are really, they are concerned, and they are not wrong whether it will be a painful procedure. I tell them, don't worry at all. We will do total test, and it is absolutely painless, and not even a single drop of blood will come out. And it must not come out. Why? If you are pricking so hard, skin will be flare up. That flare response will be there, and that will be false positive. So it should not be there. Volar aspect of the forearm is chosen. Even some people are doing on the back also. If needed, shave or use hair remover on forearm. Clean with alcohol, then air dry the area. Glycerinated allergen extracts of 1:10 concentration used as drop. Hold lancet at 90 degree to skin. Pierce through drop into epidermis. Tenting done. 45 degree, just here to elevate. Dr. Sunita and Dr. Rupali will give the practical demonstration just now. And you have to observe those reactions after 10 to 20 minutes is an average, 15 to 20 minutes. Trust me, I am into it and want to present a paper also, delayed response. So many times the response is delayed. So many times response is quick. And at my center, what I do, I kept a small clock there, just near to the testing area, and my assistant take all pics, 10 minutes, 15 minutes, 20 minutes. And within 15 to 20 minutes, we have to take the reading. This is the skin prick test, allergen drops, histamine saline. A specific distance should be there so that it should not overlap. But sometimes what happens, if few of the response they overlap, doesn't matter, hardly matters. Select those 2, 3, 4 and do next test at other site also. That is going to give you a 100% crystal clear idea which allergen sensitivity is there or not. This is the 1 mm lancet, straight pick into epidermis. Mind it, it should not go deeper down. And the tenting at 45 degrees is done. This is the response, wheel and flare response. This is the measuring scale. You have to measure skin reactions in millimeters. I shared it with you, life is a constant learning process. So many times what happens, a direct light, well illuminated room, you are not able to see the response. Make lights little bit dim, keep a table lamp on the side or your mobile on the side with on light, torch, and you will find the difference. What you were seeing, visualizing from 90 degree, no, it should be from the side and you will find the difference. Another point, I presented one of my paper at World Congress level, that is the feel deep. What happens, it's not just the visualization, you must feel the response. So many times, the response that spreads down and the induration is on the lower side. So you must feel each and every response to make 100% sure that you are doing justice to the patient. This 1+, 2+ is since years together, but no, I am not following that. I am following millimeters. You get the exact idea in my each and every report of allergy testing. It's all millimeters mentioned. And skin reactions more than 50% of histamine are significant for allergen immunotherapy. Not each and every sensitivity is for immunotherapy, and on the top of that, history correlation is must, because whatever you are doing is a sensitivity report. It's not showing 100% that yes, this patient has got allergy with this. See, you can see allergy test report, into brackets sensitivity test. Contraindications when you should not go ahead with skin prick test: acute respiratory infection, uncontrolled asthma, dermographism. Again, I have presented one paper at European Academy about the dermographism. What happens when a patient comes to you? You never know that this patient suffers from dermographism. You complete the test and all response are big. Both the hands are full of wheel and flare response. What to do? Then what I have devised is that feel all response. Whatever is more in millimeters, note it down. For those specific limited allergens, do allergen specific test. Correlate allergen specific, the dermographism result and the history of the patient, and go ahead with the immunotherapy. Absolutely, there is no issue in that. Severe eczema at the site of testing, severe anaphylactic reaction in the past. Yes. Patients of angioedema and anaphylactic shock. I came across a few of the patients. What I do, I take those patients to ICU. There is a hospital in front of my clinic center. I take that patient to ICU. Don't take any risk at your center. No, not at all. Why? Charge extra, have all facilities, instruct nursing staff and the ICU doctor that this is a case of anaphylaxis. Keep every resuscitative measure ready. You never know. Be safe. So in anaphylactic reactions, allergy, because you have to diagnose with what allergens that patient is getting problem. So this is the way you can go ahead. Recent contact with the test or native allergen and the pregnancy. Molecular allergy diagnostics. This is upcoming and everywhere now this is the latest technology. In a single run, 300 allergens. All allergens are covered starting from food to latex. Purity is there, no cross reactions. This is one thing very important. Cross reactivity is not there. And higher specificity, molecular allergens are there and they are purified components. Automated report is there. Coming to the comparison, all SPT, MEDEX, multiplex, RAST and immunocap. Trust me, at this point of time, skin prick test is the final answer. Another slide is also there about this. Skin prick test all over the world. This is final answer. Pulmonary function test, as I shared with you, one should do to confirm diagnosis of bronchial asthma, to know severity and variability, to know response of bronchodilators and steroids, follow-up of disease progress on treatment, to step up or step down treatment. Trust me, I am treating routine asthma patients, allergic asthma patients, inhalers, I prescribe bronchodilators also, everything. When our colleagues are prescribing nasal spray, chest physician, why we not? Acquire knowledge and go ahead. What next after allergy test? Yes, definitely immunotherapy. Different types of immunotherapy are there: subcutaneous, sublingual swallow, sublingual spit, oral, inhalation, nasal. At this point of time, all over world, 2 immunotherapy is in practice. One is SCIT, second is SLIT, subcutaneous immunotherapy and sublingual immunotherapy. 1980, idea of SLIT came, rigorous trials in 1986 and first clinical attempt done in 1998. Sublingual immunotherapy SLIT is recommended in cases especially IgE-mediated allergies where avoidance is not practical. What is rational? GI tract has an abundant mucosal immune system, so-called gut-associated lymphoid tissue, hence an effective antigen can be expected. Sublingual oral immunotherapy uses the principle of oral absorption. Antigens absorbed through lymphatics reaches submandibular lymph channels. Now, what is composition of SLIT? Glycerinated aqueous allergenic extract from various allergens governed by individual sensitivity pattern. Extracts are suspended in extracting fluid containing 50% glycerin, Indian pharmacopoeia according to weight by volume ratio. How allergen immunotherapy works? At the end of the day, you are allergic to anybody, start tolerating him. This is basic principle in our day-to-day life. Everybody is different. So many times, things doesn't suit you. What to do? Start tolerating. And this is the basic principle of immunotherapy, whether it's a sublingual, whether it's a subcutaneous, immune tolerance. Rapid desensitization, early tolerance and sustained tolerance. How to order sublingual immunotherapy? Only arrow allergens, but in last few years, even the immunotherapy against food is also into practice. Select allergens as per reactivity, history correlation, very important. Maximum allergens per set is 2 to 3. Mono allergen preferred, maximum of 2 sets. Maximum quantity 5 ml divided as per reactivity. Initiation with 1 is to 500. Built up 1 is to 250. Maintenance with 1 is to 150. 100. I go then 1 is to 50 and 1 is to 20. Gradually you have to increase the titers, concentrations. Keep immunotherapy order and patient response. This you should have, because what were the allergens you prescribed on the day 1? What was the concentration? How much ml was devoted to particular allergen? On the next visit, because first 3 bottles they come and they last for around 10 months. First bottle 1 month, second bottle 3 months, and the third bottle 6 months. That's around 10 months dose. Then patient has to order the next bottle. You should have that record. How was the concentration you prescribed at initial? Which allergens were given, what percentage, what ml of sensitive that allergens. How to take immunotherapy? First bottle 1 is to 500. First day first 1 drop, then 2 drop, then third day 3 drop, fourth day 4 drops, 5th day 5 drops. Then every day 5 drops till green bottle finishes. That is the number 1 bottle. That is the highest concentration, lowest concentration. That is 1 is to 500. Then comes second bottle, blue 1 is to 250. 5 drops twice a week. Then 5 drops once a week. Third bottle 1 is to 150. Always keep oral vaccines in refrigerator. Always shake bottle before use. Always take vaccines in time. Always take vaccines empty stomach. That's why in the morning hours. Keep drops below tongue for 2 to 3 minutes and then engulf. Do not take any food till 20 minutes. Side effects. Trust me, I'm into this since years together and practically no side effects. What we are giving? I convinced to my patient, immunotherapy is practically not a drug. Whatever is the sensitivity pattern and your history correlation, that is there in increasing titers in glycerin base and saline solution, nothing else. So what medicine? Because so many times patient asks you, what this contains steroids? That's the biggest doubt a patient has and attendant has, whether you are not prescribing steroids. So clear everything. Side effects, practically no. Trust me, if a patient puts more of allergens, this immunotherapy, he gets allergic symptoms, nothing else, nothing else. Contraindications for initiation. Mind this word, initiation, to start immunotherapy. Febrile infection, acute inflammation of respiratory tract, tuberculosis of lungs and eyes, patients on beta blockers, pregnancy, convulsive neoplastic autoimmune disorders, pregnancy. If a patient is on immunotherapy and then she gets pregnancy test positive, absolutely there is no problem at all. She can continue immunotherapy. Need not to stop. Very happy and proud to share my oral presentation. I was the only person, lucky one, to got the chance to present at Istanbul. That is the World Allergy Congress, just October 22. My paper was on result of sublingual immunotherapy in 570 patients of severe persistent allergic rhinitis who were on symptom score 3 and took slit for more than 3 years. You see, wonderful results, very promising results of sublingual immunotherapy. And definitely, once we are into practice, we need to have excellent results. We cannot do practice like that the patient comes, let's see, 20% result, 30% results, recurrence, no. If the results are there, we are successful. And that is the thing what we want. And my dream treatment of allergic rhinitis, primary allergy vaccination before allergy march starts. I'm into R&D. My mind goes on thinking and planning and doing the things. Primary allergy vaccination, mind it. Allergy runs in family. It has got a genetic predisposition. When we can immunize kids against diphtheria, pertussis, and all other diseases, why not allergy? Why a human being should suffer? No, we are here to help them out. And this is my dream. My humble efforts for creating awareness, 29,300 copies distributed free of cost to doctors across India, worth 1 crore 46 lakhs and 50,000. Awarded by India Book of Records. And this handbook of allergic rhinitis, if anybody of you interested, this is my personal mobile number. Please WhatsApp me your total postal address along with the PIN code and everything. I'll courier you to your address. This is another book, Naak Ki Allergy. You can scan this QR code. This is available to everybody. This is in Hindi. This is for patient education. Thanks a lot. My humble efforts transforming knowledge into clinical practice. Thank you so much. Now, we should go ahead with the Dr. Sunita and Dr. Rupali, please.
How frequently you encounter the anaphylactic reaction while doing the allergy testing? Not at all.
In last 20 years, that was a vasovagal, that kid. He was constantly staring this. And then the moment I asked him to lie down on the couch, perfectly all right. Because the amount of allergens that goes in a skin prick test is very minimal, very minimal. But yes, in angioneurotic edema, in anaphylactic shock reactions, be careful. Why to take risk? Why to take chance? Go onto the ICU and do allergy testing over there. My colleagues, Dr. Sunita Shukla from Mumbai, Dr. Rupali from Varud, both are into allergy practice since years together. Both will be going to demonstrate you a skin prick test. And we are just like one family. Anybody has got any query, we are here to solve that query.
So I have one question.
Yeah, please.
My curiosity.
Yeah.
Day to day, obviously, we had exposure to the allergens day and day night. So why we do not develop, you can say, immunity against these allergens rather than with skin prick test or this therapy, we get immunotherapy. But why naturally? Why we do not develop this immunity? Because day to day and night we are taking allergen inside our body.
Every person differs. Every patient differs. We are, if say, for example, 100 persons in this hall, the percentage of persons suffering from allergic rhinitis is 35%. Rest 65 are spared. They develop immunity. So it's not with everybody. In one family, 5 people are there, 5 members are there. One is getting allergic problem. So it totally depends upon the patient's own immune system. And all allergens, they are all viruses, bacteria, they are all there. But everybody doesn't get infection. Everybody doesn't get symptoms of respiratory infection or anything else. It depends totally on the individual immune response.
So
Yeah.
I can also add to your point. If
Yeah.
yeah.
Sunita, please.
So, thank you, Dr. Jain, for starting the ball rolling for this session. So, to answer your doubt, basically, when in the atmosphere, the allergens are in huge amount. So, if you see, if you are on the bed, you have thousands of dust mite entering into your nose and eyes. So, the body does like a surgical strike. So, when you react and you start with the sneezing and all those symptoms, it is a surgical strike. Like if one enemy is entering from the border, the thousands of our soldiers are protecting us. In that scene, lot of histamine is released and other chemical mediators, and you get the reaction. What happens in immunotherapy? We are fooling the T cell system. So we give the immunotherapy, whether it is drops, subcut, whatever, it goes in very minute drops. So it's like sending a spy to the neighboring country, your enemy. The spy will befriend your enemy. He will stay in their house, and at night when everyone is sleeping, he will murder them. So that is what immunotherapy is doing. We fool the T cell system by giving very small doses of the allergens only, and in that process, the body starts making antibodies towards it. It's the same concept of any vaccine, whether it's the OPV vaccine or the BCG vaccine or the corona vaccine which we have taken. But in that process, the good antibodies are made, and that is how we develop tolerance. That's why it should be called as allergen desensitization. The word immunotherapy, people confuse it with lot of cancer treatment and other immunosuppressants and all. So actually it is an allergen desensitization. And that is how you develop tolerance against it. I hope I answered your question. Yeah.
So for the 7 days which you said the person should not take any antihistamine. In that 7 days, if he has acute attack or something like that.
Wonderful. Again, my next paper on this. Sharing with everybody what I do and what I have find excellent thing. For symptomatic relief, routinely, what we do, fluticasone furet nasal spray. 2 spray each nostril once a day. What I am doing, 2 spray each nostril twice a day for those 7 days. Patient doesn't get problem. Pardon? Yeah. With fluticasone furet nasal sprays, you can go ahead with allergy testing. There is no problem at all.
Patient has a lot of nasal block. Nose block. He can use oxymetazole.
100%. No problem at all. And now the combination is available. That is...
Fluticon OX, what is your say on Fluticon OX?
Yeah. Won't take the name of the product. But trust me, trust me, in 2010, in Asia Pacific Congress, in 2018, again Asia Pacific Congress, I presented the paper about using oxymetazolin. In 2010, it was xylometazoline. Now, in 2018, it was oxymetazolin. First use that, wait for 5 to 10 minutes, then use steroid nasal spray. That was my paper, and on the bottom in the future guideline, I wrote, there is a chance that combination of this spray should be of great help to the patients suffering from allergic nasal polyposis, and nasal obstruction is the main symptom. And in October-November 22, Drug Controller General of India gave the permission of this combination, and I was more than happy.
So how many days?
28 days maximum. Should not be used more than that, because that is the lot of trials are there. In my this afternoon session, our allergy session, I'm delivering lecture on that. That will be there.
So can we start with a practical demo? Because
Dr. Sunita and Dr. Rupali, Nitin, please आ जाओ आप help करो. और till the time both are arranging everything and giving, very few slides are there. Practical tips, what to do and what not to do. Please,
So
go
I
ahead.
would suggest we will divide ourselves into 2 groups, because we have 3 allergen kids. Maybe we all three can help you with that. And we will show you how to do the skin prick test on your own arm. That's the best thing. Let us start with histamine and saline, which is a positive control and a negative control. Before putting on the patient, we should know how histamine feels when you do it, because the itchiness which it causes is severe. So we all will be showing you that. Then we have other allergens also. Whosoever wants to go to the next step of trying allergens, that can be also done. So we are open to all suggestions and any opinion on this, or okay.
Only
So
few
we can
slides are
split-
there.
Yeah.
Till the time you prepare everything,
Yeah.
let's interact. Let's utilize time in a better manner. Practical tips in allergy testing and immunotherapy. Does and do. Awareness, video and literature. Very, very important. As I shared in the initial time only, that make patient fully aware about how allergy testing has been done. And yes, another practical point that will become, detailed history. That is very, very important. Explain about allergy test and immunotherapy, mainly results. What patient says, okay doctor, this much amount, this much time, this much treatment, 100%. Honestly, I tell them categorically, absolutely no. It totally depends upon your immune system, your allergy test results. Around world over, 80% results are there. And what I tell them, if you get 80% results, you may get 100%, but at least one thing is guaranteed. No side effects, no adverse effects. You are safe. What you are spending is just only money. And if you are lucky enough to get the full relief, what more you want, and I'll be more than happy to help you out. So this is the way you should go ahead. Written consent, I told you, is must. No anti-allergic medicines, no homeopathy, no Ayurvedic. This is again very important. Sir has just shared about homeopathy. Sometimes what happens, patient comes and says, I have not taken antihistaminic. But yes, I was taking that churn. You never know what it contains. So better to ask, to request them not to take any homeopathy, any Ayurvedic and no antihistaminic. Ask patient not to apply any cream, oil and moisturizer on the upper arm before allergy test. Cloths better should be half sleeves. Check emergency medicine and oxygen cylinder. Allergen kit should be stored in fridge 2 to 8 degree. Shake bottle well before use because they are in suspension form. Patient lying down position and eyes towards other side. He should not see pricks. Prepare forearm away from wrist joint and cubital fossa. Very important. Because what we have learned as the cutaneous mast cells, we test from cutaneous mast cells, and near to the wrist and near to the cubital fossa, cutaneous mast cells are very less. You won't get results. Test dose of histamine and saline in doubtful cases. So many times what happens, a patient says, I came from 200 kilometers, 500 kilometers. I get patients from all over India. And he doesn't remember what medicines I have taken. He doesn't have any record. Doesn't matter. Fine. We do test dose with histamine and saline. Early response and late response. What I just shared with you, that I keep a clock over there. So many times I see, my God, all 127 allergens, no positive response. I just ask my assistant, wait for 15-20 minutes more. Till that time you go ahead with the pulmonary function test. Then again, let me. And yes, in so many patients, late response is there. So be careful about that. Field dip response, I shared it with you. Sometimes that wheel and flare response, that is specifically that induration part that spreads down towards dermis. So once you feel with the tip of the finger and nail, you are able to locate the dimension of that induration. Then side light. That is very, very important. And low light and side light. Does and don't pulmonary function test? Yes, in every patient. Before order for immunotherapy, decide allergens to be selected. History correlation is very important. Then maintain records, follow up, discontinuation of immunotherapy, when to discontinue. Minimum 2 years. One MD medicine, she is into echocardiography and all this thing. She has allergic problem on immunotherapy. After 1 year, around 1 year, doctor not getting that relief. Continue it. Minimum 1 year is there. And with the next visit, she was more than happy. So in few patients, you get response gradually and little bit late. Discontinuation of immunotherapy, minimum 2 years. One must continue for 2 years. In international, 3 to 5 years is recommended for long-term benefit. Always keep yourself updated. Trust me, I gain knowledge even every day. Again, going to Hanover for European Academy. Yes, if you are a member of European Academy, I am member since years together, and excellent academic material in European Academy. Just you have to become member, and all academic material is available online. And if you can attend European Academy Congress, wonderful. I attended and presented my paper with 140 allergens at Helsinki. 8,000 delegates, 8,000. That is the biggest event of the world in allergy. Pardon? Yeah. Yes. All. Skin, pulmonology, ENT. Yes.
हिस्टामिन एंड सी अगर 3 दिन के बाद में भी अगर आपको अच्छा रिएक्शन आ रहा है यू कैन गो अहेड विद द टेस्ट दीज आर प्रैक्टिकल टिप्स व्हाट द बुक सेज इज
Treatment are doing, if the patient get fever or other problems,
देन यू शुड नॉट डू इट
all stop. No, immunotherapy.
सो इट डिपेंड्स व्हाट टाइप ऑफ फीवर इट इज
Suppose typhoid आया है,
नहीं तो बेटर है 1 वीक के लिए
कितनी देर में रिस्पॉन्स करना चाहिए?
ये 15 मिनट हिस्टामिन इज 10 minutes and if there is a response you can go ahead with the allergy test but here why it is Monday so now once a chair happens you put history and see how it is always the swab should be cleaned with normal saline cotton dipped in normal saline so that
after every week because the epithelium goes off. Epithelium goes off because if it is contaminated, his stamina you can do the rest.
आपने नॉर्मल saline नहीं लाया you felt your negative only that much is the so kids and
ये content
so I'm giving you this you can tell them lancet if you don't have a lancet you can do it with a needle also which works very well okay because everyone doesn't have a lancet and maybe by the time the provider gives you lancet you are not going to wait for that it's not practical you can put a mark on the pen but the way it will start itching just write whatever you want next to it wherever was the drop suppose this is the drop you can write H on the
अच्छा.
How long should we wait for them?
For histamine 10 minutes, for other allergens it is 15 to 20 minutes.
And drops
You want to
and the
do it
distance
yourself?
should be
You
at
have a
least
right hand?
1.5
Yes.
centimeters.
So I want your
What is the circle usually we are advising?
At least 1.5
So circle is
most like sensitivity of this. The best is this part, and this part, and then the upper one. Yes, upper back surface. हाँ पहले आप भी yes और एक साल फटाफट कर दीजिए बस आपके लिए इसको राउंड करके नंबर्स
And all the patients who are doing cosmetic surgery, they go for a allergy test. How they response rate reduces like anything.
Just plain allergic we do not have any elements of fungal in response. We can still give it And how soon after fetch do you recommend starting? Like in some cases, post-operative also when the load is a lot. So then
Allergic rhinitis. May I request Dr. Sunita and Dr. Rupali to please come on the stage, and all participants who attended allergy workshop will have a group photo just for a minute, and then Dr. Yogesh and everybody is waiting. They've got a session on cholestoma. Dr. Sunita, Dr. Rupali, please come on the stage, and my colleagues who attended the allergy session, please come here. Please, we'll have a group photo.
Thank you. So now we'll start with the panel discussion on surgery for cholesteatoma. I am Dr. Yogesh Dabolkar. I'll like to invite the panelists for today's session. Dr. Amit Sharma. This is in alphabetical order. Dr. Amit Sharma, Dr. Jeevan Vedi, Dr. Mustafa is still busy with the endoscopic air session. He will join us shortly. I'll invite Dr. Maruti Kalyankar, Dr. Maruti Kalyankar, Dr. Mubarak Khan, Dr. Sachin Nagre, Dr. Sunil Shenge, and Dr. Venkatram Reddy.
Check.
As soon as Dr. Mustafa finishes, he will join us. So now, to start with, I guess all of us have a common love interest, and that is the surgery of the year. We all agree on that?
True, sir.
Everyone loves loving otology, right? Everyone is loving otology. We may have divergent views on some points, but the interest is common. So today's topic is endoscope ho ya microscope, dekho magar pyar se. The Anushka's picture is just for representational purpose, Anushka Bhavi. What we are talking about is to look at the year with love. So here I would like to ask the panelists the instrument of their choice when operating on ear cholesteatoma. So who all are using endoscopes? Can you raise hands for cholesteatoma? And who use microscopes? And who use both? Okay. So we have a mixed group. There are some people who are using exclusively endoscope, some are using exclusively microscope, and some are using both. So whether we should be using only one or two is a matter of preference, choice, and also comfort level. Hmm? Like we have different relationships with the endoscope and microscope. Some of us may be bound by one, but looking at the other with interest. And sometimes we like to use our endoscope, but we also want the microscope to be draped and kept ready. And some of us like to use both endoscope as well as microscope at different points of time. And plus there are new things coming into picture like this augmented reality in ear surgery. So who knows, tomorrow we may not be allowed just one or two, but all three. So now I'd like to ask the panelists the preoperative considerations. When you are looking at the patient, particularly for those who are using both, what will decide whether you want to use a particular tool or you want to use the other one? So I'd like to ask Dr. Amit.
Uh, so basically, I am for microscope because the factors like your age, ear canal, and antecanal hump, these all are can be, better judged and better tackled with a microscope, and we get a very open and wide field to operate upon, and I think that's the way it should be.
Mubarak, Dr. Mubarak.
I only stick to only one thing, endoscope.
Okay.
But you need two hands because everything cannot be done with the endoscope. By holding a single hand, see, my hand is packed with this. So if I need this hand, so you need two hands and the endoscope, and you can manage everything. Believe me, I don't have microscope in my OT. I can manage each and everything with the endoscope. For the pediatric, it is the best one because you can't give those big scars. You need that small scar, excellent healing. For this, the endoscopes are the best for the managing the pediatric cholestatomas or the pediatric whatever. My youngest child is around 5-year-old having that, and you can manage it beautifully. Only the endoscope size matters here. We use a 3 mm endoscope for the pediatric, and you get that nice panoramic view. And I think you should go only for the endoscope, but you need two hands to manage the things. As the flow go on, we will discuss that.
Dr. Jeevan.
On the same, because this is not the debate which microscope or endoscope, what you are using. The basic is the result and your comfort. Surgeon should be very comfortable. As I am in teaching institute, I am basically started with the microscope only because my postgraduate students, they get well versed with the microscope first and then they can change like that. So all these like age, ear canal size, anterior canal hump. So you can tackle all the things what Amit said.
Okay.
So I think it's not a debatable topic, microscope or endoscope.
So when you decide to go for microscope, when do you decide to go for endoscope?
No, basically I am only using the microscope and I am very much comfortable with the microscope. Okay. With ease and both hands are free.
Okay. So, Dr. Sachin?
Sir, I am also using microscope only for cholestatoma surgeries. In regular tympanoplasties, nowadays we are using single-handed endoscope, not two-handed. But as far as cholestatoma is concerned, 100% microscope.
Okay. So, middle ear endoscope and mastoid microscope. That is how you...
I always start with the microscope, but at the end of the procedure, I want to see the nooks and the corners of the middle ear cavity. For example, hypotympanum, sinus cavity. In that case, I use my endoscope, whether I have left some cholestatoma flakes or not. For that, I am using, and that helped me a lot. In many cases, I try to save the canal wall, posterior canal wall.
Okay.
In limited disease, if the canal wall is saved, I can use my endoscope once I finish my most of the work.
Okay, so you initially use the microscope and
Yeah, it is
later on
the
for the
combined.
hidden areas you will use the endoscope. Doctor?
Yeah, I think mine is slightly different. I do both endoscope as well as microscopic ear surgery for all extensive lesions, because I'm basically for endo ear surgery only single hand. I don't use any holder. For single hand, it has some handicaps. So I choose my patients. If there is a ear canal is absolutely narrow, I tend to operate with a microscope. If it's very wide, definitely I go for endoscope. Limited disease, central perforation, limited cholesteatoma, confined to attic, as evidenced clinically as well as imaging wise, definitely I do endoscope. Canal hump, as people say, the microscope is much better. No, I differ, beg to differ. If the canal size is good, definitely the endoscopy has got a very good advantage. But vice versa, people will think. Basically, everybody is a micro ear surgeon to start with, because we have been in the journey for decades, 3 decades. Everybody is basically a micro ear surgeon, but taking advantage of endoscope, you can choose certain cases to operate. Basically, we use 3 mm telescope only. Earlier, we used to do 2.7, but the picture is very small. So, if you have a zoomer, definitely you can 2.7 can be a good tool. But routinely, I use 3 mm. So my choosing will be definitely ear canal size definitely matters, because I do both. And those who are doing exclusive endo ear, that's a different. But if you are, 50% this way, 50% that way, definitely we can choose our own cases. All central CP is basically endoscope. If it's a long-standing ear, dry ear, and no mastoid opening and see, but you can definitely go for CP, definitely go for endoscope. It's a good tool. And you can have a very panoramic view. As little cholesteatoma middle ear, yes, angle telescope can be used at the end of surgery, and there's a huge advantage. You can save, you can actually you can actually retain the normal anatomy. That's very, very advantageous with endoscope.
So this is discussion not only about endoscope or microscope. So other things I would like to ask the panelist. What are their, choice of pre-operative antibiotics, or do they give any pre-operative antibiotics? Yes, Dr. Mar.
Hi, good morning. I think, like all other surgeries, pre-operative antibiotic is a must in my setup, and a dose of antibiotic. If I find some wetness also, I can start 2 or 3 days ago. But if cholesteatoma is active and discharging, then definitely antibiotic is a must. For pre-op antibiotic is a must.
Okay. Pre-operative imaging, Dr. Sunil.
Yes, in most of the cases, I am only doing the X-ray mastoid. But if the patient has some complication like a headache, vertigo, if I am suspecting some intracranial complication or facial palsy, in that case, I am always go for HRCT temporal bone. I am not going for HRCT temporal bone each and every cases because of the financial status of the patients also. But these are my...
Anyone who uses routinely all patients HRCT?
Okay, so I'll be adding on to this. So there are, till 8 months back, I had only 3 criteria for getting an HRCT. So those were an oral polyp, a patient whom I am going to revise for someone. Third is the patient presented to me with some complications. But now coming to a corporate setup and talking about the practical aspect, I would rather get it done for every case of cholesteatoma, because I think that's the way forward. It gives a lot of information. Secondly, you miss on few things when you are not knowing the CT scan. When you know CT scan, you can actually defer few of the issues which you can tackle intraoperatively. Thirdly, you are operating for a surgery. Okay, let's not go into the finances of this, but still you take 2 hours for a surgery. Getting a CT scan of 1,000, 1,500 rupees is minimum you can ask, because that will give you a lot of information. And it also saves you, frankly speaking, in a medico-legal hassle.
Dr. Venkat?
HRCT, even central perforations, we do as a must. Okay. Unless patient says, I don't have money for that. That's the only constraint. Otherwise, we routinely ask for HRCT of the temple bones, irrespective of the disease.
Dr. Sachin, choice of anesthesia for cholesteatoma surgery?
In my setup, we do all these adult patient under local anesthesia.
Okay.
In pediatric patients, revision cases and cases with some complications, we do under general anesthesia. But almost all cases we do under local.
Dr. Jeevan, choice of anesthesia?
Choice of anesthesia in our institute, it is generally a general anesthesia. Because basically, now when good anesthesia is there, why to give any type of pain or some, I think there is a one paper where the surgeons are discussing something about the patient and they are hearing that and after that they complain about. So your ease is that with a good anesthesia you can perform your surgery very well. There is no any, in local anesthesia, I think it is better to go for general anesthesia because cholesteatoma surgery takes time, most of the time.
Dr. Mubarak?
In that case, we always do in the local, we use 0.5% bupivacaine, 50% 5 ml, and mix with the 2% lignocaine with adrenaline. So that combination of both the local gives you more length of action.
Anesthetic is by this side?
Yeah, always.
Then
And
why-
we give the block when the patient
Then
is...
you can give the choice to
One
anesthetist
thing
only.
we can agree is that you have to involve the anesthetist, even in local cases. But so the debate will be whether to use local or general. I'm sure everyone has a choice, and also it sometimes amounts to the economic considerations. We have a varied panelists, and some of them are operating in rural areas, some of them are operating in corporate hospitals. So
No question about rural, no question about corporate. My each and every patient is under general anesthesia. My anesthetist is so best friend of mine, and you need to be, because I need that bloodless field. I do each and every ear case under general anesthesia. He gives a TIVA, that is total intravenous anesthesia, put a laryngeal mask. I carry out my surgery for 4 hours, 5 hours, extensive cholesteatomas and all. Let it be a simple perforation and all. Because it's so fantastic anesthesia they give. 90/60, I need that field. And the pulse is below 80. So that combination, if you maintain, you get a fantastic job, you can do that. Okay?
I agree perfectly with it because this is also what I do. Every case is under general anesthesia.
Dr. Mustafa, would you like to comment on that? Choice of anesthesia for cholesteatoma surgery?
Always general anesthesia. And back in Dubai, we have to do all surgeries under anesthesia, general anesthesia only.
So, Dr. Mustafa, you joined us late and you missed the Bollywood references. I'm sure you would have loved it, but just I'll play back. So, whether we are using endoscope or microscope, our love interest is common, that is ear surgery. And we have to look at the ear with love. And whether we are bound by one instrument or we want to hold one instrument while also keeping the microscope draped, or we want to use both the instrument, is a matter of choice. Your predominant, you are using what instrument?
I usually start with the endoscope. Even for the attic cholesteatoma, I'll start with the endoscope. Only if the disease is going more posteriorly and where I have to open up the mastet, then I'll bring in the microscope and do the cortical mastectomy and complete the disease removal. But I always keep microscope in the surgical room because I'm harvesting the tracheal perichondrium and I like to harvest it under microscope all the time.
And what about the drilling? When you are drilling, do you use the endoscope or microscope?
For the atticotomy, I'm using the curette only. I'm not using any drill, auto drill from the ear canal. Okay. And definitely, if I'm going to open the mastet, then I'm going to use the drill under microscope.
Okay. Dr. Mubarak, you use exclusively endoscope. So I wanted to ask you this: when you are drilling with the endoscope, doesn't the bone dust affect the vision?
Absolutely not. If at all you have developed certain tool, you need to create the instruments in and around that tool. Then and then that technique becomes perfect. Okay. And cholesteatoma needs to be dealt from where it originates. And the endoscopes are the best for that. So inside out should be the rule for the cholesteatoma. Follow the cholesteatoma. Use drill, use whatever curate. You can do everything with the endoscope. Whenever I am drilling, so my two hands are free, and I use an endoscope as an exoscope when I am drilling, and it doesn't affect. I have developed that cover for the drilling bit too, so it doesn't touch the endoscope, it doesn't damage the canal, and even those bone dust is not a matter of choice because the suction is in my left hand. It is taking care of the heat as well as the fogging as well as your dust. So that's why the two hands and the endoscope is the future. Okay.
So often we are faced with cholesteatoma where there is an intact chain. So how do you approach this, Dr. Amit?
Yeah, I'll be discussing this only hearing air with a limited disease and intact chain. So these are very, now in today's time, probably we can catch it up with the CT scan. We will pre-op have some idea about it. We get a pure tone audiogram. So if it is the intact chain and the cholesteatoma is lying lateral to it, then my focus with a microscope would be to take out the cholesteatoma in toto lateral to the chain without disturbing the chain. But again, I said it's a rare instance. Most of the time, the cholesteatoma goes medially. And in those situations, I have to kind of take out the incus, I have to make the space, and I have to go for ossicoplasty on the later stages.
Yes. The other scenario, ear polyp in a 4-year-old child with ear discharge and facial palsy. Dr. Sunil, would you like to come?
If the patient presented with the facial palsy, if the history is acute, depending upon the history whether it is acute or chronic, and I will always explore the patient because I will just removing the polyp and patient has a facial palsy. If the history is of ASOM, then I will just remove the polyp, send the polyp for histopathology, take the swab for culture sensitivity. But if it is a history is a chronic, I will explore the patient.
Dr. Venkat?
Yeah, definitely. The scenario what you have given, 4-year-old child with a polyp and ear discharge, the facial palsy, definitely I will suspect a cholesteatoma in this case.
Okay.
And if cholesteatoma is not there, I will be surprised. What else it could be? Only exploration will tell us. Or the CT can give a clue to our suspicion for the diagnosis.
Dr. Maruti, when you are operating, do you always... so, Dr. Sachin, what are your views on canal wall preservation?
Yeah, so canal wall skin is always preserved. Means while taking incision and while elevating the canal wall, that skin, if disease is more, then many times we remove the skin or otherwise just elevate the skin. And that will cover your cavity and it will help in the healing of the cavity.
Yes, Dr. Mustafa?
You're talking about the canal wall up?
Canal wall, how do you try to preserve the canal wall? Or suppose you are doing a inside-out cholesteatoma case.
So okay, so it depends on the extent of the disease, okay? If the disease is limited only to the attic area and where I can just do a limited atticotomy and remove the disease, then there is no question about whether we have to preserve, because we are going to preserve the canal wall in those particular cases. If the disease is extending far posteriorly into the antrum and the central, like towards the tip of the mastoid, then we are going to open the mastoid from behind. We are going to do the cortical mastectomy. We are going to exenterate all the cells. But I'm always preserving the canal wall unless and until there is a clear-cut indication, like if the canal is eroded because of the extensive cholesteatoma, or if there is any previous cases, like a previous revision case which has been done, or yeah. But in most of the cases, we have to preserve the canal wall.
So you do an intact canal wall?
Intact canal wall.
Yeah. Anyone else wants to?
Here is the role of endoscope. And we must avoid the cavities now. And whatever cavities you create, you should reconstruct it. So here is the role of the endoscope, because you keep the facial ridge completely high, totally opposite to the what we have learned. Try to keep a facial ridge very high, follow the cholestatoma, use the angled endoscope, take out the whole of the cholestatoma en toto, and then reconstruct the canal wall. That should be the norms. Only in those high pneumatized cavities where you land up with the huge cavities, here I create a pseudomastoid, means a small mastoid just lateral to the antrum, and the rest all other is obliterated. So actually you have to create this ventilation, and here is the role of endoscope, and you can do it beautifully with that.
So I'll have a word for intact canal wall. Frankly speaking, there are many areas with intact canal which are not seen. Okay, I agree endoscope can be used in those parts, but still the point remains it's an exposure. Exposure should be well. Your cholesteatoma sac should be exposed all along. We have like a lot of studies which clearly indicates that with intact canal wall, you also counsel the patient for a second setting where the patient will explore again, or you go for a dewated MRIs. So intact canal wall, for that reason, I think is something we should be a little careful when we do. Secondly, counseling with the patient. Third, I would agree to Dr. Mubarak that the best way possible is you go with the disease, even if you have to take down the part of canal wall also, because that can be reconstructed now.
Anyone wants to differ, like who all are doing, regularly canal wall down and...
See, the canal wall down, question of canal wall down and canal wall up is not there. My first aim is to remove the disease completely. Then second aim is to give the functional ear, and third one is to preserve the, prevent the recurrence of the disease. So if the cholesteatoma is limited, then I will try to preserve the posterior canal wall. But if the cholesteatoma is extensive, if it is associated with the posterior canal wall destruction, if patient has associated complication like lateral semicircular canal fistula or a revision surgery, patient has a recurrence, in that cases, I don't try to preserve the canal wall. Because my aim is to remove the disease, I can reconstruct the canal wall, because cavity is a not problem. If you have done a good canal wall down mastoidectomy, good saucerization, round cavity, then you have removed the mastoid tip and make the floor of the external canal at the same level of the mastoid tip. Then you lowered the bridge, facial bridge sufficiently. Then all this, and if you remove the mastoid tip, the most of the muscular periosteal flap will medialize, and that will partially obliterate the cavity. So my first aim is to remove the disease. Because I will always not take the decision beforehand. On table, I will take the decision whether to go for canal wall or canal wall down.
Matrix elevation.
But I think with the intact canal wall also, and if you have a good endoscope, like a 30-degree or 45-degree endoscope, you can reach all corners of the middle ear cavity. So I don't think just to access those inaccessible areas, you need to do the canal wall down and do the complete mastoid. No, I disagree on that part. Only if the canal wall is eroded and completely destructed by the cholesteatoma, then I'll think, okay, I have to do the canal wall down. Even if the canal wall is less than 50% destructed, I'll try to reconstruct it. But if it's more than 50, then there is no point in reconstruction. The patient is going to have a kind of a retraction, and the disease is going to come back.
So I totally agree with them that...
I have one opinion, because it's the decision to do canal wall up or down also depends on your preoperative workup. Because a sclerotic mastoid, a younger age patient, they are more likely to recur. So I keep these preservation patients for limited disease, because I am in a tertiary center. I've seen a lot of recurrences with limited procedures. Okay. So my experience is that the dictum is canal wall down only with extensive disease. In order to preserve canal, actually we ignore a lot of facts, because we are more into cosmetic kind of a procedure, which may not pay in the long run, because the canal wall down years last for 25, 30, 40 years. We haven't seen much of a problem there.
So I'll kind of put a thing onto this. So we see the diseases which are going up to the tip cells also. So, but the canal wall is just a hindrance for a part of it. You don't need to take out the whole of the canal wall. You take out the part of it, get to the areas, remove the disease, even up to the...
Yeah, I would like to ask you, you are preserving canal wall. So what do you do in those cases where there are complications?
So for complications, I would go for with a proper canal wall down with a good metaplasty, because I don't take chances with those cases. But otherwise, so that constitutes 10% of my cases. Rest 90% will have a good canal.
So
Even if it is a canal wall down, I'll reconstruct with a cartilage.
Then do you do a second look, or do you counsel the patient for a second look?
If I'm doing, so I'm taking out the canal wall, I'm taking out the disease, and then I'm putting a this thing, cartilage. So no point.
Okay, you are reconstructing the
Reconstructing, sir. I'm taking the canal wall down, but I am always reconstructing it. Only thing which I'm putting up is, don't take out the ridge so low that you cannot reconstruct it.
Dr. Mustafa, you are talking about intact canal wall. So do you talk to the patient about a second look or a possibility of a second look?
Yeah, I always, whenever I'll counsel the patient, I'll look at the CT scan, I'll explain to him, like, this is the disease, and I'm going to try to remove it completely endoscopically. If I'm not able to do it, I'm going to open him and do the cortical mastectomy. And I'll tell the patient that I might need to go in again after a year to have a second look. So I'll always counsel the patient, always tell them. And if they come back after a year, I look at the ear, and if everything is fine, there is no discharge, the cartilage, everything is healed properly, then I'll just do the CT scan and have a look. In the CT scan, if there is any area of suspicious where I'm feeling that the patient might be having some cholesteatoma, then I might do an MRI just to make sure there is no cholesteatoma, or I might do the second look surgery. And sometimes I don't do the ossicular reconstruction at the primary stage. I'll tell patient that I'm just going to reconstruct, and during the second surgery, I'm going to clear whatever cholesteatoma is there, and then I'm going to reconstruct the ossicular chain as well.
Okay. So the next question is for those who are taking the canal wall down. Do you elevate the matrix in all cases? Because anyway, the cavity is going to be lined with epithelium. So
Yogesh, can I add the earlier
Previous.
discussion?
Okay.
See, in cholesteatomas, in my practice as well as at my ENT institute, because I am attached to my ENT since a long time, our approach to cholesteatoma is slightly different than what the discussion is going on.
Okay.
We try to do for all cholesteatomas, 95% of cholesteatomas, canal wall up procedure only.
Okay.
This, we do an intact bridge mastectomy. We thin out the posterior canal wall into a slight papery thin.
Okay.
That will give, and with a canaloplasty, that will give access to inaccessible areas. And we also use endoscope aided microsurgery for cholesteatoma. So our indications are limited for canal wall down. That is very extensive, as somebody in the panelist said, very much sclerotic, contracted antrum, where you can do atechotomy with a lot of difficulty. Then extensive cholesteatoma extending medial to ossicles. That is one. And then facial palsy is another. And involvement of membranous labyrinth. These are our indications where we do canal wall down procedure, which constitute only 5% of cases of cholesteatoma. 90-95% we do canal wall up procedure. Our results are very, very excellent.
So where you are doing a canal wall down, do you elevate the matrix in all cases?
Yes, we elevate, we define the sac, we elevate it, we remove it, and if the cholesteatoma extensively goes medial to ossicles, then only we can think of canal wall down procedure and obliterate also. We obliterate at the same time.
So everyone agrees that matrix elevation.
See, if you do a canal wall, posterior canal wall papery thin, we take a lot of time. Papery thin, and do a canaloplasty widely, then it will give complete access to the middle ear as well as from the attic side. We define the long process of incus, short process of incus, come down, and we can actually take out all the, separate the mucosal folds as well.
Anterior epitympanum is a little area which is still, you cannot get access to that area. Okay, now coming to the part of the matrix elevation. So I will just say that this is the concept which all of us would agree to, that we need a breathing mucosa below. So if we are doing a cholesteatoma surgery, the point should be we take out the epithelium and we leave behind the mucosa. Now what you do, how you do is up to you. For me, it's a neuroprobe, a fine neuroprobe which I use for elevating only the epithelium. I take the epithelium out of the mastoid bowel also, and I make sure that whatever mucosa I can preserve. That's my aim of raising the epithelium from the bowel or from the aretus area, because I need to have at least 50% of the mucosa in that area which can breathe. If I reconstruct or if I put a cartilage for making it up as soft wall reconstruction.
So in all canal wall up procedure, mucosa should be preserved. Otherwise, where should the gas section take place? What is the use of preserving the canal wall if you are not preserved the mucosa in the mastoid cavity?
Right. So, intraoperative challenges, middle ear adhesions, how do you deal with those? Yes, Dr. Mubarak.
There should not be a problem for removing, because a lot of the starting of the cholesteatoma is with the adhesions only. Okay, it's a retraction pockets, and then grade 1, grade 2, grade 3, grade 4 adhesions. And here again, with the endoscope, you can remove it plane by preserving the mucosa. If at all, while taking out those adhesions, if I land up with the open promontory and there is no mucosa, in such cases, I try to use the PRF sheets. I create a PRF sheets, I use that. Like previously, the people are using the Celastics. So I use that, I cover that bare area.
What is this?
This PRF. Sheets. I create the PRF sheets, that is a PRP from that. It's a platelet rich fibrin. So I create a sheets for that, and then I use for that. And that's fantastic.
To prevent readhesions.
And the patient can afford the gel films are a good alternative. But only thing is it's a costly affair, and PRP is a little, can make it in a hospital. But if patient can afford, I would put up a gel film. I'll put a biofilm. Sorry, biogel.
So, about labyrinthine fistula, what are your views, sir?
Labyrinthine fistula, bone dust, cartilage, and the fascia. It's a must. 3-layer repair is
smaller ones, less than
less than only bone dust and fascia. Yes.
Okay. Doctor.
Somebody can, like, how do you diagnose, like, a patient who is presenting to you, please get a CT scan done for the patient. Patient will tell a history of either a vertigo in the past, and once you
So how do you diagnose?
So yes, sir. So if you have your diagnosis, and then you can go, and only major surgical aspect which I think into this is that labyrinthine fistula should be dealt at the end of the surgery. When you have done rest of the work, then only start raising in that area.
Yeah, that principle is to be followed. That's essential.
And I think for the repair, it depends on the size, how much the fistula is there. If it is a small fistula, I think the just periosteum which we are raising, that periosteum, it seals. Like even though in our cochleostomy we are doing for cochlear implant, so if there is even though perilimb gusher and all, so we put all that periosteum around and it seals properly. And
We use a
bigger one,
perichondrium. If the defect is large, invariably we use the perichondrium. That's the best.
For cholesteatoma invading the stapes suprastructure, anyone wants to add anything? Whether
So, cholesteatoma invading the stapes suprastructure should always be removed. Okay, it's a fine dissection used with a,
will you use the endoscope or a microscope for this?
Sir, I will use only microscope. Only microscope, because I need my 2 hands there in that area to clean that area. I probably need a suction in my hand, a cotton or a gel foam in that area.
Yeah, so you want to stabilize the stapes also when
Sir,
you are doing this?
with one hand, I don't think we should, like, it's kind of difficult.
While taking out this cholesteatoma from the stapes, again the endoscope helps very beautifully. You can find out that plane, and you need those fine peaks, and then plane by plane you can dissect it out.
But then you are recommending two-handed approach.
That's there, but you can do it with even single-handed, but you can beautifully see that plane. With the cholesteatoma, okay, it's going in between the 2 crura and all, you can take it out beautifully. That's all, with the endoscope, yeah.
I think it's possible with one hand as well. So I'm using one hand with a suction elevator kind of thing. We have a very good Penethy suction set with a...
So do you recommend endoscope for it?
I always do all middle ear work with endoscope, no microscope in that. So with endoscope, it's quite possible. And if we have an intact suprastructure with a step ADS, then we can take some like fulcrum extrum of the step ADS and we can do the dissection in that particular plane. And there is a very little risk of like dislocating the suprastructure as well.
I think we have a little bit discussed this. Everyone agreed about decompression. What about investigations? When you are faced with a cholesteatoma with facial palsy?
HRCT is must in these cases.
Okay. Anything else? MRI?
No, yes, we do only HRCT.
I would like to know, sir, your thoughts on MRI, sir. What extra information we'll get in an MRI?
Sometimes, then a concomitant neuromas. In one case of cholesteatoma, we had a neuroma also. So those things can be seen
Pardon?
in the MRI. And in case of cholesteatoma,
Okay.
the MRI gives a good image, the extension of the image. Because the fibrosis, you can confuse, because whatever opacity doesn't mean it's a cholesteatoma, but cholesteatoma can be better reflected in the MRI. You may not diagnose clearly, but...
No, sir, you definitely
no,
can
not
diagnose,
only
sir.
the disease extension, but also the tumors like.
No, cholesteatoma can be very well seen with the MRI. But my point was why in a facial paralysis you would like to? Because I get, in a lot of cases, I get done the diffusion weighted MRI if I have a doubt in a revision case or something. But how it would add to facial paralysis?
No, cholesteatomas we advise. The patient doesn't want to get it done, it's a different. But cholesteatoma, extensive cholesteatoma with a facial palsy, we advise MRI, yes.
So, decompression, okay, decompression.
So, I would like to I would like to know the panelists what's their thought on that.
Dr. Jeevan?
Decompression, it really, because why there is a facial palsy? Because there is a erosion of the fallopian canal by the cholesteatoma, and after that there is a edema around the nerve sheath. So I think decompression means as soon as you will open it, you remove the cholesteatoma and you can see basically the exposed facial or dehiscent facial.
You are removing the cholesteatoma,
Yeah.
but in addition to that, are you drilling?
Yeah, little bit means anterior and posterior to means front and behind. That we go up to the normal facial now. Because what happened, the bone is there, so after removal of the cholesteatoma, it is also covering it, though it is giving the facial palsy. But after that point, there is a edema. So it is better to see and remove it till you get some normal section of the facial now.
Dr. Venkat?
See, the decompression, as a classical decompression, do it, don't do it, all depends on the operative intraoperative findings.
Intraoperative findings.
Suppose you see edema, the satellite edema here and there, I think we have to decompress it as gives us satisfaction. Because some cases, if you remove cholesteatoma, limited disease, slight edema somewhere, they may recover with the steroids. But thing is, if intraoperatively, if there is a suspicion that it is constricted multiple areas, edema points, various points, then we need to decompress full-fledged.
I'll just add to this, sir.
It all depends on intraoperative.
But with the all due
Decision
respect
is
to
intraoperative, what I
doing a
mean.
decompression surgery for a cholesteatoma with facial paralysis, I think now it is a time that we should all decide that it is not a surgery we should plan and we should do. There is a paper from Dr. Alok Thakkar in AIIMS that has clearly shown few relevant findings in that also. So doing a decompression for facial paralysis is something overdoing. That's my thought, and I would actually ask panelists to...
Because most of the facial palsy in cholesteatoma is involvement of the tympanic segment of the facial nerve. So that is already the open, and bony vertical part is need to be decompressed or not, depending upon the finding. If the cholesteatoma is already eroding the tympanic.
Intraoperative finding is the key. To what extent you decompress it. You decompress, don't decompress it, it depends.
So now coming to cholesteatoma in hidden areas, particularly those who are using the endoscope, they will agree that the endoscope is useful for this. But those who are using exclusively microscope, how do you deal with the cholesteatoma in sinus tympani or facial recess?
So earlier what I was doing, I was using a mirror used to have for sinus tympani mirror which was there. But now with 30-degree endoscope, in such scenarios I'll put an endoscope. Of course I'm using a microscope. So my major tool remains a microscope. For about these hidden areas, I would like to have my auto endoscope along with me, and that's a good tool for me.
Okay.
I think with the type A and type B sinus tympani, we'll be able to clear it using an endoscope. But if it's a very deep type C sinus tympani, which is going all the way retrofacial, then even with the 45-degree angle endoscope, it's really difficult in my experience. So what we have to do, we have to do the cortical mastectomy and we have to go retrofacial. To clear that particular area.
So very deep sinus tympani, you may use the microscope with a retrofacial approach.
Yeah.
Okay.
Always, whenever there is a mastoid, microscope will come in.
Yeah. So erosion of lenticular process, coming to the, you have removed the cholesteatoma and now coming to the ossiculoplasty. So Dr. Mustafa, what do you do in such situation where, the rest of the ossicles look normal, only the lenticular process is necrosed?
So if I can use some cement, I'll use the cement to augment the lenticular process and the head of the stapes for that.
Okay.
And if it's not possible for me to put the cement and connect the ossicular chain, then I think if it's a cholesteatoma case, and depending on the extent of the disease, I might need to remove the complete incus as well. Then I'll use the partial ossicular prosthesis to put it on the head of the stapes.
So if you feel that the incus is involved and diseased, then you'll remove the incus.
Yeah.
But otherwise, if it is healthy, then you may use a
I will
bone
just
cement.
leave it. Yeah, cement.
But you will use endoscope or microscope for it?
Endoscope.
Endoscope.
For me, all ossiculoplasties are with the cartilage. I don't use any prosthesis, nothing. For such situations, I just create a small hole cartilage. If it fits over the stapes, and another part comes in contact with the incus, and then I wrap it with this small piece of perichondrium or again a PRF sheets. So let it be I minus, M minus situations, let it be this situation, or there is I minus, S minus, M minus, everywhere I am going to create those prostheses with the cartilage. So for ossiculoplasty, for me, the friend is a cartilage.
So here, in this situation, what do you do?
This one? This is a lenticular process. I create a small cartilage piece.
Okay.
I punch it out. That is fitted over the stapes head. And another part is crafted to fit over the incus.
Okay.
So in this situation, so you get an almost near normal hearing for this patient. So need not to take it out. If incus is gone little bit more, then I take it out and I create just a vertical strut here and I carry out in the type 3.
So,
Yeah.
anyone would like to differ on this, whether, for some reason, they'd like to remove the incus?
So I have again, there might be some reason that the incus is eroded. There might be some issues. So probably most of the reasons it is the disventilations. So these are the reasons. So I would actually see what exactly is the disease. But in most of the situations with this incus, for ventilation, most of the time it would come out, actually. And I wanted to ask Dr. Mustafa regarding what glass. You are using glass ionomers for making it up?
Sorry?
You are using glass ionomers?
I think the same cement which the dentist, the maxillofacial
But
surgeon.
that has got a lot of ototoxicity.
No, some of them, they don't have it. And there is I forgot the brand, there is a special one which we use for the ear as well.
Okay. Dr. Sachin?
I use cartilage only.
Okay.
We don't have access to these glass ionomers and all these things. And almost all ossiculoplasties we do with cartilage. In this case also, as only lenticular process is eroded, we can use cartilage.
Cartilage interposition. Yeah. So what do you do for complete absence of ossicles? Dr. Sachin, you can continue.
So in complete absence of ossicles also, if footplate is there, we use cartilage. And if then it's only hearing air and dead ear. Only hearing air, we had to do something, but we don't use TORP and PORP in cholesteatoma cases. We can have second look after disease-free 6 months at least.
Okay.
I would like to add here, because the cartilage gives us fantastic results with this, almost a airborne gap closure of up to 20 decibel. For all I minus, M minus, S minus situation, I create a umbrella, that's a cartilage umbrella. One piece of cartilage where I make a small hole and then one vertical strut coming through that, so it's like as an umbrella. Fit it. Perfectly it works, and that another part comes in contact with the steppies head, and almost it's like as an cartilage torp. If it is not possible for that, you can go for the boomerang. I modified a boomerang for the cartilage, and it works fantastically, believe me. So whenever the all ossicles are absent, go for the cartilage umbrella or the modified boomerang for the cartilage users.
But what about only hearing ear? Would you reconstruct? Would you not?
Yes, definitely. So you have to give a chance for the, but I completely counsel the patients. I don't guarantee the results for the hearing. For in such situation, I tell him what is the best optimal result. I can tell him, but I don't guarantee.
Dr. Jeevan?
First, just I want to throw some light on that erosion. First question, erosion of the lenticular process of the incus. Now, lenticular process is really the tiny process which is just touching to the head of the stapes. So, in this case, only lenticular process is erosion, and rest of the, you sure that all disease is clear. So, we can use that bone with periosteum, that spine of Henle or something, a very tiny bone with periosteum, to reconstruct that. Then you will see how much the incus is gone. Not only the lenticular process, your question is of the lenticular process only. If it is more, then you can remove the incus. Again, this will be helpful to see the cholesteatoma in attic and all that area, and you can refashion it, and you can put from stapes to the malleus. So this will be the good one. You can using that if the cholesteatoma, because histopathologically also one study was there. So if you drill it out, because we sent that for the histopathology, how the cholesteatoma, whether that incus is reusable or not. So micro invasion by that cholesteatoma pulse is not seen in that cases. So we can use that one. For complete absence of the ossicle, naturally, what Mubarak Khan and Sachin is that boomerang cartilage reconstruction, because TORP is giving some extrusion problem, even though if you cover it with the cartilage and only hearing ear, you should give the chance for the hearing reconstruction.
So you will reconstruct. Yeah.
Okay. Can I say something?
Yeah.
Am I interfering too early? Can I say something?
Yes, sir. Yes, sir.
You know the picture what you showed earlier, just showed that again. So, and Mubarak and everybody said practically the same thing which I am going to repeat. Only thing is when I use a cartilage, I have excess perichondrium. So this perichondrium will drape around the incus. This is what gives a tremendous stability to your cartilage. If you do not do this perichondrium, some people, some junior people, if they, for example, they cannot have a cartilage and the perichondrium in continuity, no problem still. Take a cartilage, piece it there, and put the perichondrium, but the perichondrium should not be too much to go to the floor of the middle. There should not be any adhesions occurring. Adequate perichondrium, and if the incus is thinner, the periosteum is still better to use than the perichondrium. See, but cartilage with the perichondrium is a good solution if the incus is thinner for the longer duration. Now this is a lenticular process, a bit of a long process gone in this situation. But if the thinner, then use the periosteum to drape around it. And you go after 6 months, 9 months, you can see such a beautiful incudus stapedial joint. And we had done it to show it. Right?
Thank you, sir. So post-operative considerations now. Dr. Venkat, antibiotics do you give for how long?
Optimum we give about 3 weeks.
3 weeks.
3 weeks. Yes.
Dr. Amit?
I want to know, like, why would I...
First, you tell me what you are going to do.
So, for a cholesteatoma surgery, sir, we will have intraoperatively we will give IV and 7 days of oral antibiotics. That is like 99% of the situations we do that.
Okay.
But I would like to know 3 weeks.
Anyone wants to differ?
No, they will have some, serious kind of discharge later on, and we have some benefit of doubt, most of the cases.
I think let us, let us agree that we can agree to disagree. Yes, Dr. Sachin?
So you give only for 1 week and stop it.
Huh? Dr. Sachin?
Antibiotics for 7 to 10 days only.
7 to 10 days. Yes, Dr. Sunil?
Yes, most of the patient I use nowadays. I have started using the culture and sensitivity. I usually give culture directed antibiotics for 10 to 14 days.
Yes.
So my antibiotic is till the pack is inside. So my pack comes out on on 14th day. So till that period, I would like to give antibiotic.
So you are keeping a normal pack or a
Ointment.
ointment?
Antibiotic ointment pack.
Any particular ointment or?
Neosporin.
Neosporin, okay. Then
Can I again interfere for a minute? You know what this young man told you about the culture and sensitivity. We ENT surgeon overall have two deficiencies in us. We don't use culture and sensitivity as often as we should be using it, and it's any part of it. I used to go and teach Madhuri Mehta. Her cavity used to heal faster than my cavity. She did a culture for every case of CSF, whether it's a colostoma, whether central perforation, and she gave a specific antibiotic. How cavity, let's say my cavity healed in 3 to 4 weeks, her cavity will heal 2 to 3 weeks. Why? Because she gave a right antibiotic according to culture. So I keep on talking in many conferences, I'm still idiot, I don't do culture regularly still. I do for colostoma more often than the central perforation. But this habit we should learn, and you give a specific antibiotic, the chances of, even take rate, infection is one of the causes of failure of the, let's simple tympanoplasty. Our ossicoplasty doesn't work. Whatever we put as ossicle, if there's infection, then ossicle, there may be adhesion, there may be fibrosis of ossicoplasty is not going to work as well as when there's no infection at all.
No, sir, but the problem is culture sensitivity is where most of the time these patients are on antibiotics or drops. Antibiotic drops. So in most of the time it comes sterile. So that's also another problem. So the futility of culture sensitivity.
Dr. Mustafa?
No, that part I agree with you. When you are central profession, in colostoma, if it's a dry also, please take a culture. If you're not done pre-op for, let's say you want to do emergency situation, there are very few emergency situations where you can do colostoma. In those situations, you still do a culture on the table, you collect it. Dry, of course, there's no question of it.
We are teaching we have a time limitation, so I would like to quickly go. Dr. Mustafa, how long do you advise follow-up and how frequently?
Like, I'll ask the patient to first come after a week of the surgery to remove the sutures, and then 2 weeks after that, like first week and 3 weeks. And after 3 weeks, I'll see, because I'm not putting any pack, I'll just use the gel foam to pack the ear. And I'm not doing the, most cases, I'm doing the canal up surgery, so there is no pack in the cavity. So I'll see the patient after 3 weeks, and if there is any bit of discharge, and if I see that there is a kind of granulation and some edematous flap and the graft, then I'll give them some antibiotic ear drop for a week, and then I'll see them again after that.
And how long should the patient follow up?
So once I'll see them and the graft is completely healed, I'll ask them to come back again after 6 months, and then after a year to see if there is like the patient needs any second look surgery or not.
Dr. Sachin, how do you address cavity problems? If there is a weeping mastoid, mucosal disease you see in the post-operative follow-up period?
Cavity problem, if it is weeping mastoid, then we give good suction clearance and some ointment and drops we give. Cavity takes some time to heal, and eventually, if patient is disease-free, cavity will heal.
Dr. Amit,
as I said, most of my cases, I'm not making a cavity. If I get a patient who has a cavity problems, I would use some acetic acid drops, some suction clearance, and I would actually, after few weeks of that conservative management, I'll try to go for a radiological investigation, because sometimes there is a disease which is lurking there, and you might have to revise these cases. So if there is a patient with a constant cavity problem, I would like to them to evaluate. And most of my experience has come up that they will have some disease, and this is the reason that they were discharging. So you have to revise them.
Dr. Mubarak, you have a lot of publications, so I'll ask you this question. How to measure outcome?
That's a big question. So, number one thing, if at all the cholesteatoma you are talking, what patient needs is a dry ear, number one. If at all you can give a good hearing, that's a second thing. And there should not be a cavity problem. That's my philosophy now. I'm trying to reconstruct it as much as possible, and the endoscopes are helping me for creating a very small cavity and then reconstructing it. So if at all you want to measure the outcome, number one thing is, in cholesteatoma surgery, whether you are giving to give a dry and a safe ear, and another is a hearing, whether we can give the hearing. And with that, ossiculoplasty is also in a one single setting. In Indian settings, there is no second look and all, so you have to try to do your best in first only.
First.
Because whenever the patient is coming to me, वो बोलता है सब अभी भी कर दो बाद में कुछ मत. So we try to do everything.
Our
Still
patients
I
can't
tell the
afford
patient,
second surgery.
yeah. So still I tell the patient, because for the cholesteatoma, definitely even the revision rate for me is still a 1 to 2%. Huh? So I try to convince कि भाई आ बाद में आ वापस you have to come. So outcome measurement is dry and safe and hearing, and that can be done in a single setting. Yeah.
Dr. Venkat, causes of recidivism?
Yeah, I think cholesteatoma needs a lifetime follow-up, because we have seen recurrences even after 15 years, 10 years also. They need lifetime, they have to come to us
I'm sorry,
at least
sir.
once in a year, twice in a year.
I personally don't agree
Or
that we have to
sometimes-
keep a cholesteatoma patient for lifelong follow-up. If you have done a good job, you will know, sir, and ultimately within
We
6
are,
months or a year it will come.
Just a minute.
We got-
we will
see,
not engage in
we got recurrences
discussions.
even after
I'll
12
just
years,
ask one question
15
because
years.
we are
What does it
we
mean?
have a time limitation.
If you have a recurrence after a decade, a recurrence,
yeah.
what does it mean? Patient has to come for lifetime follow-up, at least once in a year, later on once in 2 years or 3 years or so.
We have to reduce this time of follow-up. At least we can do that.
That reduce the follow-up.
So that brings us to the surgical ergonomics, whether to use single-handed, two-handed. I'm sure Mubarak will say two-handed.
Obviously, दो हाथ चाहिए. कुछ भी करने के लिए दो हाथ चाहिए. ना? So endoscope के साथ अगर दो
Don't give us a dirty ideas. Don't give us dirty
इस्तेमाल किया
ideas.
तो कोई सवाल ही
कुछ
नहीं
भी
है.
करने के लिए क्या ये scientific program है?
So that's the end of that's the end of our panel.
On a lighter note, देखो मगर प्यार से ऐसा टाइटल था. अगर सिर्फ आपको देखना है प्यार से तो माइक्रोस्कोप. अगर आपको देख के प्यार भी करना है, जिंदगी भर निभाना है, सब करना है तो ओनली एंडोस्कोप.
I'll just add to that. अगर खोल के बहुत अच्छे से एक्सपोजर के साथ करना है तो माइक्रोस्कोप.
Let's have
At
a
the
group
end of the
photo.
day, you have to give the result. Open, do the explore it.
I think we don't have time enough for questions because the next session is there. We'll just have a group photo quick. The rest of the questions can be.
Thank you, our panelists, for such an informative and very informative and interactive discussion about the cholesteatoma and cholesteatoma surgery, whether to use endoscope or microscope. I would like to invite our chairperson, Dr. Masood Hassan, sir, to kindly felicitate our panelist.
Just a minute.
Yeah.
Thanks to all audience.
Very nice slides.
I invite you all to my September course where the Daniel Marshoni is there, Professor Gadre is there, and it's the first time single versus two-handed. endoscopic ear surgery. So do visit to the Talegaon, that's in Pune, okay?
Acha, now they want to hand over the mementos.
So I would like to invite Dr. Mustafa Kapadia, first of all. Dr. Venkatram Reddy. Dr. Sunil. किसी में है, किसी में नहीं है. Dr. Raman. Dr. Jeevan. Dr. Maruti. Dr. Mubarak Khan. Dr. Sachin. Dr. Amit Sharma. I would. I would like to invite Dr. Yogesh, our moderator, to felicitate our chairperson.
मुझे नहीं मिला तो मैं ये ले लूँगा.
Dr. Sonali and Dr. Arjun Das.
इसमें है एक्चुअली. भाविका मेरा लैपटॉप लिया ना.
किस? Dr. Sanjay. अरे Yes, sir. Our chairperson. Sir, जो
chairpersons. हाँ इसमें कर तो दिया है शायद. हाँ एक मिनट. Just don't start the times. कौन सा वीडियो? नहीं ऑडियो. Okay. So good morning everyone, respected chairpersons and respected delegates. So thanks Aoicon Jaipur for giving me opportunity to present my work in front of you. I'll be speaking on pediatric airway foreign bodies, tip, tricks and challenges. So quantum of problem is very high, almost 2.5% mortality with this problem in a large retrospective study conducted at US. It is a one of the commonest difficult situation, and bronchus is the most commonest site for lodgement of the airway foreign bodies. So it requires patience, precision, partnership, and planning. So it has having three, everybody knows that its initial phase of choking, followed by asymptomatic phase because of relaxation of reflexes, and third is the stage of complications. So this is the scenario which I have faced recently. During, what happens exactly during airway foreign bodies? This patient was brought during lockdown. No staff, nothing. So they were searching for me. I am having a nursing home. You can see that baby is choked, and within 1 or 2 seconds I came down in my OPD. There was no time to take the patient in the casualty or my ICU, and I took out the foreign body. So everything good, everything, and I removed this foreign body instantly, within 1 second, and I could save the child. Even the parents did not know what I did. So we could save that child, but this doesn't happen with airway foreign body every time. So this is basically a CCTV footage which I took just to understand the quantum of problem, what exactly happens when patient is brought in your hospital of airway foreign body. So everybody knows the eye see what the mind knows. So you need to suspect. Because X-ray may be normal in these cases, airway foreign body, and they always present. If you are having a strong clinical history, go inside and check it. This is the rule in airway foreign bodies. And you have to decide benefits versus drawback. And the main issue is it's a childhood problem, and most of the time this baby is roaming here and there, and parents did not witness the foreign body. And you should, as a bronchoscopist, you should do more and more negative bronchoscopies, because you should suspect, go inside, check in, and check whether foreign body is inside. So why babies are prone for airway foreign body? Everybody knows, because they want to explore the new world. But why? Why one should start doing bronchoscopy? Why everybody should do airway foreign body? So this is a 11-month-old infant. I did almost only 1 month prior. X-ray was more or less normal. We took the child, and I went inside with my rigid stores ventilating bronchoscope. I could see the foreign body. 11-month infant. A foreign body in right main bronchus. It took me hardly 1.5 minutes to take out this foreign body. Not more than 1.5 minutes. So everything was good. So baby was discharged next day morning, and we could save the child. But it doesn't happen every time. After 7 days, we received this child, but patient was brought dead, because he could not reach. This is what happens in. So if at the initial presentation, if the hospital where he reaches first, if that person could have done bronchoscopy, we could have saved this child. So this child landed up with forensic department, and you can see the foreign body lodging in the subglottis. So this is what happened. This is after 7 days. This is same age, same sex, same foreign body. But the earlier the patient, we could save the child, and in this case, we could not save the child. You can see the foreign body. This is a postmortem picture of the child, where foreign body is seen in the subglottic, and we could not save the child. So I appeal everybody to start airway foreign bodies, and this requires a proper roadmap and proper planning. Your discussion with the team, which involves anesthetist and pediatric intensivist. And what I do, because I'll be discussing on tips and tricks, what I do, if I suspect that patient is foreign body is maybe in the subglottis, and we may need to go for tracheostomy sometimes, because I had 5 cases in my series where I did tracheostomy, and in 3 cases we removed foreign body transtracheal. So I infiltrate preoperatively only with 2% xylocaine and adrenaline. So this is our conventional bronchoscopy set, which I started in 2011. My first bronchoscopy I did in private setup only. So because the main issue is we don't get proper exposure during our residency. This is my first child. And these are few cases which were done. The middle one is presented with surgical emphysema, again 11-month-old child. And we could remove the foreign body with conventional bronchoscopy. So this is another patient. You can see a subglottic coconut. So it was too big to come transglottic, so we did tracheostomy and removed it. This is an epileptic child, and removed it transtracheally. This is 2 more cases of transtracheal removal. One is jamun seed, and another one is almond. So those who are doing conventional bronchoscopy. This is a very good trick. You can convert a conventional bronchoscope into a conventional non-ventilating scope into a ventilating scope. Just put a adequate size tracheostomy tube on the top of it and ventilate the child. So you can reduce the number of insertions, which is directly proportional to the morbidity and mortality of the child. This is how we did it till 2016. Then we introduced a flexible scope. So flexible scope, again, it is a boon for us. We can go inside the 3.5 millimeter endotracheal tube, and we can see whether foreign body is there. This video is not playing. So from 2016 onwards, almost we had airway foreign bodies. I am talking more than 400 cases we had done airway foreign bodies. Flexible and other bronchoscopies are doing very routinely. So from 2016, I am doing with my Storz ventilating scope. So the advantage of Storz ventilating scope is we have precision, a very good vision, less morbidity, and ventilation. Main is ventilation. So you can avoid or reduce the actual number of insertions. So this is a very simple procedure. So you can see this is my first foreign body. I can do like this. This is my first case with ventilating bronchoscope. I had seen on YouTube only because previous to that, because we are used to endoscopy. So I am just inserting the scope. I'll be inserting the optical forceps and removing the foreign body. So this is a very simple procedure. Now this is another case of 11-month-old infant. So on this case, what I want to emphasize is you have to go for chexoscopy in each and every. So this you can see the baby with respiratory distress. We went inside. I could see 2 foreign bodies. You can see 2 foreign bodies, and we retrieved the foreign bodies. Then we did chexoscopy. So on chexoscopy, there was 1 more foreign body. So you can see. So this is the importance of checks. After removing airway foreign body, don't say that I had done my optimum work. Just go again inside and check for any other foreign body. So this is the crux and most important thing. Another thing, 4-year-old child with Rajma seed. What I did in this case, because this was a very big foreign body. So I did infiltration also, neck infiltration also. And what actually I did, because this Rajma seed that got swollen and it was not coming out transglottic. So we actually crushed the foreign body inside. So this is this has been done with the help of ventilating bronchoscopes. We could actually crush the foreign body and remove it in pieces. So this took some time, but we could retrieve the foreign body. And this Rajma said 4 years ago. Another case of, you can see a hazy lung, 10-month infant. We received the child from mainly 10 months to 15 months, maximum age group. That's what we received. And smallest one which I did with ventilator is almost 6-month age. So 10-month infant with sudden respiratory distress, SPT was around 40%. Emergency scope. So patient was intubated by a pediatrician called, and this is the beauty of flexible scopy. Now I am in ICU only, I am doing flexible bronchoscopy. Patient is on ventilator, and I could see that foreign body was there. This is a post-op X-ray, you can see. In the left main bronchus. So there was no forceps space at all. So we could manipulate the foreign body inside. Don't try to grasp the foreign body in the first. You have to properly take a grip of foreign body, airway foreign body. This is the most important thing. As a beginner, what we do when we see the foreign body, we try to catch it and remove it. Don't remove it in first go. Try to have a proper grasp, So when I do bronchoscopy, I play with the foreign body inside the trachea and bronchus, and when I make sure myself that I had proper grip of that foreign body, then only I try to take out. So this is the most important trick and thing that needs to be. So this is then simply it was removed. This was again custard apple seed. Now this is again was one of my most difficult cases, 11-month-old infant with worsening respiratory distress. You can see a retrocardiac shadow over there. So there was a consolidation on left side and little bit hyperinflation on left side. And you can see a compensated lung on other side. So this was this picture on the extreme right. You can see I had turned the head of the child on right. So when you are going in the left bronchus, you just turn the head on the left side. So this was a coconut piece. Now I am going inside with my ventilating scopes. So you can record the things. This is one more important thing there. You can record the thing, you can present your data, and you can inspire others to go for this procedure. So this is how but there was, because it was a very old foreign body, lot of granulations were there. So what we did, there is a other channel is there, injection cannula. So what I do, you can see I am sucking out the secretions. I am going beyond the foreign body with 6 millimeter infant feeding tube. I am going inside, sucking all the secretions, and after that I got a good vision. And sometimes we put adrenaline patty or xylocaine adrenaline patty inside the bronchus, and so now you can see the foreign body. So foreign body was visible, and we could remove. Then this was a simple game. So we could remove the foreign body. Again, this is very, very interesting case of 9-month-old infant with retained foreign body since 3 months. So at the age of 6 months, that baby inhaled the foreign body at the age of 6 months. And so you can see I did a flexible scopy because we are not sure of the diagnosis. So when you are not sure of the diagnosis, go for flexible scopy because this procedure can be done in sedation only. It is very simple procedure because in all the cases we take consent of on-table death. If we are going, so you can see a plaque-like thing in subglottics. So this is actually a foreign body. So in CT also everything was normal, nothing. There was little bit subglottic narrowing. That's what they were saying. We did. Then we went inside with a forceps. We had a tactile touch, and surprised to feel there was something hard and that dislodged when I touched with my optical forceps. So this is basically a peanut forceps. Earlier I was having only peanut forceps. Now I am having all the plethora of variety of forceps which stores are making. So now you can see the dislodgement of the foreign body, and then I am trying to remove the foreign body. So it was a big piece of plastic, and that was there for almost, so in this case what I did, that foreign body was not coming. So for just buying some time, I pushed the foreign body inside the trachea, ventilated the child with my ventilating scope, and then I could, you can say, manipulate the foreign body inside the trachea. Now you can see that piece. So now I got a proper grasp. Now I am removing. So I am removing it from trachea. I pushed the foreign body early. I did not try to remove the foreign body because lot of granulations were there, and this was the foreign body. This was a big piece of foreign body in 9-month-old infant, which was, and when we elicited the history, it was 3 months prior. He or she had a history of choking. Now again, check scoping. So foreign body, both bronchus, which is a nightmare for any bronchoscopist. So you just go in one bronchus, then check for other bronchus and remove the foreign body. So I'll just present my last case of foreign body, both bronchus. 3-year-old child with sudden respiratory distress, choking spell while eating peanut at around 7 p.m. There was gross reduction in air entry. You can see this is a classical X-ray. Hyperinflated lung on left side, pulse rate was, and baby was brought in with saturation of 64. So this is a pre-op video of child respiratory distress. So we intubated the child because child was hardly maintaining the saturation. So through that, I can see the foreign body in the left lower lobe bronchus. We could remove the foreign body with our optical forceps. Okay, then this is the removal video. Then again, we intubated the child. Again, we intubated the child, did flexible scopy. So in flexible scopy, again, we could see one more foreign body, and that was torn on left side. You can see one more foreign body. So this is the importance of check scopy, and from left bronchus also it was removed. So this is how we did. It was almost 1 hour 45 minutes of struggle for removal of that foreign body, and you can understand as an ENT surgeon, foreign body both bronchus, what does it mean? So we had almost 5 cases of foreign body both bronchus in our series. So these are few instructional courses which I had conducted in Vidarbh ENT conference, Gondia, in national level IOHNS conference, where I educate and do bronchoscopy training on my own model, on goat model, and on my papaya model, which is developed by me. And this is the training in Maharashtra ENT conference. So thank you. And I'll be shortly announcing a Gondia bronchoscopy hands-on course only for 5 delegates. So that will be a full day course. So I'll be announcing the dates shortly. So it will be held at Gondia. Complete, you will be having, not live surgery you may have, because I get many cases of airway foreign body. If we get on that day, we will have live surgical session also for those 5, those 5 registered delegates. So thank you. Thanks.
Thank you, Dr. Bhagat, for such an informative lecture.
Now I would like to invite Dr. Rakesh for the session, Insight into Tubeless Ventilation.
They will be presenting an insight into tubeless ventilation, Thrive in upper airway surgeries. Thrive is a transnasal humidified rapid insufflation ventilatory exchange, a novel non-invasive oxygen technique. The recent introduction of apneic oxygenation technique has been reliable method for maintaining oxygenation during short airway procedures, and one such excellent procedure is Thrive. This delivers warm and humidified oxygen at a high flow rate and maintains the CPAP and ventilation of the carbon dioxide. Thrive has revolutionized our practice and showed an improved patient safety in difficulty airway cases when there is a chance of desaturation. The benefits of Thrive are non-invasive nature, ease of administration, provides an uninterrupted surgical field, and prolonged safe apneic window, and low risk of barotrauma when compared to conventional jet ventilation, and prevents endotracheal trauma. In this, our main objective was to know the operative time, total anesthesia time, and safety of Thrive in upper airway surgeries, and to compare the safety and efficacy of usage of Thrive on different upper airway surgeries, and also the surgeon's satisfaction. All patients who are undergoing laryngeal surgeries with tubeless ventilation were included in the study, and surgeon satisfaction was also noted. Methodology is just standardized anesthesia technique was followed for all the patient. Patient received glycopyrrolate and midazolam 0.02 mg per kg as per pre-anesthetic medications. Injection with propofol 2 mg per kg was given, and the patient was maintained with total intravenous anesthesia using propofol and dexmedetomidine. Adequate analgesia was obtained by fentanyl, and this specified Thrive equipment delivered a high flow nasal oxygen from 10 to 60 liters per minute, and FiO2 was maintained at 1. And this was the proforma we recorded. Age, sex, BMI, and ASA class was recorded, and the type of surgery, operating time, and the mean SpO2 before surgery, induction, during surgery, post-op, and any complications were noted. In our results, we had 32 cases, of which 18 were microlaryngeal excision, and 6 were direct laryngoscopy and biopsy, 4 were tracheostomy, and balloon dilatation for subglottic stenosis for 4 cases. These were the, in balloon dilatation, we have done for 4 cases, 3 female and 1 female. And this case is for biopsy. The main advantage of Thrive is we can maintain the oxygenation without any intubation, so that there is a lot of space and instrumentation is very easy. And chance of desaturation is very less. We can assess the tumor and take easily biopsy. And throughout the procedure, there is a high flow of oxygen through Thrive. This is a case of larynx. We have taken a biopsy without intubation. Next is a case of subglottic stenosis. Here we can see a membranous stenosis in the subglottic region. We are cutting the membrane with coablation. This is the main advantage. There is no endotracheal tube, nothing, and there is a lot of space for instrumentation. With coablation, we are cutting the membrane. Then we are introducing the balloon, and we are doing dilatation. Throughout the procedure, there was no desaturation. This is the next case, where there is a small vocal cord polyp. We have done the excision without intubation and without desaturation of the patient. And this is also for biopsy. There was a big growth in the subglottis, and we were able to take it out. This is the next case for vocal cord polyp. And in our case, most of the microlaryngeal excision, the age was 33 years, direct laryngoscopy biopsy was 51, and tracheostomy was for 63 years, and balloon dilatation, average age was 23 years. That main ASA physical stress is important. In microlaryngeal surgery, class 1 was 11 cases, class 2 was 7. In direct laryngoscopy and tracheostomy, they were in class 3 and class 4 because their old age had a lot of comorbidities, and balloon dilation, most of the patients were in class 1. This is important as we should categorize the risk for Thrive. And this is what that operating time for most of the cases were between 20 to 30 minutes, and the total anesthesia time was 30 to 40 minutes. And most of the condition in pre-op SpO2, induction phase, and during the surgery, there was no desaturation. Most of the patients were above 95%, and end-tidal carbon dioxide was also normal. And post-op SpO2 was also normal. Desaturation was defined as SpO2 of less than 90%. No patient in our case series had desaturation episodes during the surgery. No complications were noted. Surgeon satisfaction was between 8 to 10 score, and post-operatively patients were comfortable. Thrive allows apneic oxygenation. High flow nasal oxygen is dependent on physical phenomena of aventilatory mass flow. This is the physiology how we can use apneic ventilation. Aventilatory mass flow is a physiological phenomena in which, provided that a patent air passage exists between the lungs and the exterior, the difference between the alveolar rates of the oxygen removal and the carbon dioxide excretion generates a negative pressure gradient of up to 20 centimeter of water that drives the oxygen into the lungs. This clinical application is known as, in modern anesthesia, as apneic oxygenation. Apneic oxygenation has to be used experimentally. Usually it was in pre-induction phase. Now we are using during surgeries also. And it reduces the pharyngeal dead space, increased fraction of oxygen and carbon dioxide in alveoli, reduction of airway resistance and work of breathing, and improvement in lung compliance. And this is the other studies. Rakesh et al. Had shown 16 cases of upper airway surgery, and there was no episodes of desaturation, and apneic time was for 35 minutes. And Yang et al. Has shown 23 cases for microlaryngeal surgery. The mean operation time was for 12 to 16 minutes, and total anesthesia time was up to 30 minutes. And one case was demonstrated by Lasit et al. For supraglottic growth for tracheostomy. And several studies have demonstrated that Thrive allows enough time for short procedures with reported apnea time ranging from 18 to 65 minutes. This has extended the application of Thrive beyond simple use for pre-oxygenation. The Thrive cannot completely or secure the airway. It is always mandatory in OT setup. We have to get ready for emergency tracheostomy, and anesthetist should be ready with ventilating bronchoscope or CMAC for intubation if there is desaturation. Thrive was appropriate safety precautions can be tried in most of the patient undergoing microlaryngeal surgery, and absence of endotracheal tube gives a better view of pathology with uninterrupted surgical field. All patients in the study maintained carbon dioxide PCO2 was normal and tidal volume was also normal. The initial results use of Thrive as per our study and other study definitely encourage both in adult and pediatric age group. Thank you.
Thank you, Dr. Rakesh.
I would like to invite Dr. Kamrul Hassan. Is he in the hall? Dr. Krishnamurthy. Dr. Kamrul Hassan, Dr. Krishnamurthy. I would like to invite our chairperson to felicitate our speakers, Dr. Tipti ma'am, Dr. Rakesh, Dr. Sanjay, I would request Dr. Sanjay to please felicitate our chairperson. Thank you, everyone. This end of the day session. We'll meet after the lunch break. A very good afternoon, everyone. Welcomes you all to Aoicon 2023. We'll start the session. I would like to invite chairperson to come on the dais and have a seat. Dr. Vikram Khanna, sir. Dr. Vikram Khanna. Dr. Madhupriya. Please, ma'am. Now I'd like to invite our first speaker, Dr. Subir Jain. Dr. Subir Jain.
Welcome, Dr. Subir.
Good afternoon, everybody. It is immense pleasure and great privilege to be here at Aoicon 23 at Jaipur. In this allergic rhinitis session, we have got 4 speakers, and we are going to cover different aspects so that there should not be any repetition of the subject. Going ahead, latest in the management of allergic rhinitis. We all are very well aware about signs, symptoms, and everything about allergic rhinitis. What you are seeing in this slide is latest. Definitely, I am going to talk about latest in the management of allergic rhinitis. This is the condition of a patient suffering from allergic rhinitis. We all are very well aware about all the symptomatology and everything about allergic rhinitis. Going ahead, what are the routine drugs we are using in our day-to-day practice? Since years together, we have started from CPM, now to Bilastine. At this point of time, Bilastine is the latest molecule available all over the world. Going ahead, qualities, those positive points, those advantages of Bilastine I'm going to discuss here and talk about it. A modern second-generation H1 antihistaminic has the highest number of desired properties, 10, for a modern antihistamine according to international ARIA guidelines. Pharmacology of Bilastine, mechanism of action, selective inhibition of peripheral H1 receptor, highly selective for the H1 receptor, rapidly absorbed after oral administration. At this point of time, would like to tell you one thing, very important, that the Bilastine should be taken empty stomach. The advantage of taking Bilastine empty stomach, it gets practically 100% absorbed. Don't worry, if a patient has taken something and he has taken after the food, the 30% absorption is reduced. Onset of action is 30 to 60 minutes, half-life is 10 to 12 hours, bioavailability is 61%, and that's a once-a-day daily dosing, that is 26 hours duration of action. Does not undergo any hepatic metabolism and excreted mainly in the feces. Cardiac safety, renal safety, CNS safety. That's one of the safest molecule at this point of time all over the world. Going ahead, lowest occupancy of brain H1 receptors, no driving impairment, no CNS depressant, safe flying, no alcohol effects on central nervous system. Coming to the most important point, Bilastine antihistaminic activity. 3 times higher than cetirizine, point to be noted, and 6 times higher than fexofenadine. At this point of time, all over the world, cetirizine and fexofenadine are major molecule to be used, and they are using. But trust me, In 2015, I was at Seoul World Allergy Congress, and 2015, the Bilastine was already there. And I think in European countries, Bilastine is in use in day-to-day practice. Going ahead, pediatric age group. For symptomatic treatment of allergic rhinoconjunctivitis and urticaria, Bilastine is really useful. Bilastine is indicated in children aged 6 to 11 years with a body weight of at least 20 kg. 10 mg of Bilastine once daily in the treatment of allergic rhinoconjunctivitis and urticaria in pediatric population. My new product addition of Bilastine adult. That's something very important. At this point of time, Bilastine is available 20 mg, Bilastine 40 mg, Bilastine 20 mg with Montelukast. But the new product addition is with decongestant, that is phenylephrine, Bilastine with phenylephrine and paracetamol. We all come across the patients, if patient is suffering from only allergic rhinitis, then it's okay. But if it's a common cold, congestion is there, headache is there, pain in the throat is there, there we want to add paracetamol also. And then the sixth one highlighted is the Bilastine 10 mg, phenylephrine 10, dextromethorphan, antitussive also. So this is just my new product addition of Bilastine in adult group. Coming to the pediatric one, already this 1 and 2 is available in the market. We all know that in pediatric age group, it's very difficult to convince a child to have the medicines. Mother is always behind a child with a spoon and the bottle, and the child is roaming around and around and around. That's a real tough job. So why not to combine Bilastine with phenylephrine and paracetamol? Mind it, paracetamol is 250 mg. Why? It's indicated at this point of time from 6 to 11 years. And paracetamol dose will be 250. And then with antitussive. Going ahead, intranasal treatment of allergic rhinitis. You all are aware and you all are using this. Won't go into details of this. The latest developments which are there is the bioadhesive and IRRS technology. Bioadhesive in intranasal corticosteroid nasal sprays. No drip technology uses FDA-approved bioadhesive polymer which helps to penetrate mucin layer, securing the drop on mucin layer, which in turn increases retention time of the drug. What is the advantage? If a drug is retained more at the nasal mucous membrane, better absorption, more effective. IRRS technology, that is intuitive repriming-free robotic system. That is the blockage-free, non-return valve at the orifice, maintenance-free locked adapter, repriming-free sealed air pathway, and the compliance. Won't believe what I used to do. I used to open each and every nasal spray and used to see. Most of the bottles contains pipe, but this 360-degree doesn't contain any pipe. That's the bottle which you can tilt up to 360-degree and you can do the spray till the last drop. That's really something very good. My research papers on combination nasal spray, I presented at 2010 Singapore, Asia Pacific Congress of Allergy, Asthma and Clinical Immunology, and 2018 Bangkok. That is the combination of a decongestant and a steroid. And to my pleasant surprise, in 2022, Drug Controller General of India gave the permission of this fluticasone furet 27.5 microgram and oxymetazoline 50 microgram. I was so happy that yes, now this combination is available and patients are really benefited. The decongestants had immediate effect on the nasal obstruction improvement that were faster than intranasal corticosteroid effects. We all are very well aware and we use this combination. And what is the advantages of adding intranasal steroid to oxymetazoline? Increasing the action of oxymetazoline, corticosteroids influence alpha adrenoreceptor availability, thus increasing the action of oxymetazoline. No tachyphylaxis. Fluticasone reverses the oxymetazoline-induced tachyphylaxis of response and rebound congestion. Reduced rebound congestion. Intranasal corticosteroid ameliorate the development of rebound congestion when used concomitantly with topical nasal decongestant sprays. So many persons, so many people, so many my colleagues have got a doubt of why. Can you use oxymetazoline for such a long time? Yes, definitely you can see at the bottom lots of studies has been done. Lots of research papers has been presented. And yes, there is a distinct advantage. And the reduced dose of decongestant. Routinely what we use, oxymetazoline, xylometazoline twice a day. But here, only once a day is enough. Now the advantages of adding oxymetazoline to intranasal steroid. Other way around, both are beneficial. That is a symbiotic effect of oxymetazoline and intranasal corticosteroid for each other. And at the end of the day, these are the beneficial for the patient. Oxymetazoline reduces the edema of the nasal mucosa, facilitating the excess of steroids, thereby ensuring better and faster action. Enhanced nasal capacity by decongestant allows greater penetration of intranasal corticosteroid. In this combination, bioadhesive should be added, will be of more help to the patient. Better efficacy of steroids and the significant on most nasal symptoms of allergic rhinitis beyond the relief of nasal congestion and faster of action versus intranasal corticosteroid alone. So definitely this combination is fantastic and gives ultimate result. You can imagine, you all are ENT surgeons and you are into the practice. The patients who present with the nasal polyposis or the late phase of allergy where there is a main problem is nasal obstruction. Patient is not able to breathe properly. The whole night he is sleepless nights rather. Opening mouth, drying of the tongue, drying of the oral cavity, and the life is miserable. And there, if nasal passage is open, what else a patient wants? And that's why the fixed dose combination of fluticasone furoate 27.5 microgram and oxymetazoline 50 microgram hydrochloride nasal spray is superior to individual one. And the dose is so simple, just once a day in the night, so that a patient will have a pleasant sleep. But that's really miserable condition. We tried everything. You tried Bilastin, you tried intranasal corticosteroid, you tried intranasal antihistaminic. Everything has been tried, but the condition remains the same. So what? What next? Oh my God. He is saying, enough, doctor, enough of the drugs you have tried. Sometimes you're given fexofenadine, now you're giving Bilastin. Enough, please, please. Now, what to do? Yes, we have got the solution. Where allergen detection and avoidance is not practical, there comes the role of allergy testing and allergen immunotherapy. Established guidelines on allergy testing and allergen immunotherapy all over the world. European Academy, American College, everywhere, World Allergy Organization, everywhere allergy testing and immunotherapy is the final answer at this point of time. Going ahead, most important is the detailed history of the patient. Diagnostic tests, multitude of tests are available. So many tests are there, but the final answer is only a skin prick test. Patient should be without short-acting bronchodilators. It's not like that the patient enters your cabin, your chamber, and yes, come, we'll do the allergy testing. And really sorry to say at this point of time, allergy testing should be done under a clinician guidance only. That is the best way. And patient should be away from all these medications minimum 7 days. Latest device, 1 mm, skin prick test methods. Volar aspect of the forearm is used, and if needed, shave or use the hair remover, clean with alcohol, then air dry the area. 1:10 concentration of allergen extracts are used. Hold lancet at the 90 degree and just tilt it at the 45 degree and tenting is done. And after 10 to 20 minutes or 15 to 20 minutes, the wheal and flare response are observed. You can see this is the prick test, measuring scale, and skin reactions more than 50% of histamine are significant for allergen immunotherapy. This is the sensitivity pattern. This is not directly, you cannot say like that yes, this is the allergy test report. No, this is sensitivity report. Molecular allergy, this is coming up and all over the world. You can see this is the latest technology, the single run 300 allergens. Allergens starting from food to latex, everything has been done. Coming to the other points of molecular allergy diagnostics, that is a purity, no cross-reactivity is there, and automated report. With all these advantages and points in favor of molecular allergy diagnostics, still the skin prick test is the gold standard world over. That should be done before prescribing, before going for immunotherapy. What next after allergy test? Dr. Sarika? Dr. Sarika, yes, be ready. She is going to tell detail about immunotherapy. Yes, latest in the treatment of immunotherapy, I'm not going to cover because we had all the discussions and that one speaker is going to cover only one things. But just going ahead, this is the sublingual immunotherapy, mechanism of allergy, immune tolerance, single word. And very happy and proud to share that at Istanbul World Allergy Congress, I have presented a paper on sublingual immunotherapy. About 570 patients of severe persistent allergic rhinitis are treated and wonderful results, absolutely marvelous results, and patient was cured. I was more than happy. And conclusion, Dr. Sarika is going to cover all these things. Upcoming modalities, treatment modalities of allergic rhinitis, allergoids, tablets, drops, and injections. In these products, the structure of the allergens is modified using chemical treatment, example given with formaldehyde. The prostate allergens or allergoids are still recognized by the immune system, especially the T cells, but binding to allergen-specific IgE antibodies is strongly reduced. As a result, time ho gaya? ठीक है, fine. We'll go hardly 2-3 slides or more. Allergoid immunotherapy is the allergy vaccine with a carbamylated monomeric allergoid available in tablets, drops, and injections. It features an exclusive allergen modification that reduces the allergenicity, contrasting the risk of side effects. Intranasal immunotherapy is available in the world. DNA-based vaccines, biologicals, Dr. Sunita is going to cover, and intralymphatic immunotherapy. These are all super specialty things. It's still under research and development and will come soon. But my dream, ray of hope, is the primary allergy vaccination before allergy march starts. That is from atopic dermatitis to rhinitis to allergic asthma. My humble efforts of creating awareness, 29,300 copies distributed free of cost to doctors across India, worth 1,46 lakhs and 50,000. And that has been recognized and awarded by India Book of Records. My mobile number is there. If anybody wants to have the copy of this book, please WhatsApp me your total address with the PIN code and mobile number. I will forward this copy.
Thank you, Dr. Subir Jain. We have just time for one question if anybody has. There is a panel discussion tomorrow morning at 9 o'clock where Dr. Subir and the other speakers will be there. So I request everyone in the audience who's interested in the field of allergy and immunology to please join us tomorrow at 9 o'clock. Any questions?
Which kit you are using? Which allergy testing kit?
Which means
Skin prick testing kit.
I've used all Cure Pharma, and then another one, Evexia. I used all. And
what is important is that the kit that you use for testing, the same manufacturer should provide you the immunotherapy
correct
vials. So, thank you, Dr. Subir. Please give him the memento. So just wait for a minute. Last May, okay, I will do it at the last. I now invite Dr. Sarika Verma, a multi-dynamic personality, not only in ENT, but also IMA, sports, and in politics. And she is going to speak on immunotherapy, which is the only treatment modality which can alter the course of the disease on a permanent basis. Over to you, Sarika.
Thank you. Good afternoon, everyone. It's a pleasure to be here. And my family has a joke. They say you studied ENT for 8 years, 2 post-graduations, 3 years of senior residency. You spent 1 week on allergies and you're doing most of your work in this. So I feel it's your destiny. And sometimes certain fields just call to you. And allergy is my passion. I've been working on allergies for the last 20 years. I'm delighted to see many of my friends and teachers. And I hope all of you take back something from here. So there are just two things. If you have not been doing allergy testing, first and foremost, you cannot do immunotherapy on the basis of a blood test. That is the first rule of immunotherapy. Second, before you start doing skin prick testing, please do a certified course. It is recommended and it is mandated by law that you have to be a certified specialist before you attempt it, because your patients are not guinea pigs. I'm saying this to you because I practice in North India and I see even today patients, doctors who are giving immunotherapy on the basis of a blood test. There is no legal leg to stand on. Blood tests are only about 50 to 60% accurate. You cannot do it without. So these are the two. If you can take just 2 steps back from you, I'll be happy. So immunotherapy is nothing new. It was 110 years back that Leonard Newman gave his first inoculation to himself for symptoms of hay fever. He died early and his work was continued by Sir John Freeman. The WHO position paper is that allergy testing and immunotherapy are the only two ways. Allergen avoidance and immunotherapy are the only two ways to treat allergic disease. Everything else is symptomatic. So you give immunotherapy, you give pharmacotherapy, all of that is perfect. That is what you have to do as a ENT. But if you want to treat allergy, you find out, first step is identification, which you do by the help of a skin prick test. Tell them to avoid it. And only when avoidance doesn't work, you start immunotherapy, and you will see it's very rewarding. So there are various kinds of allergies: rhinitis, bronchitis, rashes, food, drugs, and contact allergies. We are going to specifically be talking about allergic rhinitis, which all of you know is excessive sneezing, watery nose, nasal blockage, nasal itching, which may or may not be associated with conjunctivitis. Areas classified allergic rhinitis into intermittent and persistent based on whether it is less than 4 weeks in a year or more than 4 days a week and more than 4 weeks in a year. And both are further classified into mild, moderate, and severe, depending on whether the sleep is hampered, whether their work is disturbed, whether they have to take leave from school or work. So these are the ways that when you see a patient, when the patient comes to you with sneezing, you automatically know this is allergic rhinitis. But in your prescription, start writing intermittent allergic rhinitis, persistent allergic rhinitis, mild, moderate, or severe. So this helps you decide what is the course of action, when are you going to do pharmacotherapy, when are you going to tell this patient to get an allergy test done. Because sometimes I have patients who come to me one episode of urticaria or rash, and they say, Doctor Saab, allergy test kar do. So we just tell them, no, you don't have to do it. So there are indications when you do the test, and you must not try to do a short-term gain. One allergy patient has done, let's do allergy test. That's not how it works. We are here for the long haul. I've been doing it for 20 years. All of us practice for about an average of 40 to 45 years. I mean, I always believe that we have to do ethical practice, and what you will not do to your family member, do not do to your patient. And the indications for immunotherapy in allergic rhinitis is that mild and intermittent do not need immunotherapy or allergy testing. So you'd give it in intermittent patients who have severe symptoms, moderate or severe, and all patients of persistent allergic rhinitis, whether mild, moderate, or severe, need immunotherapy. Asthma, bronchitis, hyperreactive airway disease. Asthma, the indication is intermittent, you do not need it. And mild persistent and moderate persistent, you need allergy testing and immunotherapy. Again, in severe persistent, patients who are persistently on bronchodilators, who are unstable, whose FEV1 is less than 60%, do not do allergy testing. You may get into trouble. I've always seen and I've learned from my seniors that it's more important that you pick your patients wisely. It's more important to do certain surgeries than not do them and land in complications. Same thing for allergy testing and immunotherapy. Choose your patients well, be more selective. And the more severe the patient's disease, the better their results will be, and the more grateful they will be to you. So chronic rhinosinusitis, nasal polyps, I'll be speaking a little more in detail. Food allergic rhinitis, food allergies, 9 foods are responsible for 90% of the food allergies. And immunotherapy is available, but it is experimental. It is not FDA approved. So I have patients who have given food allergic immunotherapy, but I've given them to writing it's not FDA approved, it's only experimental. If you tell them, then it's fine. Allergic cough, I have a series of hyperreactive airway disease children who we do immunotherapy only for dust mites, and I've had beautiful results. Allergic conjunctivitis, angioedema, I'm seeing more of this, and a lot of atopy. So allergic diseases are huge. It's very surprising to me that, otosclerosis and angioedema and CSF leaks are less than 0.1% of the patients that we see in our daily practice. But we have large orations for them. And allergic rhinitis affects 20 to 30% of the Indian population. And all of us as ENTs see a lot of allergies, but we are kept in a small room, like a side specialty. I hope one day we will be giving orations in the big room for this. So allergic treatment, Dr. Subir has spoken very nicely about it, and I will be speaking to you the part that where immunotherapy is to be added. So early detection is important, allergy testing is very important, and it enables correct and optimal treatment. The various kinds of testing, I'm not going to it, but only single slide. Allergy testing by skin prick method is safe, quick, reliable, painless, repeatable, visible to the patient, economical, and happens within 45 minutes. You can give them the report. So it's very, very nice to do. So WHO recommends that it is the gold standard for allergy testing. These are the aeroallergens, dust mites, pollen, cockroach, animal, and molds. 50% of your patients will have dust mite allergy, whether they are intermittent symptoms or they are persistent symptoms. So give your dust mites utmost importance when you're doing your skin prick test. Sometimes if I get a negative and I think that it may be, so I do a repeat test because dust mites are very, very important. And 20 to 25% are pollen. Then molds. Molds especially are important for AFRS. And insects and animal lander, we try avoidance. We usually don't give them immunotherapy. So this is just for the people who want to start doing allergy testing. This is what I test for: 3 dust mites, 10 fungi, 25 kinds of pollen. I just brought this list because many of you asked me, so I've just written it down. These are the kinds of dust, insects, and animal epithelium. And we test for about 55 kinds of foods. So SPT, as Dr. Subir has already mentioned, I'll not be talking about it. This is the outcome. Once you do a SPT, what do you do with that? First and foremost is allergen avoidance. Medical management remains the mainstay of treatment, and for the patients who need it, oral and subcutaneous immunotherapy. Environmental control is very important for dust mites to instruct each and every patient. There's a certain set of, all of this is available online, nothing new. But you have to tell them to start doing it, and you'll find that there's a significant result in this. Environmental control, especially for pets, tell them not to let the pet be in their bedroom at all. And if they have to be in the drawing room, then the pet should not be sitting on the sofa, and try not to have carpets in the house. Early avoidance is very, very important. Space study, it says that just by using impermeable mattresses, they reduce the sensitization rate by 4% in babies. And this is a very important study of 205 children who were given immunotherapy, and their asthma at the age of 7 years reduced by 50%. So very, very important. We have to stop the allergic march, and that depends on you and me. So allergen immunotherapy is the administration of gradually increasing quantities of allergen vaccine to the subject so that they get exposed and they do not have symptoms. This is the pathophysiology. The main thing is that the allergen immunotherapy acts on reducing the IgE production. It produces blocker antibodies. It reduces the Th2 cells, so that overall, the early phase and the late phase, both the allergy symptoms get controlled. In the initial phase, you will find that the IgE increases and then falls later on. And in the late phase, many patients will ask you, should we get a skin prick done afterwards? Most of the time, I tell them, don't waste your money. If your symptoms are better, the skin prick test doesn't matter. So if the patient is not symptomatic, anyway, we are not going to do immunotherapy. So, but I have certain patients who say after 3 years, we want to get a skin prick done. And then you find that they are negative for all the things that we have tested for and treated them for. And there's a delayed phase skin prick testing reactivity. Initially, Ig will increase and then it will fall. Initially, IgG increases and later on falls. But IgE and Ig, the total Ig counts. Many of you have seen, people come to me with serial Ig. This year, my Ig was 800. This year, my Ig was 1200. This year, my Ig was 2000. It doesn't matter. We have seen Ig up to 40,000, 50,000. It's a good indicator for the patient to find you. But you don't have to do serial IGs. It doesn't help you in the treatment. It doesn't help you in the prognosis. So Ig, like I said, it doesn't make any difference, even if it is high. And sometimes we have seen persistent allergic rhinitis patients with normal Ig, even 34 Ig, but they're extremely symptomatic. And when you do the test, it is strongly positive. So my thesis was on the correlation of skin prick testing, total Ig, eosinophil count, etc. And you find the serum Ig is not really a great indicator. So I'm saying it's a good place for the patient to find it and get alarmed and come to you. But you as a specialist do not have to be relying on IgE alone. So I'll speak to you about the indications for immunotherapy. Of course, it should be IgE-mediated disease. It should be a skin prick test positive. Sensitization should be relevant for the symptoms. Suppose the patient has only symptoms that happen maybe once in February, and throughout the year is fine. And if they are not positive for the pollens which are there in February and March, like holoptia, and we find that certain patients are very, very specific. So the patient's symptoms must correlate with your skin prick test. We are not treating the skin prick test. We are not treating the blood test. Patients come to me with skin, we did a blood test, so many things are positive. If they do not have symptoms, they do not need treatment. That is the bottom line, right? Symptoms should be of sufficient and severe duration. Like I said, if they have 3 weeks of sneezing, you don't give them allergy test or immunotherapy. You must have access to good extracts. Patient should be compliant. The patient should not think that, no, if you think that the patient is not going to do a treatment, don't give them immunotherapy, because you are putting a lot of effort and energy. You explain to them, you follow up with them every 3 months, you call them up and say, okay, how are you feeling? In my clinic for the last 20 years, I have the record of every allergy test patient I have done. And I make a note of, this was the better thing, these are the things that did not suit them, these are the patients that needed a step-down treatment. So each patient takes a lot of effort from you. And if you feel the patient is frivolous, don't waste your time, just give them pharmacotherapy. And this is a very important practical point, the refrigeration should be available at the patients. And so many patients, there are poor patients or certain patients who are like in the border states where I have patients from CISF who do not have access to a refrigerator. So what you can do is oral immunotherapy is actually quite hardy. And I've started giving only for these patients, maybe 1 bottle. Say 3 months, when they finish it, they get the next bottle. So that still lasts. Instead of taking the whole year's course, we try to do that and try to help them as much as possible. Indian position paper is the same, nothing, you have to have severe disease. And general contraindication for both slit and skit are that any serious disease, any life-threatening disease, you cannot have, I once was in the OT, I saw a lady, a 70-year-old lady, 80-year-old lady who was getting bilateral TKR. And she had a big thyroid mass, large, and which turned out to be a malignancy. So, that's what you should not be doing. If the patient is really sick, don't try to treat them for allergies. How many minutes more? How many minutes more? 2 minutes more? Okay. Okay, pregnancy does not need just one word. We do not start immunotherapy in pregnancy, but you can give it when the patient gets pregnant later on, you can comfortably continue. Only skit and slit are available in India, the others are not available. Be careful about cross-reactivity. I know some doctors tend to mix things, but in oral immunotherapy, you cannot mix pollen or mites or epithelia or molds. You have to give a single. And in subcutaneous immunotherapy, you can mix up to a maximum of 5 things. That includes dust mite and pollen. Fungus cannot be mixed with anything else because they are proteolytic. So subcutaneous immunotherapy, twice a week injection. The first dose should be given by you with all the paraphernalia. You have to keep everything ready, emergency kit and tray. And maintenance is once a month. I don't ask my patients to come to me because patients come from very far away. I tell them to go to a local GP, get their injection, stay in the clinic for 30 minutes, and then they can go back. So most of the patients don't have a problem. 2015, this is a standard schedule is what I follow. I'm just going to go very quickly. All of these are there, but fortunately, by God's grace, I have not had to have any adverse effects. Oral immunotherapy is very safe. It was given FDA approval in 2015. After that, we've been doing it. Intensive phase is 1 year. You have to give a build-up, twice a week drops. First time, I just tell them how to do it. They have to put it in the fridge and take it by themselves. Tell the patient not to take it by themselves. Tell somebody in the family to give it to you, like a maid or a staff, any family member, because by themselves, they tend to over-medicate, and your medicine finishes fast. So now, if they have to do it, if they live alone, then I tell them they have to look in the mirror and see how many drops are going in. Maintenance is 2 years. Usually, 3 years, of course, is more than enough. Some patients need a prolonged therapy. It's very, very safe. Immunotherapy, there are no deaths that happen. It's much safer than other things. And what do we expect? Good efficiency over symptomatic, early onset of efficiency. Within a few weeks, you start seeing results. Sustained and increased efficiency, long-term efficacy. Prevention of newer sensitization is very, very important. Otherwise, the patient you've done an allergy test 7 years back, I'm just finishing, last 2 slides. A patient you've done an allergy test 7, 8 years back, you find that they were allergic to 4 or 5 things, and they come back, they have not taken treatment, then they go in for polysensitization where they are allergic to like 10 or 12 things. The lesser the number of allergens, the better is the result in immunotherapy. The more they're allergic, it's more difficult to treat them. So definitely it reduces the need, the asthma progression reduces the need of medication, and it's definitely more cost effective. These days with the fexofenadine and bilastine costing about 12 to 15 rupees a day. So, and the nasal spray costing between 400 and 600, in a month the patient is spending 1,000 to 1,500 rupees on pharmacotherapy. So if you take immunotherapy and the patient starts settling down, it's definitely more cost effective. Both of them reduce, a comparison between medication is, it reduces medicines, has an increased effect, disease modifying effect, prevents sensitization. So in CRS, I'm just not going to talk about it. I have a series of nasal polyps that have worked very well. It reduces the rate of recurrence. So I've been doing allergy testing for 20 years, and I find it very, very rewarding. And there is more than 90% of my patients had improvement in their sneezing. 88% of the patients of recurrent nasal polyps did not need recurrent surgery, the third surgery that is. Hyperreactive airway disease, all the children are off the nebulizer, which I think is a very big thing for me. Urticaria and isolated urticaria, do not do immunotherapy as a first step, do allergy testing, tell them to avoid the food that works better. So my takeaway points are these, that allergy is treatable. Please don't tell your patients you have to live with it. Thank you very much.
Thank you, Dr. Sarika.
Thank you, Dr. Sarika, for such an informative talk. And we appreciate your experience in allergy, and it definitely helps to improve the quality of life in the patients. House is open for any questions.
All questions will be answered by Dr. Sarika over lunch. Okay? Yeah.
Okay.
So, I am allergic to mobile phones ringing during an academic session, and my only therapy is I'll take away the mobile. So please put it on silent. And whoever answers the mobile should whisper, not talk loudly like you. Our next speaker is Dr. Gayatri Pandit from Bangalore, and her topic is allergy management in chronic rhinosinusitis.
Okay. Good afternoon, everybody. I'm happy to see the hall full, at least, if it is in a smaller hall too. At the outset, I would like to thank organizing committee for giving me this opportunity to speak. I'll be speaking on role of allergy in chronic rhinosinusitis. Allergic rhinitis is something that you have gone through many a times, right? So I just want to begin with this case scenario. This Mr. XYZ, aged 32 years, presented with a history of undergoing sinus surgery 1.5 years before, and was apparently well for 8 months. And past 6 months, he has been having nasal blockage, post-nasal drip, hyposmia, all these things. And I do a nasal endoscopy at clinic and find this, that the polyps are recurring back, and you see a thick secretions. I'm sure that you will be able to relate this to many of your case, isn't it? You would have done a fantastic job per operatively. But what is that we are not doing? What is that we are not evaluating, that these patients are coming back to us with these things? So let me just quickly run over through the role of allergy in chronic rhinosinusitis. If you take a chronic rhinosinusitis as a whole, the contribution of allergy to CRS development to a severity therapeutic response was not totally understood. So the first meta-analysis which was done by Wilson was inconclusive. Some of the papers that he found was favoring allergy, some of the papers were not favoring allergy. But then the recent article which we see in a EPOS 2020 guidelines by Marcus, that recent meta-analysis showed a more strong association in particular phenotypes of nasal, sinonasal polyposis or CRS with polyp varieties. So perennial allergens were found to be more important than seasonal allergens when it comes to CRS with nasal polyps. So if you go through all the articles which are available for association of allergy and CRS, you see that there are many more in the recent articles which support association of allergy. And you will see that this support is more for CRS with nasal polyps. So the CRS without nasal polyp, you don't have a much association with allergy. So to broadly classify, we have two different phenotypes here. This is a very broad phenotype where you have one with a polyp and one without polyp. Without polyp will present more of a facial pain and a postnasal drip, whereas with polyp would present more as an hyposmia, anosmia and a nasal blockage. You have a eosinophilic predominance, you have a Th2 inflammation, you have an intense edematous trauma, and their response to steroid is very good when it comes to polyp variety. Whereas CRS without polyp variety is more of a Th1 driven inflammation, more of a neutrophilic. I wouldn't say that it is completely neutrophilic. It is a neutrophilic predominant inflammation, and these are the cases which responds to macrolides. I wouldn't say that it is totally not associated with asthma. The less association of asthma when compared to with the polyp variety. So these are the kind of an inflammatory mediators that we have, like Ig, IL4, because this is where we are targeting our therapies also when we are treating on the long run too. If we have to further know your CRS with polyp is whether strongly having a Th2 inflammation or not, this is what you can gain from the histories or from the patient's previous record. If we had a comorbid asthma or a late onset asthma, former surgery where you have an histopathology report with eosinophilia, NSAID exacerbated disease, blood eosinophilia elevated, total Ig elevated, this is actually for a foreign scenario, but our patients will have on an average have a 300 to 400 Ig in a routine checkup too. Specific Ig positivity either by SPT or by specific Ig blood test. So if your patients have these two, this means that your patient definitely have a strong indicator of Th2 inflammations, and these are the patients who will definitely require allergy evaluations. The EPOS 2020 guidelines is slightly different, or it tried to give a little more of broader phenotypes. It basically divides it into a primary CRS and a secondary CRS. Secondary CRS is where you have all the either immunodeficiency disorders or a ciliary motility disorders or a odontogenic, whereas primary you have again the thing that which I spoke about, type 1 and a type 2, and in type 2 it can be either a localized or a diffused. So if we summarize, we have 3 different varieties which actually specifically belongs to allergic variety. One is a AFRS, then you have a CRS with nasal polyps which is eosinophilic, need not be Ig positive, AFRS, and again CCAD, that is central compartment atopic disease. So what are the investigations that we generally do when you suspect an allergic evaluation? And you see that quite often total Ig and AEC is what the patient themselves come to you with. As Dr. Sarika rightly said, they are the specific indicator for them to look in for you. But they may not be, they are not a very specific test to tell that this patient has sensitized to certain allergy, but a very high total Ig. So for example, in an AFRS, we will find a Ig level usually above 1000. So they are also used as a prognostic indicator sometimes when you are treating AFRS patients, and they might also help you to identify certain patients who are good for a biological treatment. AEC again does not either tells you that it is allergic or cannot exclude allergy also, but high AEC, especially in an ARD patients and all, can be a poor prognosticator sometimes to your this thing. So what we more look into is a skin prick allergy test and the tissue biopsy, the knowledge that you can get from that particular patients. So is it that every polyp patient requires allergy? A patient of a CRS with polyp who have a concomitant history of allergic rhinitis, whose symptoms basically began as I used to have 10 years before as in runny nose, sneezing, and then later now I have an anosmia, hyposmia or a blockage. So whose symptoms actually began as an allergic rhinitis, central compartment atopic disease, we'll just speak about it in one slide more. AFRS patients definitely yes, because this is one of the diagnostic criteria also for you to tell that it is AFRS, CRS with asthma. So any CRS with asthma, it is worthwhile doing allergy test. And CRS patients who have a family history of allergy, any form of allergy, let it be atopic dermatitis or asthma or allergic rhinitis, any family history of allergy, these are the patients of your sinusitis patients who will definitely require allergic rhinitis. In AFRS patients, these are the fungi which are found to be of a culprit. So we could include these particular allergens while testing for AFRS patients. So what is the central compartment atopic disease? So this is a new mention in a EPOS 2020 guidelines where you see the inflammations more centrally. You don't have much of a pathology in a frontal or a sphenoid, especially at the tip of the middle turbinate or the anterior part of the middle turbinate is where you see a polypoidal changes. You may not see as a frank polyp throughout, but these are the areas where you see because that is a first point of an aeroallergen contact. And this kind of an picture in your CT scan or in your endoscopy picture are the one which has a high association of allergy, and these patients 90% of the time they do show sensitivity in our skin prick allergy test. A small note on aspirin exacerbated respiratory disease, which presents as a triad of nasal polyps, asthma, and NSAID intolerance. Why I have put it here is it's a pseudo-allergy. It's not actually an allergic disorder, but appears like. It is a non-IG mediated. It is not a type 1 hypersensitivity of the NSAIDs, but here patient has a deficiency of this enzyme, and that's why there is an increased surge of a leukotrienes, because of which the patient is having a lot of symptoms. One more typical feature of an AERD is it is an adult onset disease, it is an adult onset asthma, and they are not a very good responders for medicines, and they are intensely eosinophilic. Like how your other polyp patients would respond to your intranasal corticosteroids, these patients don't respond, and that itself should give you a high index of a suspicion that whether this patient has an AERD. Asthma requires definitely a special mention in CRS. Approximately 20% of CRS patients have asthma, and conversely, 2/3 of asthma patients have sinus inflammation. So I often tell that chronic rhinosinusitis with polyp is nothing but a small piece of your asthma in your sinus. You have to take it that seriously. You have to make your patients understand it is that serious that you treat asthma too. So there is higher prevalence of CRS in severe asthma patients when compared to mild asthma patients, and these are the patients who are quite often have a frequent exacerbations of asthma too. And vice versa, when you treat for the polyps, their asthma also becomes better. Why I am telling all these things is it is very important to do pulmonary function test in our CRS patients. So it will be very good if you could include this in our preoperative management to do one pulmonary function test. The other important information that we need to gather while operating for a CRS with polyp patients is this histopathology report. It's there in our recent Scott-Brown also. You don't need to take a photo of this. So what is the most important information for us is what is the inflammatory predominance and what is the eosinophilic count. So higher the eosinophilic count that we have, higher is going to be the steroid dependent. Your polyp is going to be steroid dependent. So you need to deliver more steroid without causing any adverse effect to your patients. So how do we do that? The very easy conventional way that we have is an intranasal corticosteroid spray. But unlike in allergic rhinitis, where this is a wonderful drug, but because our target is more on a nasal inferior turbinate there and a tip of a middle turbinate. But when we use it in a polyp patients, because our inflammation is there here, inflammation is there here, we are not able to target these places. So that is why what we have to practice is a post-op steroid irrigation where you put it with a normal saline as in budesonide raspule, and believe me, once patients start doing it, you will see that how the polypoidal formation reduces, and once well learned, it is not very difficult to do it. You can use either a direct saline bottle or any of the commercially available bottles where you can put 0.5 mg of a budesonide raspule for a 200 ml. So for a 500 ml, you will be nearly using a 1 milligram. Patient holds in that position for some time and then puts him back into namaz position and takes it off. The advantage of this is you are able to achieve higher concentration of a steroid locally without giving any systemic adverse effects. So what about the oral steroids? So you quite often see many of these patients improve drastically well when you give an oral steroid. And many people end up giving a pulse therapies of a 5 days or a 7 days. But ideally, we should not be doing that. If you are doing it, you should be covering it for a half-life of the steroids completely, where it is 14 to 21 days. The other immunomodulatory antibiotics is a doxycycline, which can be used as an steroid sparing sometimes, because that also is known to have some anti-inflammatory effect. The immunotherapy in CRS has, by the scientific evidence, we don't have a strong evidence how we have it in allergic rhinitis. But there are definitely certain things that have been observed when immunotherapy was given in CRS patient. Is there is an objective improvement in endoscopic scoring, radiographic scoring, and decrease necessary for revision surgery when you do immunotherapy in such patients. When it comes to AFRS, Alternaria and Cladosporium are the only allergens which have a scientifically proven evidence for immunotherapy, though we do practice other allergens sometimes off-label. So this case, which I showed in the beginning, we evaluated for allergy. His SPT showed sensitization to house dust mite, cockroach allergen, and his AEC was 600. Tissue biopsy, you could see that he had a tissue levels of more than 10 eosinophil per hive power count. Patient was educated on environmental control for the aeroallergens. He was started on a neck extension irrigation with a budesonide, which I mentioned earlier. We have started on a house dust mite immunotherapy only, and this is the follow-up, this thing that you see. So there are a little bit of a polypoidal formation still here. You can see that how the sinuses are opening up now. So this is a broadly for you to have a rough idea, whereas without polyp you could do a more of a mucosal sparing. With polyp variety, with severe disease, with asthma recurrence, it is better to do a draft 3 surgeries. And in such cases where the role of biologicals will come into. So there are specific indications for biologicals. It is not that right and left for each patient that we can start with the biologicals. So to summarize, phenotyping of CRS is very important for management of CRS. Allergy evaluation and pulmonary function test should be a part of CRS with nasal polyp management. Optimizing allergy management in CRS patients reduces the recurrence rate, and biologicals are hope in specific tough cases. And I would request Dr. Sunita to take over to give more light on the biological roles in CRS patients now. Thank you. Thank you very much for your patient listening.
All questions for Dr. Gayatri will be answered during the lunch break. All our 4 speakers will take their lunch plates only after answering all the questions today. The last speaker for today's session is Dr. Sunita Chapola Shukla. She will be speaking on biologicals in allergic rhinitis. Over to you, Dr. Sunita.
Good afternoon, everyone. I know it's a postprandial session, so I hope to keep you all awake. And my first half will be about all the latest international guidelines on something to do with nasal allergy, and at the end will be some practical patient cases which I will be showing. So thanks, Gayatri, for starting that biologicals in severe tough cases. So to start with, when we say about allergic rhinitis does not come alone. It comes with a lot of comorbidities like allergic rhinitis with asthma, which is now known as a one airway, one disease. We have CRS with nasal polyp, which Gayatri covered so well. The most important thing in any of the nasal allergy is about the quality of life. As shown by Sarika, that ARIA guidelines, you will see that they have mentioned quality of life so important because it affects your sleep, absenteeism, and also psychological effect. So these all, if they are the Th2 type of inflammation, what else can we do? This is the most recent Euphoria guidelines about the treatment about severe allergic rhinitis. Here they have mentioned that if there is a failure of previous treatment, the only things which is important is allergen immunotherapy, oral corticosteroid or short course, surgeries, and add-on therapies. But if a patient wants sustained long-term effect, the only answer is allergen immunotherapy. This is a gist of all the international guidelines which I put it in one slide. That is the European, the ARIA, EPOS, ICP, and so on. Here you will see that every stage of allergic rhinitis treatment, you will see that they have mentioned at the end that you do consider AIT. AIT is allergen immunotherapy at every step, because this is the only disease modulating treatment for any IgE-mediated allergies. And as rightly said by Sarika, allergy immunotherapy, now this is the latest review, and it is said that it is a unique and unmatched model because it is a precise medicine, it is personalized for each patient. No two patients will usually have the same immunotherapy because this depends on your skin prick test, and that is how you make their treatment. And this is what we all as doctors want, that the best for the patient. This is an algorithm of a nasal polyp. We all know how to treat polyps. I'm not going into that. But many times we use steroids and we escalate the treatment as and when. Most of the patients will go for the sinus surgeries, and if they are not better, again we go for steroids, and these are labeled as the persistent disease. We all know the side effect of oral steroids. Though they are anti-allergic, they also have an anti-inflammatory and an immunosuppressive effect like recurrent infection, myopathy, cataract, and so on. So what if we get a picture like this where the patient has been operated twice, thrice, and 4 times and comes with you and he says, I don't want any more surgeries. So this is a typical case of CRS with nasal polyp, and these are the patients that in spite of surgery, their symptoms persist, and there is the role of biologicals. And also in a minority of the patient where surgeries are contraindicated and the patient has some other comorbid IgE conditions where you consider biologicals. This is just a quick review of the CRS phenotypes. Everyone in the speaker has covered it very well. This is a slide I want you all to focus as ENT surgeon, because these are the endotypes and phenotypes of the CRS. Here, there are 2 types of inflammatory thing. Actually, it is 3 types, but we are concentrating on Th1 and Th2. In Th2 inflammation, there is a role of immunotherapy, but not in Th1. And how do we know whether our patient is which type of inflammation? So this is a brief about Th2 inflammation in CRS with nasal polyp. And here, once we know what are the root causes, the polyp is not the cause, but the cause are all the chemical mediators like interleukin 4, 5, 13. They give rise to a lot of IgE levels and eosinophilia and causing all the other effects of the patient's symptoms. So as an ENT surgeon, now theory is good, madam, but how do we know what our patient has? So these are the clinical diagnostic markers, whether it is allergic rhinitis or CRS with nasal polyps, where you will come to know whether my patient has a Th1 or Th2, because the treatment for both the thing is totally different. So here is the role of biologicals, which are nothing but products which are made from living organism and are used very rampantly in vaccines, antibodies, and hormones, and so on. So once you know the problem that, okay, my patient has a severe AR or polyp, the game changer are the biologicals, and the US FDA approved one are the omalizumab, which is anti-IgE. We have dupilumab, benralizumab, and mepolizumab. But henceforth, my talk will be only on omalizumab because in India, this is the only one which is available at present. So omalizumab is an anti-IgE monoclonal antibody, and what does it do? It will this is a very nice video. These are the circulating IgE in the blood, and that is how they get attached to the mast cells. Now, once an allergen enters into the body,
IgE is cross-linked by an antigen, the cell degranulates.
So, once the allergen enters into the body, it binds with them and the mast cell degranulates, causing release of histamine and so on. Once you give omalizumab, which is the green color, they bind with these IgE and they prevent the degranulation of the mast cell. Also in this process, the receptors of the IgE on the mast cells are also decreased. So that is what omalizumab does. But one thing patients feel that if you are giving them omalizumab or anti-IgE, the IgE should reduce. You have to tell the patient before only, once I give omalizumab, it will bind to the IgE and now it will become twice the number in your blood. So never repeat a IgE again for at least a year. And if the patient does it, he will say this doctor is not good and the IgE level has increased. So this is a EPOS guideline. This I want to take 1 minute because we all are practicing ENT surgeons. What is important here? If the patient, this all is for recurrent polyps, bilateral polyps in a patient who already had a endoscopic sinus surgery, we need 3 criteria. These all will tell you that this is a Th2 inflammation. What does it mean? So a tissue eosinophilia of more than 10, blood eosinophilia of more than 250, and a total Ig of more than 100. And the second is whether the patient is using recurrent corticosteroids. I know few patients who have been using corticosteroids for more than years and for alternate day, and they are facing the long-term side effects also. Very important, quality of life. How do you assess it? Your loss of smell, whether the patient has smell, and other comorbid conditions also. Now, once you have decided that, okay, the patient is meeting 3 criteria, you start giving biologicals and you evaluate these patients after a minimum of 16 weeks, that is 4 months. And the criteria are these 5, whether the polyp size have reduced, their systemic corticosteroid need has decreased, what is the effect on quality of life, smell, and other comorbidities. And accordingly, you decide whether you continue the treatment or not. So omalizumab has very good results. This is a systemic review and a meta-analysis about RCT, which shows very good effects of omalizumab in allergic rhinitis. I have used omalizumab only in 1 patient of severe allergic rhinitis where the rhinorrhea did not decrease in spite of the patient being on 3 antihistaminics, oral corticosteroids, and topicosteroids. So this is a study about omalizumab in nasal polyps, and this was done for 52 weeks. These all are available on the net, and this is, they said that it is a very good option in patient with severe disease. AFRS itself could be a type of CRS with a IgE-mediated sensitivity, and it is said that if the patient is immune hypersensitive, we get AFRS. If the patient is immune competent, we get a fungal ball. But if the patient is immunosuppressed, we get an invasive fungal sinusitis, and the management of all the 3 is very different. But there is some study which says that there is a role of immunotherapy in AFRS, and though it is a level 2B evidence, we still do it at our center. There are some role of anti-leukotrienes, but omalizumab definitely has a role in AFRS. So these are the advances in allergic rhinitis in a recent paper. So the risk factors, we all know what allergic rhinitis is and all those theories which we have heard in COVID, but the important point is the pollution. The more the pollution and the PM level is, the more pollens will stick on these PM levels and they gain entry into the lower respiratory airways, causing a lot of other issues. The mechanism, the recent trend is the Th2 and the Th1, and that is how your treatment changes. Diagnosis, we have CRD, which Dr. Subhijan has covered so well. And the treatment now depends on the type of the endotypes and the biologicals. Initially, all the guidelines for any medical thing was opinion-based, and then it became evidence-based medicine, and now we are in the era of precision medicine. These are the recent EPOS guidelines, and precision medicine is the one which is a personalized for your one patient. It is not a one-size-suits-all tailor model, and this helps in the prevention of disease and good patient satisfaction. These are the 4 Ps of precision medicine, and here what I want to highlight is the patient's preference. Whatever you want to give, it is like a la carte menu. You tell the patient of the disease, how it is. In allergy, it is totally customized. One model does not fit all. Give them the option of surgery versus biological, but this is not the first case. 80 to 90% of the time surgery has a role. It is only for those difficult cases where biologicals kicks in, and it is a endotype-driven treatment. So this is a gist of a surgery. This is a recent paper, 2022, which tells about the patient selection, choice of biological, how do you assess your treatment response. So in the approach, all my colleagues have covered this very well. As ENT surgeon, I want the two most important last lines is that do a CBC for eosinophilia, do a total IG level. Total IG is not mandatory in all your patients of AR. It is only important if you think it's a severe condition and you might need to give biologicals. And the most important thing is the nasal polyp. Ask your histopath person to do a eosinophilic count. This can be post-surgery also, and it could be a pre-surgery also before you decide on the surgical approach. Always ask for quality of life. The EPOS guideline says that SNOT 22 is good, but I love this visual analog score which is advised by ARIA and Euphoria, because here the patient, it is so simple even for an illiterate patient to tell whether he is smiling or he is not happy. Always ask for sense of smell. These are few pictures of the skin prick test of recurrent nasal polyps. And when such a patient case, this is one of the patient I have shown here. This is a young lady, polyp surgery done 4 times, positive to dust mite pollens. Look at the IG level, it was 962. We gave her a treatment of immunotherapy, omalizumab, and the results are beautiful. Again, a AFRS patient. Here you can see the multiple allergens, IG level of 1200 and above, aspergillus positive, and you can see the result for yourself. Right from first month polyp size, and see this is the 3rd month of giving omalizumab. Again, one more patient. I have the result only of 1 month. But when a patient's come to it, it's not a nose which walks that I have only allergic rhinitis. The patient as a whole can have multiple allergies, which can be asthma, urticaria, angioedema, and so on, and it is a multiple allergy syndrome. These are the few patients where we have given this is Sonu Nigam. He had a very severe food allergy reaction to seafood. These are the patients where I have used combo of immunotherapy with biologicals, and these are just of the cases. You can see how severe the food allergens are. These are the patient for anaphylaxis. These is urticaria, angioedema, and so on. So we have used almost 380 omalizumab injection for multiple cases. Because if you're practicing allergy, you can't just do allergic rhinitis. You should have a knowledge of everything. Patient education is important because that is how you make a treatment plan, thinking about all the other allergy conditions. Give some avoidance measure to the patients in print so that they can read about it, have some brochures, do some videos in local language, and most important, when the patient says, I'm using the inhalers or the steroid spray, and it is not affecting, check the technique. Most of the time, the technique is wrong, and the patient blames that the medicine is not good, and the doctor is not good, and the doctor changes. So the learning point is that we should know what is AR and asthma, take quality of life into consideration, smell, other comorbidities, and to know if it is a Th2 inflammation, go for the CBC, IgE, and a polyp histopath. The only problem I find with biologicals is that we don't know for how long do we need it. But this question I have posed it at many international conferences, we still don't have an answer. I hope India is the first one to answer the last point. Can my immunotherapy change the way biologicals have to be used? So with this note, my take-home message is that allergies can severely impact your quality of life. They can be due to Th2 inflammation. Please refer to an allergy specialist for diagnosis, immunotherapy, and biologicals. But I am in love with immunotherapy. AIT is the only disease-modulating treatment in allergies which changes the allergic milieu to non-allergic from Th2 to a Th1. And thank you for your patient listening.
Thank you, Dr. Sunita. And with this, we conclude the session. Any questions can be addressed to the speakers over lunch. With this, we end the session, and I would like to invite all the speakers for their mementos.
Dr. Subir Jain. Dr. Sarika Verma. Dr. Gayatri Pandit. Dr. Sunita Chapola. I would like to invite Dr. Subir Jain sir on the dais to felicitate our chairpersons. Thank you for such an interactive and informative session on the allergic rhinitis. Now I'd like to I would like to involve the next chairpersons of our next talk, Dr. Prashant and Dr. Sanjeev Kumar. I would like to call on our first speaker of this session, Dr. Naveen Patel, Coagulation and ENT.
We are starting our next session. Dr. Naveen sir.
Yeah.
You will be getting 12 minutes.
Yeah.
First buzzer will be on at 10 minutes and last one will be 2 minutes after and 12 minutes.
Okay.
Thank you, sir.
So 12 minutes, right? Yes. Yeah, it's a large 1 hour talk which I have to combine in 12 minutes. Thank you very much. I will be talking about coagulation in ENT. And to this august audience, I would like to know that making coagulation understanding is very simple. It's a conductive medium of sodium chloride. When applied with the radio frequency, it produces a cloud of sodium ions known as excited plasma, which breaks down the tissue. You see this orange cloud, and it is this orange cloud which cuts and seals for you. So, what does it do to the tissues? It just, without any harm, it dissolves the tissue molecular bonds. And in an ablate mode, that means a cut mode, actually what you are doing is called hovering over the tissue. In an ablation, that means in a cutting mode, you are near touch mode with the tissue, and we paintbrush the tissue with the movement of the vein without the pressure. So this is what is the difficulty with most of the people who are starting coagulation phases. So they touch the tissue. This is near touch mode. When are you touching the tissue? When you are coagulating, you are touching the tissue. So when anybody who is starting the coagulation, they get frustrated because they are not paintbrushing the tissue. They are not in a near touch mode. That's the reason why they have a difficulty. And what are the advantages of this technology? It has a very limited depth of thermal penetration. It has a minimal quality tissue damage. It has a localized effect, and a very important, the control volumetric tissue removal, which is very important. You don't have any other technology which produces removal of tissue with hemostasis. So you have two types of coagulation system. One is called coagulation old legacy system. This is the new Vervolve system. There are vent portfolios. With this system, you attach the vent portfolio that is for tonsils and adenoids is EVAC 70 extra HP and Precise Max. And for nasal surgery is Precise EZ View. And this is the view of the vents, Precise Max. This is the turbinate vents, Reflex Ultra and PTR and Ultra 45. Soft pellet, you have Ultra 55, 65 and SP. You have laryngeal vents known as Precise LW and Precise MLW. LW is for debulking, MLW is for precision. They have a turbinator van, which is a new van, which is also a very important thing. They have brought, with the new Vervolve system, they have brought a new Hello van. This Hello van has been having two specific advantages. It has two saline ports for plasma creation, so it can coagulate on the front and the back, both the sides. And to prevent the clogging, the central suction port has been made larger, and it comes with a declogging stylet also. So kinking is also very easy, because the older EVAC 70 extra HP, when you kink, it used to reduce the flow of the saline. They have made a changes in the new Vervolve system. They have improved the irrigation system is now changeable. They have brought into the system. You can go from 0 to 5, and you can increase your coagulation also. And you have two modes, which is called high. High is for the volume reduction of tissue like tongue base and adenoid removal, and the medium is for the tonsil dissections and for the laryngeal surgeries you may have to come out. Now the new van will be of lower power also. And you have a specific yellow button for this preventing the ablation mode. If you put a wrong pedal, you can create a hole in the tissue. That's the reason why they have a disable of ablation mode. And when you want to do a fine dissection, you select a medium, which has also 3 modes, plus, minus, and medium dot. And rapid developing, you also have 3 modes over there, high, high plus, and high minus. It is again backward compatible, so there is an attachment available for older collator van to get connected to the new system. And this is the figure for higher the debulking, and you pay for the coagulation. What are the applications in coblation technology? Tonsil adenoid surgery, which is a pediatric OSS surgery. You have adult OSS surgery, the laryngeal applications, the rhinological applications, and the skull-based surgeries. So tonsil and adenoidectomy is by far the commonest procedure done by us. And we, in last 14 years, what we have done is 1,200 coblation-assisted procedures, and we have refined the technique. How did the whole technique evolve? From a conventional to a diathermy to a laser to a harmonic scalpel to a coblation. And we use a microscope because it provides you a very stable source of light. It gives you a magnification. So believe me, a magnification makes your tonsillectomy very easy. And you can use your 250 mm lens. We describe a book technique, and this is a book technique which is being shown here. So you start at the lower pole, utilize the van to dissect the tonsil, and put a C-shape incision on anterior tonsillar pillar, allow the tissue to, plasma to do the job for you, and you roll the tonsil, peeling an orange out of an orange pill, and rolling it over on the posterior tonsillar pillar. So this is how you do a tonsillectomy bloodlessly. And this is the book technique of tonsillectomy. So you roll it over onto the posterior tonsillar pillar and remove the tonsil from the posterior tonsillar pillar. Choanal adenoids left. When you do a cured adenoidectomy, you will leave behind the choanal adenoids, means a failed adenoidectomy. Patient still will be mouth breather. So why do you want to do a blind adenoidectomy when you can have such a beautiful vision with an endoscope? The 45-degree endoscopic view of your nasopharynx transorally. Again, over there also the technique has evolved from a blind technique to an endoscopic adenoidectomy using suction diathermy, microdebrider, or coblation. And we propagate a transoral endoscopic approach wherein the position is same as the tonsillectomy. So neither the patient nor the surgeon nor the endoscopy trolley has to move, ensures complete removal of choanal adenoids. And there is no hassle of transnasal endoscopic approach like deviated nasal septum, turbinates high, or very young patient with small nose. So the trick is to rotate the camera 180 degree away from you, and you can position your van. The left hand is holding the scope. I am a right-handed surgeon, so I'm holding my right hand, holding the collator van. This is how you are in the same tonsillar position. This is the view which you get. This I'm showing old legacy system van, which is doing the adenoidectomy. We use a saline cuff around the saline bottle so that every time you press a pedal, there is a beautiful flow of saline coming in. And this produces a dissolve of tissue. Up here, what you are utilizing is called a volumetric tissue removal of coblation system. That is how you do. How do you define the level of dissection? This is the area where you are actually looking at a buccopharyngeal fascia after removal of your adenoids, and the final result would be like this. So when you are seeing this buccopharyngeal fascia down here, that means your adenoid removal is complete. That's how you define your dissection and remove all the choanal adenoids. You can do a coagulation at the end of the procedure. This is a video of a transnasal endoscopic approach, which I will skip because I have a limitation of time. What are the coblation-assisted surgeries for OSS? In obstructive sleep apnea surgeries, all static obstruction needs to be corrected, and CPAP trial is given, which we accept as a modality of treatment. How do you do a correlation of DICE with decision-making in SDB or sleep disorder breathing? When you have a high Willem or a salpopharyngeal fold, you do coblation channeling. When you have Willem AP collapse, you do anterior palatoplasty. When you have a lateral collapse, you do a expansion sphincter pharyngoplasty. And in a circumferential, you do a Zeta palatoplasty or expansion sphincter palatoplasty plus anterior palatoplasty. What are the surgeries for obstructive sleep apnea? You do coblation-assisted uvuloplasty, uvulopalatoplasty, uvulopalatopharyngoplasty. You can do a coblation-assisted tongue-based reduction, and you can utilize coblation in a multi-level sleep apnea surgery. This is a coblation-assisted uvuloplasty, where this is where you can just remove the portion of the palate while you are reshaping. This is nowadays, the resection of palate is not a very common modality. So for a thicker palates like ours, that is the Indian subcontinent, we use occasionally like this, right? And you remove the part of the palate utilizing your coblator wand. This is a modified Zeta palatoplasty, where I'm showing where you are actually making utilization with the marking the stuff, then remove the coblator to remove the mucosa and the mucosal glands, and then you relocate your soft palate and suture it into the, on the palate, both the sides to your pharyngomandibular raphe. And this is how it is done. So it's basically a modified Zeta palatoplasty. This is how it is done. And this suturing is with a Vicryl, and you, in a sense, what you are creating is a very large opening at the Willem level, right? This is a coblation-assisted tongue-based reduction, wherein you are putting a patient into a tonsillar position with a small blade. Your tongue is retracted with a stitch, and you are utilizing 45-degree endoscope facing the tongue, and tongue-based reduction in the behind the circumvallate papillae, removing the central portion of the adenoid tonsil tongue base, utilizing the unique mode of coblation is volumetric tissue reduction of coblation. And this, you should do it till you see the whole vallicula, right? And that is how it is done. Okay? I have a lot of videos to play, so I'm going a little faster. Coblation is in laryngology, benign lesions of vocal cord, recurrent respiratory papilloma, masses in glottis and supraglottis, hemangiomatous lesions, subglottic stenosis. This is local RRP. This is recurrent respiratory papilloma, a preoperative video showing you the lesions. This is an adult onset RRP, right? And this is the video of actual surgery of the patient utilizing the coblation LW wand. You utilize the LW wand to debulk the lesions. It is one of the best wand which you have, because you don't have to worry about the fire with a CO2 laser. This is a very safe in oxygen-rich environment like airway. So you are utilizing the LW wand to debulk the lesion, and this is the almost complete reduction of tissue. And this is almost the last finer cleaning of the system, okay? You can remove the vocal cord polyp. I have a beautiful video wherein I am using an MLW wand, a large wand, which is, I am utilizing the MLW wand to remove the polyp. and this is an end result. Okay? You can use for subglottic hemangiomas, mucus retention cyst, subglottic stenosis. You can utilize it for glottic masses. This is how the masses can be removed utilizing the coblation. This is a secular cyst, which is a preoperative video, right? No, this is, sorry. This is a preoperative video. Large secular cyst which can be removed utilizing the coblation laryngeal band, and this is post-op 1 year, right? Coblation in bilateral vocal cord palsy, you can do a Kashima's procedure with this, and this is how it is done. This is how you do a posterior cordectomy with or without removal of partial arytenoid. Coblation in rhinology you can use for turbinatoplasty, coblation-assisted coagulation in apostexis. You can use coblation-assisted removal of masses from nose like nasopharyngeal angiofibroma, rhinosporidiosis, inverted papilloma. This is turbinatoplasty, which is utilizing coblator band. And this is the way you can use other way around, utilizing your EVAC 70 to do the turbinate reduction. And you can utilize end point like this. This is coblation-assisted JNA removal. Again, it's a large video. You utilize the coblator to dissect the JNS from the tissues. So you can use coblation very freely in juvenile nasopharyngeal angiofibroma surgeries. This is a removal of rhinosporidiosis, and this is hemangioparasitoma. So you can use coblation to do the procedures.
Summarize, sir.
I'm summarizing. Coblation is used as an additional armamentarium in complete excision of disease, and whenever there is need for volume reduction of tissue, irrigation and hemostasis at the same time, which is not possible with any other technology. Coblation is excellent for debulking of lesions and hemostasis, but lacks precision of laser for margins of resection and managing depth of resection in malignancy in laryngeal vocal cord lesions. Considering the safety of airway, for rapid debulking, you would utilize coblation along with CO2 laser. Coblation is not necessarily only way of managing difficult and common lesions in ENT, but surgery should be a part of a surgical armamentarium, and role of coblation as a standard of care for ENT disorders is established worldwide. Thank you very much.
Thank you, Navin sir. Thank you. Our next speaker is past National AOI President Dr. Viral Chaya sir. Okay. Okay, so our next speaker, Dr. Colonel Kamalpreet Singh ji, and will be speaking on acoustic trauma. Sir, again, total time given is 12 minutes.
Yes, sir. Sir, Viral Chai, sir, would you like to present? Okay.
A very good afternoon to you all. I am Colonel Kamalpreet Singh. I am from Armed Forces Medical College, Pune. So after the scintillating talks, let's hear about something you may not have heard about and what happens in the armed forces. The acoustic trauma is an entity which we routinely encounter, and I will be talking briefly about them. So the impulse trauma, so this was, you may also be encountering during your routine practice. That was starting from the workers, from our coppersmiths, the people who are working in the mines. They sometimes get encountered with the acute impulse trauma. So there were no laws for them till 1923 in India. So 1923, there was a Workers' Compensation Act which was made for them. And in 1987, it was revised. And after that, it is still not revised. However, there are various amendments for that. And in the armed forces, we don't have any such act. However, there are certain guidelines which we follow to compensate them. So what happens to this man who is holding this rocket launcher and his main bread and butter is this only. So are we paying, deafness is the price which we are paying for this. I will be talking about the morbidity, how much it is prevalent in the armed forces. So noise, we all know that it is an unwanted sound. It may be impulsive, where we call it as acoustic trauma, or it is intermittent over a long period of time, where we call it as a noise-induced hearing loss. So these are the various decibels. This is just theory. Pertinent to note is that in our entertainment clubs, like in the pubs and all, and especially yesterday night also, there is a huge sound which gets there. So we may have some loss of hair cells during those parties. And of course, during the gunshots and explosions, it is much beyond that levels. It is much beyond 140 level, 140 decibel or 150 decibels. So the routine, this is not much of interest, but just for interest's sake, it may generate some interest. I put that generally the pistol, rifle, and the revolver, once we fire, so this much is the peaks which are achieved during that firing. And the rocket launcher does the main damage to our soldiers. So it generates the sound levels much beyond 150 decibels. So there are some Canadian and the US rocket launchers. The Canadians, they are good. They are devising the rocket launchers which have less sound decibel levels. So this is what is important. So how much is the duration of the sound of the impulse trauma? So as we note that if the sound trauma more than 120 decibel, if it is for just few seconds, it may lead to deleterious effects. So similarly, there are some other things which we must note, that the 100 decibel levels for 15 minutes. Why it is important? Because a lot of us use our headphones. So if we use for long periods, it may lead to permanent damage. So what is the aim? So we have to identify what is the type of hearing loss, whether it is acute or whether it is chronic, or whether it is noise-induced hearing loss, and what are the measures which can be taken to prevent it, treat it, and the various hearing protectors which can be used for it. So acoustic trauma and noise-induced hearing loss are the two broad terms, though there are other entities which are terminologies mentioned in the literature, otitic blast trauma or the impulse noise trauma. So auditory effects of noise, basically auditory adaptation. Auditory adaptation, it is a physiological thing. If we have noise of 70 dB, so the ears are outer ear cells, they readjust, nothing happens to us. If the levels are more than 120 decibel, there can be temporary threshold shifts. And if it is prolonged for more than 3 weeks, the effect is more than 3 weeks, it turns into the permanent threshold shift. And acoustic trauma is more than 140 decibel on a short period, within seconds. So factors leading to permanent hearing loss, so that depend on the intensity and the duration. And there are some biological factors. These are very important key roles, that why some of us don't have hearing loss even if we are dancing in the floor or firing the rocket launcher. Okay, so there are various studies. First of all, they were saying there is a criteria of age, which is very important in the armed forces, because they send the people home that now you are prone to acoustic trauma, now you won't work in the army. But however, there are various studies, not the Indian studies, the studies done abroad, they have said that the age has no role. Genetic susceptibility is very important. They have found that there is an AHL gene on the chromosome 10, long arm of the chromosome 10. The people who have that, they are susceptible to hearing loss. That's why the reason that some of us may develop acoustic trauma, some of us may not develop. And of course, the other pathological conditions, if we have coexisting ear disease or the eustachian tube dysfunction, then the impact is much more. The primary care in our settings is the regimental medical officers, and the problem with this is that they are not able to reach us in time. So we are sitting as ENT surgeons, we are sitting at a tertiary care center. Maybe tertiary care center is a Jammu, but they may be sitting quite ahead, maybe in Poonch or other areas. When they reach to us, it takes 3 to 4 days. So the important period is lost in that. So they may present with burn injuries, the discharge. Most of them have perforation. So nothing great in this, but however, Sometimes, I will give you some statistics also. They have ossicular disruption, perilimb fistula, and they have the threshold shift. So most of them, they are in temporary threshold shift. However, they reach late to us and may end up in permanent threshold shift. So what we have found that most of them, 95% of them, if they have acoustic trauma, the perforation heals by itself. So there is no need for any surgery in that. Only in about 5% of the cases they require a tympanoplasty. So we must not hurry. We should wait for at least 12 weeks before we do a tympanoplasty. Most of our soldiers, when they have a huge pride that they won't report to us, they won't come to a doctor, that because it's the pride of the unit and the Pulton, that they don't want to get treated, because the pride of the Pulton is more than the pride of the individual. So they go home and then they may be visiting many of you. Doctor Saab, ये हमारा दिक्कत हो गया, थोड़ा देख लीजिए. So we should not hurry and do the tympanoplasty and all, because that have long-term effects also on his assessment. The medical will be done and he may have a scar, he may have a residual perforation, then there are some implications, he may not get the disability. So, but we should wait. What the point is that if we wait for 12 weeks, most of the perforations heal by itself. And the hearing is also satisfactory if we treat them on time. I will come to the treatment of this sensory hearing loss, especially in the next slide. And the duration of the hospital admission is okay. So what the problem is? Problem is that most of us, we as an ENT surgeons or as a whole, we should advise them that they should use a hearing protection. We in the armed forces, we have the ear muffs, the ear plugs and all, but they hardly use them. Even they say that wearing a turban also, they mask the hearing by about 10 to 20 decibels. So there are the steel helmets which are worn by our soldiers. So they don't offer any protection. So now we have proposed, so I was in Jammu, so I have proposed that there should be a helmets which should have a metal settings and a ear muffs inbuilt in that. So by force they have to wear the helmet and the ears will be protected. The role of concurrent upper respiratory tract infection, this is there, we already discussed. Eardrops. So we should not advocate them eardrops, because most of the middle ear is sterile. The infection and everything is outside. The external ear, the middle ear, the external aortic canal. But if we use eardrops, we are going from the unsterile environment to the sterile environment. So the treatment protocols advised to them is the antibiotics and the decongestants. And if they have a hearing loss, they should be offered prednisolone. Okay, and prednisolone, we all know, we have done a study which have been published here in the Indian Journal of Otolaryngology. We have studied this in 200 soldiers who presented to us with gunshot injuries and the mine blast injuries. So most of them were blast injuries, and there were many of the gunshot injuries also. So they reported the patients, the soldiers with the blast injuries, they report to us early. The reason is, once there is a blast, there are multiple injuries to the body also. So they report because those injuries are seen, so they come to us early. Those who have only gunshot injury, only the tinnitus or the hearing loss, they don't present to us because, again, I said that they want to hide it or their pride is there. So they take time sometimes to reach to us. So this study, we have compared the 4 groups. So what we have found that if we give prednisolone for 60 milligram for 10 days and taper it over the next 4 days, that is the best regime. Though there was efficacy for all the 4 groups, in some of them we gave for 5 days, 6 days, 8 days. So what we have found that in 95% of the patients, if we give steroids within 72 hours, 10 milligram, 60 milligram, once in a day for about 10 days and taper over the next 14 days, 95% of the patients, the hearing is improved. So this is just the data that most of the patients improve, and some of them, they may end up in the permanent hearing loss. So antioxidant therapy, this is a new thing which is there. There are many papers on this. Then acetylcysteine, these we can use. The reason for this is that sometimes there is a nascent oxygen reactors which are produced. So they say that once that is there, that damage later on, it leads to the formation of a cascade, and it leads to the formation of the necrosis in the outer hair cells, in the stereocilia and all. So they help to prevent that cascade. So this is an avoidable injury, and we should all know, and whatever, this is not only the armed forces, even in the civil setup, there are, the patients may come to you also, and we must take care of the patients because most of them are unaware about their conditions. So the risk to the armed forces is, to our soldiers is much more. They have studied, one of the studies in the US they have done, that about 31% of the troops which are deployed in Iraq, they reported with some ear symptoms, and 72% was found to have the noise-induced hearing loss. Why our men don't suffer, what we have found? So reason was this only, the lack of the awareness, the peer pressure, and fear of getting boarded out from the services only also. So we should have, this is for us only, not much for you, and we should build awareness about this thing. We should have earmuffs. We should not use high headphones at very high volumes, and we should institute some comprehensive hearing conservation program in our, I think, Indian settings as well. We are in for the armed forces, but we should have a national program on this also. Jen. Any questions?
Thank you, Kamalpreet sir. Noise pollution is one of the most neglected area with the governments. Our national president, Dr. Nandu Kolwadkar, yesterday only declared that he will be doing something about noise pollution awareness.
Yes, sir.
We should pledge to help him out. Thank you, sir.
Thank you, sir.
Our next speaker is past National AOI President, Dr. Viral Chaya, sir. And he'll be telling something about coblation blues.
Respected Chairman, sir, and my dear fellow colleagues, in a cricket team, when you have Ishan Kishan, when you have all those star batting openers like Virat Kohli, Naveen Patel, I am the 12th man in coblation. But the reason of coming out with this is that many times when you start off coblation late, you've got many apprehensions. Why should we use coblation? When we are very happy with the cold steel, when we are very good with all good results, then why coblation? Why should we invest in coblation? We always have so many things and feedbacks from people that the vent does not use much, and this is all like this, and you have to invest a lot, and you need a training, and it's very costly, and you have to throw the vent after 3 or 4 surgeries. And so we always feel that the investment is more, the outcome may be less, and that when you are working in a city, which is a small city like Jamnagar or a small peripheral city, we would always feel that it's better to do with and happy with whatever we are, rather than going for coblation. What I thought was that, let me just tell you, is coblation necessary? We have some views about coblation. Nahi karna hai. That is the first thing. The first knee-jerk reaction is nahi karna hai. Is coblation necessary? You saw in Naveen's slide. Coblation is being used everywhere. Everywhere you see the coblation is being used. Today, in fact, I was seeing Dr. Madan Kapre. He is using, in CSF leaks also, he is using coblations. So where coblation is not used, what about the cost factor and what about the return on money invested? Everything comes back. Are the vents very costly? Are the vents very short-lived? And what do I do with the used vents? These are the common questions which comes into one's mind when you invest into a coblation. Is coblation necessary? Yes, we all know coblation is very necessary nowadays, because if you change before change, you prosper, like Naveen. If you change with the change, you survive, like me. If you change after change, you perish. When everybody is doing coblation and you start doing coblation, then it's not a fun at all. So why should I change when I'm happy with the cold instruments? There is always a question which comes. Friends, AOI conference, myself and Dr. Sudhakar have been in this conference since 2015. And we always maintain this thing that in a conference, basics to advanced, everything should come. That was the reason why, in fact, when Naveen's lecture was before me, I was a little apprehensive because he is doing so much of work. What would my lecture thought? But I thought, yes, it's a different direction. Let me just throw some lights because I'm sure out of these people sitting in this hall, are everybody doing coblation? Yes, maybe 2 or 3, 4, 5 raise of hands. 6, 7. Very good, chalo, very nice. Out of at least 80 people over here, 10, 15 are doing it. Great. So your eyes will see what your mind knows. It has got multiple uses. The precision with which you work is excellent. We saw in Naveen's this thing, the polyp, the way the polyp came out. Naveen, I'm using you. Huh? I'm using your slides. The way in which the polyp came out, superb. The tissue damage is minimal. The voice restoration is excellent. The post-operative outcome is very good. And forget bleeding. It's not that bleeding does not occur, but there is almost no bleeding at all. So the apprehension with the anesthetic also goes away. Usually in my times when myself and Dr. Sudhakar, everybody used to do a routine tonsillectomy, over and above the cold instrument, they used to pack the tonsil, the endotracheal tube around so that, it's become so cumbersome that you have a mouth gag, a short mouth, a short neck, and the back of the anesthetic, and you put a blade inside, and then you open up, and then you do all those things, then tonsil bleeds, and here the anesthetic is very safe. He is seeing the surgery on the screen. He knows what is happening, and his extubation goes without putting a laryngoscope inside. Okay, this is a small video which I have just shown. Naveen has shown all the videos, but this is how fast a tonsillectomy can be done. This is how a bleedless this surgery can be done. But well, friends, when the surgery is going on, just keep seeing at the surgery, and I'll keep on talking on certain things. That many times we are apprehensive, whatever the vent, about the usage, how much will it work, how many vents, one band will give how many surgeries. Everything depends upon how nicely you use it. The many things are being taught when you go for the coblation workshops. The most important thing is that don't just start the coblation and try to finish everything. Give it a gap. Every time whenever the coblation occurs, I'll come to the physics of coblation, but whenever coblation occurs, always wait for a second, then again restart. Always wait for a second, then again restart. Suppose if you're doing in summer season, the saline which is there, if you keep it into a freeze and then use the saline, normal saline which is there, then your coblation becomes faster. So every time you have to create that coblation. That coblation, if you continuously just put your pedal and then keep on operating, there are many, the outcome is less, the band is more used, and at the end of the day, you feel that you are not happy with the whole thing. So this is how it goes, and we all know that this vent has coblation tip, has the coblation, the cautery, and the suction. So you are seeing that there is absolutely bloodless. The anesthetist keeps on saying, and every tonsil has its own way. And let me tell you, when you promote coblation to the patients and show this video, they all will be very happy to see that this is how the whole tonsil is, their tonsil is going to come out. And the bleeding is most minimal. And if you remain above the muscle, then the pain factor is very less. The pain factor, it is not that it does not pain. Even if you cut your nail by mistake, it pains, your finger pains. It is not, it does not pain, it is not painless. But with the normal analgesics, with normal paracetamol, the pain comes around and things become very fine. So you will see that at a certain level, at the lower pole, you can see the muscles, you may see the muscles slightly exposed, but then remove more towards the tonsil. And the whole tonsil will come out very easily. And the whole idea of doing this is that ultimately at the end of the day, when we have been practicing with cold instruments, when we have been doing it so long, and why not have the luxury? Don't you invest into bigger cars? Otherwise, 800 Maruti was there when we came, and it was a very good car when we shifted from Fiat to Ambassador. And now, we all would like to dream about Mercedes. If we are dreaming about Mercedes, why not coblation? And coblation works everywhere. So this is how, it's just one more minute or one more second to go. And this is the lower pole, and just you have to keep doing the coblation. And whenever you are seeing that I'm sucking out the saline, I'm taking away my foot from the coblation foot band so that, it gets rest. And when the whole thing appears new. So we all must be knowing how exactly the coagulation works. I hope we know the physics of the coagulation. I'll come to the physics of coagulation, but if the time permits. But otherwise, we all know that this is how we go, and this is what the whole area is. It looks so beautiful. Is coagulation costly? No. When you are the Amitabh Bachchan of your place, when you can afford everything, you have been practicing so long, why not change? We all were doing endoscopies. We all were doing normal things. We were doing tympanoplasties with a microscope. Sanjeev Kumar came in, doing endoscopic. I mean, there are so many. And there are endoscopic, tympanoplasties. Isn't it new? Didn't you change? Giving more better results? Yes. Is it costly? No. If your Vivo phone can give what your iPhone can give, you can always have a Vivo and iPhone both, no doubt about it. But then Vivo gives better, go for the better. This is usually the coagulation instrument that's being used. Coagulations are not costly. Of course, from the bigger companies, they are very costly. But nowadays, you must be seeing around in the stall the normal coagulations, but they work. They definitely work. When you are a novice, when you are you are not sure with the coagulation, don't invest into very heavy things. Just invest into normal things. This is usually the console and the vent which is there. Now, what is exactly coagulation? It is controlled ablation. And how does it work? It's the creation and application of high energy field called glow discharge plasma. It's a chemical process and not a thermal process. The 100-200 μm plasma field allows for precise volumetric removal of soft tissue with minimum thermal damage to untargeted tissues. Initially, what we were thinking was that there are only 3 states of matter: liquid, solid, and gas. In physics now it has come that plasma is also one of the states of matter. This is this plasma generation which cuts the entire thing. How does this plasma generation occur? First stage, this is characterized by transition from bubble to film boiling. This decreases heat emission and causes increase in surface temperature. Then is the vapor formation. Tissue ablation occurs during this stage. Third stage is reduction of amplitude of current across the electrodes. The coagulation effect will start reducing from this stage. Fourth stage is dissipation of electron energy at the metal electrode surface. Now, and the fifth stage is the stage of thermal dissipation of energy. These stages are explained why coagulation is effective when applied intermittently. You should not continuously keep on applying the oblations. And this ensures constant present stage of vapor film pulsation, which is important for tissue ablation. Is the coagulation went very costly? No. Short-lived, only 2 or 3 surgeries. It depends upon you. But ideally, many times I ask my colleagues, "Arey sir, हम तो खींचते हैं, जब तक चलता है तब तक खींचते रहते हैं." No, this will give infection. Don't go for the money part. Monetary is always there. But if you keep on doing 5th surgery, 6th surgery, 7th surgery, अरे चलता है, चलने दो, चलता है, चलने दो, your time limit will increase, and post-op, you will definitely find a clot in the fossa or a clot in your, it will not work at all. It will stop working. There is no doubt about it. And as I told you, how to keep the plasma state continuous and how to increase the vent life, just keep on, give intermittent things. Now, how do I use the used vent? Vent ho gaya, you are doing all this laryngeal surgery, you are doing nasopharyngeal angiofibroma, you are doing CSF rhinorrhea, you are doing multiple papilloma of the larynx, you are doing tonsillectomy, you are doing inferior turbinate cautery, so many things you are doing it. But now, jo vent use ho gaya, if you want to use, we have residents. So we just told them what you do. And they started using it. Chalo sir, just as a trial, just as a practice. Sublabel retention cyst. Put a vent on it. It burns. It's gone. Tongue papilloma goes out. Tongue tie. I think the best thing is just raise the tongue and put the coagulation. The whole tongue comes in your hand. So ultimately, what you need is for the finest, best surgeries, you need a proper vent. But ये vent जो 5-6 बार यूज हो चुका है, बाद में क्या करेंगे? इफेक्ट तो चलती ही है. ऐसा नहीं कि coagulation बन नहीं रहा है. So you can always use this. You can use a surface cautery for inferior turbinate and control the surface bleeding also. Thank you very much for being with me. I'm sure this was a very basic lecture.
Thank you very much, sir. Actually, one question from my side, both of you. Are you using coagulation in thyroidectomy?
No,
Naveen,
I am
sir?
not using. Naveen?
Yeah.
Which is a touch van. So they have withdrawn that from the market.
Yeah.
They came out with a touch van, but the new Vervolve system will bring in now, because what they are trying to bring in is now not that near touch mode. They are trying to bring in the touch mode.
Yeah.
So that eliminates the learning of which all of you are facing.
Yes.
So the new Vervolve system, what they brought in is a touch van.
Touch
It's
van.
not that near touch mode.
Okay.
So their next generation vans will be touch vans. So their Hello van is actually a touch van.
Touch van, yes, sir.
Cuts and coagulates with the touch, the way you use your diathermy.
Yes.
Okay.
So their Hedenic van will also come into the picture. Because they introduced, but it was working with the wrong.
I think Naveen, join me here on the dais only. That will be better.
The vascularity will be less, yeah.
Yeah, actually it is used in very vascular skull base or neurosurgical lesions also.
Okay,
My
sir.
neurosurgeon, it is an off-label use. He uses in the brain. All the lesions where QSA is not working, he just takes a co-blator van. On paper, he can't use it, like he puts my name in and utilizes for vascular lesions.
Okay, sir.
It's beautiful. And they have used even in gynecologists for fibroids, and they have used everywhere where you need hemostasis with volume reduction of tissue.
And let me tell you, I mean, Naveen, please be with me, but when you are removing a nasopharyngeal angiofibroma and when you are using the VAND, I mean, it does not coagulate the angiofibroma. It finds a beautiful plane of cleavage, which just takes...
The surface.
That's the side.
You can in fact cut across the nasopharyngeal angiofibromas when you have a very large stage
Exactly.
3 lesion. You can cut across. When you have clipped the vessel, you cut across the tumor, make it half, and then you go to the next stage of dissection. It makes your surgery faster and quicker. Same thing happens in larynx also. In a laryngeal huge malignancy, you use a co-blator van to debulk very quickly.
Thank you very much, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Yeah, I have a beautiful video, if they permit me. You know, for a secondary hemorrhage, the best tool what you have is again a co-blator van.
Exactly.
So if you have a bleeding happening on a 5th or a 6th day, you just utilize, I have a beautiful video I can connect and show you, or you can come to me and I'll show you video.
That'll be more better because we've got very limited time.
Yeah. Sir.
But thank you that this generated so many queries.
Yeah.
Thank you very much.
And your talk entitled so much, sir.
Thank
That's
you.
why the query is coming.
Thank you very much, sir. Thank you so much. Thank you, Naveen. Thank you so much. Thank you, guys.
Our next speaker is Dr. Ram Heda from Akola, Maharashtra.
And an endoscopy guy. Love you, sir.
He is one of the finest otologists in Vidarbha. And he will be deliberating upon endoscopic management of cholesteatoma.
Respected chairpersons, seniors, and my dear friends. This is more of a video presentation, and we will be discussing only practical aspect of approach to cholesteatoma surgery, because theory you all know better than me. Aortic cholesteatoma primarily affect the aortic, mastoid, and sometimes mesotympanum. Pathology demands urgent attention because of its ability to spread and destroy surrounding structures and may lead to intracranial complications. In the surgery for cholesteatoma, emphasis is on complete removal of disease, and the target is end epithelium. To access the disease, one may have to remove the bone. Remember, the bone is removed to access the disease area and not because the bone is diseased. More the bone removal, more is the distorted anatomy, and this makes reconstruction difficult. Residual disease at the end of surgery is responsible for recurrences. Tympanic cavity, particularly sinus tympana, is the commonest site of recurrences, and this is the area difficult to reach with microscope. Here the endoscope have an added advantage of accessing the extensions of the middle ear and removing diseases from these areas without much of the bone removal. Because endoscope not only gives a panoramic view of the ear canal and the middle ear, but also allows surgeon to bypass the canal overhang and rapidly reach the area of surgical interest. Advantage with the endoscope is the wide-angle view provided by the endoscope that enables transcanal access to the tympanic cavity, and it's otherwise difficult to reach extensions without much bone removal. These are few more advantages of the endoscope. Now, we have already seen this slide. Now, we will see whether the use of endoscope is justified in cholesteatoma surgery, considering all these points. Now, this is the case. You can appreciate there is attic restriction, very much attic restriction. Even the posterior superior quadrant and posterior inferior quadrant is involved. So, likely the cholesteatoma has gone into the mesotympanum as well. Now, this is I am doing all the surgeries single-handedly with endoscope. And for all cases, we use this mini endoral incision. So, at the end of surgery, there is no postoperative scar. And whether it is extensive disease or plain simple tympanoplasty, all cases are done with this incision only. Now, this is the disease. See, the attic is completely destroyed. And try to appreciate the panoramic view of the endoscope. Now, this is the incision taken on the posterior canal wall. This is always 6 o'clock to 12 o'clock position. And I never take vertical incisions, because if you are taking vertical incisions, then if you want to extend the incision, then it is not possible. So, this is after entering the middle ear. You can see. Now, first we will remove the disease from the facial recess and the sinus tympani. See how nicely it can be removed from these areas. Try to appreciate the visualization of the structures. This is without removing any bone. Now, this is around the stapes. Stapes part, usually I keep it to the last, because at the end of the surgery, you have much more idea about the stapes and you get more space to work around the stapes. So, see, now we are extending the incision on the anterior canal wall, because now we are sure that there is disease in the mesotympanum also, and we will have to approach the anterior cavity, tympanic cavity as well. Now, this is little bit of bone removal to get access to the mastoid. Now, try to appreciate the disease in the mesotympanum. That is denuding the handle of malleus, because we are not sure the ossicular status, but you can appreciate the long process of incus has gone. Now see, the cholesteatoma sac is reaching right up to the anterior part of the tympanic cavity. Is the video clear? Okay. So now we know the disease is extensive, and we will have to do the bone work. So we are cutting the flap and we are posing it in the inferior canal wall. Now this is elevating the annulus anteriorly. See, I am deliberately keeping a mucosa intact here, because at times you are not able to take out the sac from the mucosa. In that cases, you can excise the mucosa along with the cholesteatoma sac. But in this case, it was possible to dissect the sac out from that area. So now elevating the sac, see, we are following the disease from the middle ear cavity to the mastoid, like the cholesteatoma progresses. Now once you are sure that you have elevated the sac, then you can remove it easily. See how nicely it is seen. The eustachian tube opening is also very well seen. Then we approach the attic area. The mucosa of the middle ear also looks healthy. Now whole ossicular chain is engulfed in the cholesteatoma sac. And I know that the long process of incus is already destroyed. So I am easily removing it. But if you are not sure, then you should first disarticulate the IS joint and then remove the incus. Then the head of malleus is nipped out. Handle of malleus I always keep that way because it always gives support to the temporalis fascia graft, because I always keep it lateral to the handle of malleus. Now dissecting out the cholesteatoma sac from the attic area. See, the sinus tympani area is devoid of disease now. It is very well seen. Now little bit of bone drilling here, because what is the prerequisite? Before starting dissection in the mastoid cavity, you should be able to see the tip of the mastoid cavity and the sinodural angle with the help of endoscope. That is the prerequisite. Otherwise, you will end up in removing it piecemeal and not in the sac piecemeal and not in continuity. Now we are dissecting the sac in the mastoid cavity. Try to appreciate this is 0-degree wide angle sinus endoscope. And instrument I am using in the mastoid cavity is also our regular circular knife. Little bit more drilling there because I am not able to see the tip. Now it can be very well appreciated. Now dissecting out the sac from the sinodural angle. And we will try to dissect this sac from the mastoid cavity intact so that no end epithelium is left there. Now to try to appreciate the bulge of lateral semicircular canal. And see, still we are with the 0-degree endoscope. You can see right into the mastoid cavity with minimal of bone drilling or bone removal. At times when the mastoid cavity is well pneumatized, then you may have to use a little bit more curved instruments, but in this case it was not needed. Now we are dissecting it from the mastoid cavity. Try to appreciate right up to the base of the sac, we could dissect. And now once you are sure that you have dissected it properly, you can remove it with the forceps. Our regular granulation forceps is there. It is not angled one. So it has come out intact. Try to appreciate the mastoid is devoid of disease now. Now I will approach the stapes area because usually I leave it to the last. Never ever pull it with much of the force and only remove the part that has been elevated. And see the direction of the movement when you have to remove it. You should not pull it outward. Now this is devoid of the disease, attic is devoid of disease, sinus tympani is devoid of disease, and whole cavity. Now the reconstruction part comes. This is temporalis fascia graft. Now the flap has been reposed, the posterior tympanomeatal flap. And since the mucosa of the middle ear looks healthy in this case, I will not go for any boomerang cartilage or that. Direct columella tympanoplasty will be done, keeping cartilage on the head of the stapes. So that is the cartilage on the head of stapes. Chorda is deliberately kept like that. And then now reconstructing the posterior canal wall. This is with the piece of tragal cartilage. Now reposing the flap again. The flap may fall short sometimes, so deliberately a cut is given here because here I can afford a little bit of bone exposure and not on the cartilage. If you want, you can cover this with the skin graft. Now see, at the end of surgery with such an extensive disease, we are getting a good cavity with good ossicular reconstruction and with good normal looking air canal. So, that is the end of the surgery. So the thinking is that with endoscope, we can do only tympanoplasties and stapes and all, and extensive disease of the middle ear cleft are not possible to approach with. But since last more than 10 years, I am using exclusively endoscope. I am not using microscope at all, but microscope is always kept ready in my OT because you never know when the need will arise. So endoscope have an added advantage of accessing the extensions of the middle ear cleft and removing disease from those areas without much of the bone removal, thus providing good anatomical framework at the end of surgery which allows better reconstructions. Remember, we are primarily ENT surgeon. We are not endoscopic or microscopic surgeon. So you have both the tool in your OT. Always keep both the things, just see a second. Always keep both the things ready, because whenever sometimes the need arises, I am using endoscope, I can shift to microscope. If the person is using microscope only and he is finding to examine the difficult areas of the this middle ear cavities, then he can use endoscope. So whatever we do, it should always be for the betterment of the patient. Thank you.
Thank you, sir. Thank you very much. Actually, one point here. The future of ear surgery is combined, probably either endoscope or microscope with endoscope. So if option created that I will go only with microscope, I think they are not going to survive in otology. Probably my prediction. And what do you think about?
I already said that primarily we are ENT surgeons. And whatever we do, it should be for the betterment of patient. It cannot be the thing like I will do only with endoscope. Suppose you are stuck up while doing it with the endoscope and you are stuck up at some part, then you can always shift to microscope. What is harm in that?
But in last 2 decades, what the endoscopic, the approach of ear surgery has when and that's the struggle by the endoscopics that is not going to survive in otology. That was that. And now the endoscope in ear has survived very well established, and there is, I think, lots of paper and workshop regularly happening in national and international level. So I think the future of endoscope in ear is bright.
Yeah, that is true. That is true. Since last more than 10 years, I have not used microscope, except for the patients with the intracranial complications. And now we are planning to extend our use of endoscope for the intracranial, like extradural abscesses and all. So we'll see what the future is.
Thank you very
much. Thank you, Ram. Thank you. Thank you, all the speakers. So over to you.
Thank you all the speakers for such an informative and productive session. Now I would like to call on upon the stage the chairperson to felicitate our speakers. Dr. Naveen Patel. Dr. Colonel Kamalpreet Singh. Dr. Viral Chachaya. Dr. Ram Heda. I invite all the speakers to come on the dais for a group photo. The speaker of this session. I would like to invite Dr. Naveen Patel. Kindly come on the dais and felicitate our speakers, chairpersons. Naveen, so you're going to stay with us for next 1 more hour, as you are chairperson for the next session. Being a new and upgrading surgeon, seeing all my seniors and teaching us such an interactive endoscopic cholesteatoma surgery and seeing all these videos gives us very good confidence that in some time we also try to attempt it and perform it. Thank you, sir, thank you so much. Now I would like to call on the next session, the chairpersons, Dr. Atul. Dr. Atul and Dr. Naveen Patel. Dr. Atul is in the hall. Atul sir. So, please sir. So I would like to call on our first speaker, Dr. Nisha Gupta ma'am. The topic is endoscopic management of the orbital disorders.
So, good evening. My topic is endoscopic management of orbital disorders. My area of interest includes endoscopic lacrimal orbit and sinus diseases, and these are some of the books that we've published. Now, this is the whole plethora of procedures that we are able to perform through the endoscopic route. The first procedure is the management of inflammatory orbital disease, the most common indication. This is a 4-month-old child who presented with recurrent periorbital cellulitis, edema, and discharging fistula. He was admitted 4 times with IV antibiotics, but the swelling failed to resolve. The child was therefore taken for surgery, and on CT scan we can see sequestra lying along the floor of the orbit and involvement of the ethmoid sinuses. So endoscopic route was used to drain the mucopurulent discharge, clear the ethmoid sinuses. That's the mucopurulent discharge which was drained, and the inflammatory tissue from the ethmoid area was cleaned. But this child was done as a combination surgery with the team of ophthalmic surgeons, and a lateral canthotomy was done. Because we can see this fistula over the floor with sequestra that we saw on CT scan, so we wanted to ensure that there is no communication of this outside fistula with the orbital floor. So a subperiosteal incision was given, and the orbital floor was examined. There was no continuity found. However, the granulation tissue was removed and sent for culture. It came out as staphylococcus. So the child responded very well to the antibiotics, and all this sequestra was cleared from the floor. This is the posto. The second indication is the balanced orbital decompression. As we all know, thyroid orbitopathy is a medical disease, and it is treated with high dose of IV methylprednisolone. Non-responders undergo the surgical treatment. As we can see here, this is a 36-year-old man who presented with proptosis and fallen vision in both eyes. We can see hypertrophied muscles. I hope my cursor is visible, yes. We can see all the muscles are hypertrophied in both the eyes. And this patient underwent a medial as well as the lateral decompression, and that is why we call it balanced decompression. In such cases, the chances of diplopia are minimized. So all of us as ENT can do this medial decompression. It's a very simple procedure where the lamina is exposed by doing all those essential steps of middle meatal enterostomy, sphenoethmoidotomy, and the lamina papyracea is removed gently. The periorbita is exposed and the fat is allowed to prolapse into the nasal cavity. Any loculi into the fat are broken using the forceps to achieve maximum decompression. The same procedure is repeated on the other side, and this was combined with the lateral decompression that was done by our ophthalmic team. And post-operatively, this is pre-operative video, and this is the post-operative video. The results are excellent because they also do blepharoplasty and other cosmetic surgeries if the protrusion is too much. This is another case of medial orbital and orbital apex decompression. A 33-year-old lady presented with deterioration in the vision in her left eye, and we can see crowding of the orbital apex here on MRI. We can see this eye, her vision decreased to 1/60 with restricted eye movement. So we did only one side. She was reluctant for surgery, but she was losing her vision. So we took her up for surgery, and this is the sphenoid. We can see this was a thin bone over the carotid, and we could even see the blood flow into the carotid vessel. That's the optic nerve. Lamina pepracia was removed like in the previous case. Now here, when we perform only the medial decompression, then we prefer to leave a sleeve of the periorbita to prevent prolapse of the medial rectus muscle, and that minimizes diplopia in the post-operative period. Also in cases where the proptosis is severe and there is associated severe vision loss, then it is better to do a little bit of optic nerve decompression also and drill the area of annulus of Zinn. As we can see here, as we go towards the optic nerve, the bone starts getting thick. So this area is drilled to achieve maximum decompression of the orbital muscles also. And this bone over the optic nerve was also drilled. So once we work in this area, then it is better to give incision over the periorbita after the bony work is complete. There is no need to do a complete optic nerve decompression, but whatever maximum bone we can remove from this apex area, that is removed. So that's the part of the optic nerve that has been exposed. And after this incision is given over the periorbita, this is a 12-number blade that we've used. From posterior to anterior, incision should be given so that if we start from anterior to posterior, the fat will prolapse into the field and will obscure our view. So this is the sleeve of the periorbita. As you can see, I've given 2 parallel incisions, and we've left this sleeve of periorbita because the lateral decompression was not done in this case. The fourth is salvaging the eye in infiltrative fungal diseases. As we can see here, this 31-year-old male presented with severe proptosis, chemosis, grade 3 lag ophthalmos, and the nasal cavity is full of mass. As we can see on MRI also, the orbit is almost 3/4 infiltrated with the mass. So the aim was to acquire a biopsy and also carry out maximum debridement. So we removed big chunks of tissue with the help of forceps and teased. This is the proptosis that we saw intraoperatively. The tissue was formed, and by now we know by the appearance of tissue that the first diagnosis these days, of course, is fungal infection. We still tried to expose as much as tumor mass we could expose, which of course looked like tumor to us. That was delivered into the nose after drilling the frontal process of maxilla. Then it was teased out, and the layers were debrided. We saw only a part of lamina pepracia was left, and rest was destroyed by the disease. As we can see here, this is over the eye. This is the part of lamina pepracia, and whatever tissue maximum we could remove from the medial compartment, we removed, and it turned out to be invasive aspergillosis, and the patient was put on voriconazole. And look at the post-op picture. We did both sides, though MRI was showing one side. But we did both sides, and the other side was also full because by the time patient was operated, 1 month had already passed. He had excellent vision and complete recovery. Next comes the optic nerve decompression. Since the time is less, so I'm showing very small videos of all the situations. This is a 32-year-old male who presented with the history of road traffic accident. We can see fracture in the optic nerve canal here. And same sphenoethmoidotomy, and the anterior face was widened. Lamina pepracia was removed, And the optic nerve can be identified as we remove lamina papricia and go towards the sphenoid sinus. There is narrowing. It starts curving, and that is how we can identify. We remove as much bone as we can with the help of a blunt dissector or a right angle curette. And if the bone is thick, then it can be drilled out. And once it is thin, it is removed using the blunt dissector. So that's the optic nerve that we can see here. And that's the sign of indentation over the optic nerve. So this is whole exposure of the optic nerve. And from light perception, patient had finger movement. Not very significant vision improvement, but whatever was there, we preserved that. Next comes the orbit apex lesion. This is a video of 50-year-old woman who presented with pain, heaviness, and discomfort. As we can see here on MRI railroading sign, there is this involvement of the optic nerve at the apex area. And this was a very small lesion, so we used navigation-guided procedure. And we could, with the help of our ophthalmic team, who helped us put a retractor into the eye and identify the muscles, though we can do it intranasally also. But it is helpful sometimes when the lesion is very small. And that's the medial rectus. This is the inferior rectus. We could see this small lesion between the medial rectus and the inferior rectus, exactly in line with what we saw on MRI. So this lesion was removed and it turned out to be astrocytoma. Next is the intraorbital foreign body. This is a very interesting case who presented to us with this swelling on the lid margin. Patient had history of one external DCR. And probably during surgery, after the surgery, sometimes there is a lot of bleeding. The pack was pushed tightly and it pierced the lamina papricia and got deposited into the orbit, on the supraorbital aspect. And that's the beautiful MRI picture of the same. So when we did endoscopy, we saw this bulge and this patent opening of the external DCR. So it was a nicely done surgery, but this was a foreign body. As we started exploring, we saw these fibers, which we were quite stunned. We thought it is an orbital mass and we'll be taking a biopsy. But it turned out to be these fibers, and that's the frontal sinus. We explored all supraorbital area and we kept pulling, and these are the pieces that we removed. So the list is endless. I can't go into the details of all. And the one important indication is biopsy of difficult lesions. Then there are orbital complications of infected paranasal mucoceles and multidisciplinary approach for removal of orbital tumor. We have a full series now. But I will not be going into the detail and will be finishing here. I hope I have not crossed my time. Thank you.
Excellent demonstration, Dr. Nidhi. I would like to ask a question. When you're doing orbital procedure
Can
and
you
you're
be a little
exposing,
loud, please?
when you're doing the orbital procedures, you're exposing the optic nerve. So how do you go for the packing, nasal packing?
We just put a very soft Sofratuli pack just at the mouth of the sphenoid sinus, but do not pack over the optic nerve.
Okay.
So it's a soft pack what you are using?
It's a soft pack.
Okay, ma'am. Yes, yes.
Yes.
Yes, adequately. No. We actually, this is a topic in itself, periorbital cellulitis and when to operate. Majority of cases we do not operate. And there are certain indicators when patient is put on IV antibiotics, what is the extent of resolution and what is the pattern a particular patient is following. So we explore only if there is increased chemosis, conjunctival edema, difficulty in closing the eyes, and also blurry vision. So that becomes an emergency. Otherwise, most of the patients do respond. Even the subperiosteal abscess also we've seen resolves with antibiotic. No, it there are set parameters. If the patient is deteriorating despite antibiotic, IV antibiotics, that becomes an indication. And deterioration to what extent? Like vision compromise, severe proptosis, chemosis. No, no, it's okay. I work in an eye hospital, so and it's a huge hospital. We get a good supply of such cases. So even the subperiosteal abscess, as I said, sometimes we post the patient and he comes after 7 days, suppose date given, and we realize on the day there is complete resolution of clinical symptoms, then we don't explore.
And in
Sir, I didn't get you. Yeah, exactly. Most of them. Sometimes doctors get, one of the oculoplastic doctor got his son to me saying, please explore. So he had put his child on IV antibiotics. He knew that there is gross proptosis. And with chemosis, even if the vision is normal, but the proptosis is increasing, despite 3-4 days of IV antibiotics, then I think it's better prophylactically. You just clear the ethmoids and the child becomes all right. I don't like steroids in orbital inflammation at all. I am very scared because 2 doctors in our institution had this. So even if you have to give a conservative course, give conservative course of antibiotics. If the swelling increases, we might blame the antibiotic, that the steroid, that may not be the cause. I don't give steroids in orbital inflammatory agents.
Yeah, we will have the discussion at tea coffee. So next lecture, please.
Yeah, next speaker is, thank you, Madam, Dr. Nidhi.
Thank you, Madam.
Next speaker is Dr. Surinder Kumar Singhal.
He is going to talk about inverted papilloma changing trends.
पता नहीं चला था क्या भाई
Good afternoon, respected chairman and friends in the audience. I'll be presenting inverted papilloma changing trends. Ever since I joined my residency in 1988, since then there are a lot of changes in the surgical management, etiology, pathology, and nomenclature. So I'll be discussing briefly them and a brief experience what we have done in our institute. So as you know, it's a commonest tumor of nose and paranasal sinuses, constituting 5 to 7% of all tumors of paranasal sinuses. It has an aggressive growth. It has a great invasive potential, high multicentricity, and high recurrence rate. And there is a chance of malignancy also in 5 to 15% of the cases. If you go in the history, Wald was in 54 described this papilloma as Snyder papilloma in honor of C. Victor, who was a great scientist who first demonstrated that nasal cavity produces only catarrh, not CSF. Before that, that was a convention. And after that, it was Bill Roth in 1955 who said that described this papilloma as the nasal cavity and termed it as a villiform cancer. And Kramer and Sohm, they described it as a genuine papilloma and differentiated it from the normal inflammatory polyp. Ringertz first described the tendency to invaginate into the underlying stroma and metaplastic transformation from columnar to squamous epithelium. Brandeis in 1966 marked it as a malignant mass, and later on, Hayam's 1970 classified into inverted papilloma, fungiform papilloma, and cylindrical papilloma. But Saki in 1987 used the term Schneiderian papilloma for this tumor. Since the description of this lesion in 1854, there are a lot of changes not only in the management but also in the nomenclature of this lesion. There is no tumor in the body who has such synonymous. At least 54 synonymous has been mentioned for this tumor. Here are a few which have been mentioned here. The designation inverted Schneiderian papilloma is suggested as an appropriate title that best conveys qualities of inversion, location, distinctiveness of diameter, the character, and characteristic microscopic feature in terms of increase in thickness of the covering epithelium and invasion of the hyperplastic epithelium. As I said, incidence varies from 0.5 to 7% of sinonasal tumors. 5th to 6th decade is affected. Few reports are there in the children. White persons are more at risk compared to the persons with other races. Since the beginning, the exact etiology is still not known. Most of the time, people used to say that the Schneiderian membrane which lines the sinusoidal tract is exposed to certain irritants in the form of chronic sinusitis, exposure to toxic substances or allergic processes, which results into these changes. And the most recent is the viral theory, which has been implicated in the etiology of inverted papilloma. Epstein-Barr virus and human papilloma virus of subtype 6 and 11 are most incriminated. 16 and 18 are associated with malignant change. HPV is associated in 14% of all inverted papilloma and 100% of all exophytic papilloma. The main studies and meta-analysis of recent years show HPV rates varying between 17 to 38% with range of 0 to 70% in individual series. HPV seems significantly more frequent in IP, showing severe dysplasia or associated carcinoma than in inverted papilloma alone. Symptoms. Generally, these are diagnosed 1 to 4 years after the first onset of the symptoms, and few lesions are diagnosed incidentally in the tune of 4 to 23% of patients. The main symptoms are unilateral obstruction, rhinorrhea, epistaxis, anosmia, headache, and facial pain. The examination reveals a unilateral polypoidal reddish gray lobulated tumor, more firm than inflammatory polyp, and on palpation is friable, often bleeds when touched. It may protrude outside the vestibule or may extend to the nasopharynx. The nasal septum is often pushed to the contralateral side and may cause proptosis and facial swelling also. The diagnosis is on the basis of history, nasal endoscopy, imaging studies in the form of CT and MRI, and biopsy. Nasal endoscopy has a pivotal role in the treatment and management of inverted papilloma. It serves as a diagnostic tool, and it can tell you the site of origin of the tumor in small tumors, and it helps in taking the biopsy also. We have to be careful while taking the biopsy because sometimes an inflammatory polyp may be lying anterior to the actual lesion, and if you take the biopsy from that area, a false negative report may come. And then it helps in treatment of the tumor also with endoscopes. Imaging studies. Preoperative radiographic assessment of inverted papilloma plays an important role in determining extension of the disease and involvement of adjacent structures. And remember, in our time, conventional radiography was done, which in the form of X-ray paranasal sciences, which used to show just opacity in the nasal cavity and served no purpose. Now with the CT, you can see area of the involvement. Then you can see the attachment of the tumor or the site of origin in the form of focal hyperostosis, which can be cone-shaped, and it can be a plaque-like hyperostosis, which may or may not indicate tumor origin. There may be bone destruction, but bone destruction alone may not be an indication of malignancy. However, it is sometimes difficult to differentiate inspissated mucus, mucoperiosteal thickening, and simple polypi on CT scan. This is a coronal CT scan which reveals a large tumor on the right side of complete opacification of the nasal cavity, and you can see the destruction of the middle turbinate in the picture. Then another tumor which has a lobulated appearance going into the maxillary sinus and pushing the septum and causing a pressure necrosis of the septum also. Then you have another picture of the tumor filling the nasal cavity as well as in the ethmoid area, and this is an MRI picture which is showing the tumor itself. Inverted papilloma have heterogeneous appearance on MRI. On T1 weighted images, it appears slightly hyperintense to muscle. On T2, it appears intermediate signal intensity. Inflammatory polyp and inspissated material, they appear hyperintense on T2 weighted images. A convoluted scribbliform pattern or CCP on T2 and enhanced T1 weighted MRIs is distinctive in 80% of the cases. Recently, this appearance, that is CCP, has been named differently by different authors in the form cerebriform, striated, or gyriform, or columnar. MRI distinguishes the lesion from inflammatory secretions, inspissated mucus, simple polyposis, and it can better delineate in contrast to the surrounding soft tissue. This is an example of difference of CT and MRI. You can see in the CT scan, the maxillary sinus is opaque, which may tell you that it might be a tumor, but in MRI, it is clear. So tumor is localized to the nasal cavity only, and you can see the CCP very clearly in this. There is no evidence to suggest that PET scan should be used in the diagnosis of inverted papilloma. However, in recurrent cases or in cases where you suspect malignant change, you can use PET scan. Pathology, it originates from a wide base, irregular wide base, and it is irregular, friable, and bleeds easily. There are 3 subtypes. Inverted papilloma, then endophytic, arises from the lateral wall. Fungiform papilloma, which is exophytic and arises from the septum. And cylindrical papilloma, which is rare and is oncocytic papilloma. Microscopic appearance, it is a thick squamous epithelium and less frequently respiratory epithelium arranged in papillary fronts with exophytic type of growth. In inverted, it is thickened squamous epithelium admixed with mucocytes and intraepithelial mucocytes. And oncocytic is composed of multi-layered epithelium with eosinophilic cytoplasm along with intraepithelial lesions. This is a microscopic picture which is typical infolding of the mucous membrane in the underlying stroma. There are various staging systems suggested for inverted papilloma, and Krauss staging is the most commonly used, and it is according to the tumor extent. T1, tumor limited to the nasal cavity with no extension, no malignant change. Tumor type 2, Krauss staging, which is limited to the nasal cavity and medial wall of the maxillary sinus. And in type 3, it is extending to all walls of the maxillary sinus and frontal sinus, sphenoid. There must not be any concurrent malignancy. In stage 4, all tumors with any extranasal or extrasinus extension to involve adjacent contiguous structure such as orbit, intracranial compartment, or pterygomaxillary space, and there may be malignancy also associated. Treatment, medical treatment is only reserved for associated sinusitis. If there is, so medical treatment should be given. Otherwise, surgery is the mainstay of treatment, and radiotherapy in those cases where you find malignant change in the biopsy, which comes later on. The goal of surgical treatment is to allow sufficient exposure for complete resection of the tumor. It should allow unobstructed view of postoperative surveillance of the cavity, and it should minimize cosmetic deformities and functional disabilities. There were closed approaches in the times when we started. That is, intranasal polypectomy used to be done, and that came with a lot of recurrence. Then other procedure, open procedure came, Cardwell-Luck, Dankers, lateral rhinotomy, mid-facial, degloving, and Weber-Ferguson. But nowadays, I don't think anybody is doing these procedures. Open approaches, the disadvantages are postoperative morbidity, numbness of the upper lip, hypoesthesia of the cheek, functional disturbances, epiphora, and blindness in some cases. Stamberger, 1981, was the first person to use endoscope for treatment of inverted papilloma, and later on, numerous authors reported the success of endoscopic treatment. More than 3,000 cases have been treated with endoscope till now, and the recent literature now supports that piecemeal debulking of the tumor and now identify the site of attachment, remove it subperiostally, and drill the underlying bone to avoid any recurrence. Different endoscopic surgical strategies can be used with reported success tailored to the extent of the disease. Total sphenoethmoidectomy, wide metotomy, resection of the middle turbinate, visualization of frontal sinus, endoscopic medial maxillectomy standard, modified endoscopic medial maxillectomy, and the endonasal endoscopic resection, which is origin-based. You define the origin of the tumor with the help of shaver and take out all the mucosa and then drill that bone, and that's enough. The advantages are better illumination, better view with state and angle endoscope, better instrumentation, shaver, intranasal drill, and coagulation, and better hemostasis. And all these can result into decreased recurrence rate. The various studies were quoted for recurrence, and all the procedures which were done before the advent of the endoscopy, they are thought with so much 40 to 80%, 50 to 60%, and even modified medial maxillectomy counted for 0 to 30% of the recurrence rate. Endoscopic approach have only 0 to 18% of the recurrence rates. These are few series before 1995 and before 2002, which were saying the recurrence rates are too much. There is a meta-analysis of 156 patients, postoperative follow-up 3 to 11 years. The recurrence was 19 cases, and in endoscopic sinus surgery group, it was 9.9%, and with nasal endoscopy combined with traditional, it was 12.12%. So another meta-analysis, 2,451 patients, endoscopy group, 1526 patients, and recurrence was only in 212 patients. And open 592 patients, 111 recurrence. So you can see that comparatively the rate of recurrence is less in case of endoscopy. The most common site is lateral wall, nasal wall and middle meatus, frontonasal duct area, supraorbital ethmoidal cells, and region of the lacrimal fossa for recurrence. How can you minimize recurrence? Careful assessment with nasal endoscopy, CT scan, MRI, good hemostasis, use of debrider and drill, navigation system, and intraoperative CT scan if you can afford it. There can be chances of malignancy in 5 to 10% of the cases. 3 types: squamous cell adenocarcinoma and small cell carcinoma, and it will require further therapy in the form of radiotherapy or chemotherapy. Long-term follow-up is required in these cases. And a few slides about our experience. We 2000 to 2022, 66 patient, age range 42 to 79 years, and 66 cases were there. Males were 48, females 18. And nasal obstruction, nasal discharge, nasal bleeding was the most common symptoms. Diagnostic endoscopy, biopsy and imaging studies were done as per routine. CT scan, initially we used to do 3 mm. Later on we started doing 1 mm thick scan, axial, coronal, sagittal planes. MRI was done. These are the scans of patient preoperatively. Another patient with lobulated tumor. Another patient with a nasal mass. Another patient nasal mass and maxillary sinus. And you can see the MRI, CCP pattern. These were the staging according to Krauss staging system. So in a luster, this is the mass and this is the bone. And you can see that when you operate, you can see that whole of the tumor can be removed like this. The final cavity can like this. So these were the tumors. If you want, I can play the video. It is an endoscopic medial maxillectomy. If the time doesn't permit, I'll skip it. This is the 6-month follow-up. This is the 4-year follow-up. Another patient. Another patient. And you can see this was the patient revolving frontal sinuses, and all of these has been removed. This is the postoperative scan on this side. Again, same patient. Another patient, postoperative photographs. This is the post-op nasal endoscopy. It's a well-healed cavity 4 years later on. So these are the results. We had 6 cases of recurrence, 4 with malignancy, and they were given radiotherapy. So take home message: IP is a benign but aggressive tumor. Read the CT scan and MRI thoroughly. Remove the disease completely. Drill the underlying bone or remove from the site of the origin. Watch for any dysplasia or malignant change in the biopsy and do a regular follow-up. Thank you very much.
Thank you. Thank you very much. We do not have time for the questions. May I tell my colleague to invite the next speaker, please?
I would like to invite Dr. Rajesh Yadav as the next speaker. His topic is TMJ and its disorders, ENT surgeon's perspective.
Thank you.
Video check करने आएगी ना आएगा ना. Okay, good afternoon, everybody. My talk is on injection laryngoplasty. Before I start, I think voice is one thing which is helping us communicate today, which in today's time, more than ever, I think it makes the personality of a person. So that is why most of us recognize Amitabh Bachchan, Lata Mangeshkar. I don't know how they would be recognized if they didn't have the voices they had. So a patient who loses his voice, loses his daily routine or his life, and that is something which needs to be corrected as early as possible. And when these patients come to us as ENT surgeons and you advise them something which makes them get admitted, go to the operating room, we tell them that they need to undergo general anesthesia, this is what happens. They want to run away. So here is a procedure which can be done in the outpatient department. Patient does not need to get general anesthesia. Patient can go home the same day. and he gets a better quality of voice. So these procedures are done in cases of glottal incompetence, as we all know, and all these patients have a weak breathy voice. The most common indication is paralysis of unilateral vocal fold, and this procedure was started by Brunings in 1911. Many materials have been used over these past years, the past decades, ranging from bone dust to gel foam to bovine collagen, and presently the most common materials which I use are hydroxylapatite and hyaluronic acid. So what is an ideal material which we can use to inject? An ideal material should be bioinert. It should be easily available. It should be cost effective. It should not cause any foreign body reaction. And we should be able to inject and give a good result to the patient. So many materials are used. Some are short-term, some are long-term. The problem is what is available. So why do we do this procedure? We do these procedures in patients with unilateral vocal fold paralysis. Paresis too. We have even done injections in vocal fold scars, presbylarynx, and Parkinsonism. So if coming to the contraindications, there are no absolute contraindications. It can be done in most of the patients. The only thing which we need to take care of, patient should not be allergic to many drugs. Then you should be careful. Patient should not be on any anticoagulants. Patient should not be very apprehensive. He should be a patient who will undergo a procedure under local anesthesia readily. Where should you not inject? Patients which have a large glottic gap, where you know that the medialization will not be adequate and you need a thyroplasty, where there is a wide posterior glottic gap, and where there is a irreversible etiology, because injection procedures are temporary. These materials fade off in due course of time. Whatever material you use, that has a lifespan, so you should know that in irreversible etiologies, either you explain to the patient or you go ahead and do thyroplasty. So clinical situations where injection laryngoplasty is considered advantageous, again, are small glottic gaps, patients which are unfit for GA, who have long-term illnesses, patients where you will not be able to extend the neck and the patient can undergo a procedure, where there is a possibility of full functional recovery, and where you have done a previous laryngeal framework surgery, but you need some fine-tuning, and you can inject the material in such cases too. Complications: if you do the procedure taking care of all the precautions, then usually there are no complications. But yeah, the known complications would be bleeding, infection, pain, hematoma formation, airway obstruction, laryngospasm, and an allergic reaction to the material you're using. So, like I said, patient selection is very important. When you choose a patient where injection is to be given, you have to explain what you're going to do to the patient, how the procedure is going to be done, so that the patient is prepared, ready, that this is a local procedure. Patient either needs to be sitting or lying down. Patient should not have a lot of comorbidities, should not be on blood thinners. Adequate nasal patency and a good oral opening should be there. This is what we use. We use a flexible laryngoscope and a monitor to visualize what we are doing. We need a team of laryngologists, actually, a person who is a navigator who uses the flexible scope and guides us where the injection needle should go, a trained technician who's helping us out with all this, good local anesthetic, and the injection material with the needle. So I think a good procedure here happens only when you give good local anesthesia. At our center, the first thing which we do is we inject the skin with 2% xylocaine, the site where we are going to inject. We give it intratracheal block. That takes care of most of the anesthesia. We spray the nasal cavity with 10%, the oral cavity with 10%. And after we put in the scope, we spray a little bit of the local anesthetic through the scope also over the larynx. So emergency tray should always be there in case airway obstruction or laryngospasm occurs, you should be prepared. So this is the normal spatial orientation with patient sitting and the two laryngologists in front of the patient. So many approaches have been documented, the transoral approach and the transcutaneous approach. The transcutaneous is the favorite or the easiest to perform. In the transoral, you're putting the scope through the nose, and through the oral cavity, you introduce the needle and inject. In the transcutaneous, again, 3 methods can be used. You can go through the cricothyroid membrane, through the thyroid cartilage, as well as from the thyroid membrane. So when we are injecting, the most important thing which needs to be taken care of is that when you inject, it should be in the paraglottic space and not in the thyroarytenoid muscle. So the procedure can be performed seated or in the supine procedure, or in the supine position. I'll be showing a video of both. So these are few of the materials which have been used or have been used in India. Agarose we've used initially in many of our patients, which is not available now. Radius is not available. The only material which is available now is Restylane, that is hyaluronic acid. This was the company which we were using previously, which is now not available. So this is a small clip which shows us how this is done. So we generally use the cricothyroid puncture at our center. So you palpate, after giving a good local anesthesia, you palpate the cricothyroid membrane, and you go a little paramedian on the opposite side. If you have to inject the left cord, you will go a little paramedian on the right side, and then keeping the needle under view, you start injecting. So this is our center that we're doing this procedure, and this is the pre-filled injection with the needle. After a good surface marking, as you can see, I'm infiltrating the skin, and then I will give the intratracheal block. The patient coughs a little bit. We inject 1 ml into the trachea, and that actually helps spread the local anesthetic. And this is the hyaluronic acid, which is pre-filled in a syringe. We are using a 23 gauge lumbar puncture needle. We generally use this lumbar puncture needle at our center. And as you can see, Dr. Ramalingam is holding the scope. And after palpating, this patient has a left vocal cord palsy. So I will go paramedian from the right side. You can see the needle which is coming out in the subglottic area. And then you direct the needle to the area where you want to inject. You can now see that the needle is being introduced. This is the laryngoscopic picture. So you introduce the needle and take it deep into the paraglottic space, and that's when you start injecting. It should be very slow, and if you're in the right place, you will be able to see the medialization happening. This video, you'll be able to see that the medialization is happening. As you see, the closure will happen. As we inject, the closure will happen. So sometimes we need to inject at multiple places, and so we take the needle a little out and then reintroduce the needle and then inject again. It depends on which area you require the maximum medialization. So this is a patient where we are in, sorry, this is the same one. So here we are injecting with the patient in the supine position. So you can even do that. It's the same procedure. This patient could not sit up for a very long time, so we are doing the procedure in the supine position. So again, the laryngoscopic picture. So there are two other ways which we have tried at our center, but we generally prefer the cricothyroid membrane. Here we are going through the thyroid membrane. So what we have done here is that we have taken a 23 gauge lumbar puncture needle and we have bent it twice, 1 mm from the tip and then 1 mm from the bent side. So it has a double curve like this. And then I am introducing it through the deepest part of the thyroid notch. So once you see the needle inside, which you'll be able to, then it's very easy. You can direct it to whichever side you want to, because it's in the midline. Another way it can be done is through the scope, we can introduce the needle and inject. The only problem with this method is that a lot of material will get wasted in your needle, which will be very long. So at our center, we've done almost 53 cases. Out of these, 35 have been with Restylane, and we just did a case study, and we see how much the improvement these patients had. And we did a VHI as well as acoustic analysis of all these patients. Most of these patients fell in the age group of 51 to 60, and most of these patients were male. And we get a variety of patients. Many patients are post-CABG, some are idiopathic, some are post-CA with metastasis, with vocal fold paralysis, post-stroke. But the most common will be post-CABG. And most of these patients had left vocal cord paralysis. And post-injection, the VHI improved, and there was a marked improvement in the acoustic analysis of most of these patients. So I'm just showing you a few clips. This was the technical improvement. Now this is the actual improvement in patients. So this gentleman is a teacher in his country. No voice. Oh. It's not going there. It's not going there. So, just a few videos. This gentleman is a...
And I have come here at the Bill
He's
K
a
Hospital
governor
for
in
treatment.
Nigeria, and he didn't want a procedure. He didn't want a surgery.
My name is Derito Gashagwa, and I came to BL.
She again is a teacher in her country.
My name is Florence Wamahiga Kidudu. My name is Florence Wamahiga
So
Kidudu.
voice is harsh here because the material takes time to spread. So after a week or so, the voice quality really improves. He's the governor of Nagaland.
I'm Sarozele Lesitu from...
He had idiopathic idiopathic unilateral vocal fold paralysis, and he didn't want a surgery.
My name is Sarozele. I come from Nagaland.
This gentleman is very old, and he had unilateral vocal fold paralysis. And he said, at this age, I can't undergo a surgery. I want to talk to my kids who live in the US. And
मेरा नाम आरएस गंगवानी है मैं गुड़गांव
he
से
has
है
got an injection twice now. He has a skull-based tumor.
मेरा नाम अशोक जैन है
So all these patients don't want a surgery. They want improvement in their voice, but no surgery.
मैं अशोक कुमार जैन
This lady again had idiopathic paralysis.
For my treatment.
This is post-injection.
मेरा नाम कल्पना है.
She was that happy that she actually wanted to sing for us.
ये समा.
This lady, we did in a workshop, and
मेरा नाम सरला देवी है. मेरा नाम सरला देवी से मेरे ऑपरेशन के बाद.
she had a thyroid surgery following which she lost her voice. Okay. I'm actually done. So these are just videos of patients. So I'm going to skip the next few. I'll just share this one. You can't hear his voice, yeah.
मेरा नाम अनुभव है अभी हमको इंजेक्शन
So I'm just going to finish my talk saying that this is a very safe, simple, easy procedure which can be done in the OPD, and it can really change or give a good quality voice to our patients. And this is just what I wanted to talk about today. Thank you so much.
Excellent presentation, Dr. Neha. I'd like to ask one question. For how long this result last?
So
Or you have to repeat the injections, and after how much
So
of interval?
hyaluronic acid lasts for approximately 3 to 4 months. So different materials have different half-lives. So hyaluronic acid will last for, in some patients, 3 months, some patients 4 months. That old gentleman which you saw is now coming for the third time to us, because after 4 months again it goes down.
And how much you charge every time?
The material costs approximately 18,000 rupees.
Okay.
So there you want to be cost effective, but the problem is then fat can be used, but then you have to take the patient under general anesthesia.
Yes.
And then inject. So that lasts long. That doesn't cost, but patient has to undergo anesthesia.
Yeah, okay. We'll go ahead. We are short of time because we'll go ahead for the Dr.
He will have a result. What we do is first we push saline. We put a saline first, convince the patient how you will have this result, and then we go ahead.
Yeah, Dr. Rajesh Yadav, you can continue.
Hope this works this time.
I would like to call at the chairperson to felicitate, one of the chairperson to felicitate Nishi ma'am. Please, sir. Please see you on the dais.
अच्छा
पीछे 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 नहीं नहीं
पूरा खोलो और गोला करो 10 बार करो 10 बार एक बार भी
Okay. So I'm Dr. Rajesh Yadav, and I'm from Mumbai. So there is a proverb, love thy neighbor. You know, we ENT surgeon don't follow it religiously. In fact, TM joint, being our neighbor, we neglect it royally. So this is the reason. In fact, the 30% of our OPD patient is TMJ, and we are not aware of that. So I'm trying to make it as easy as possible for all of you. So let's know the anatomy of TMJ. This is a condyle, this is a glenoid fossa, and in between lies the articular disc. This disc is divided into 3 parts. This is anterior band, this is intermediate zone, and this is posterior band. This is continuous with lateral pterygoid muscle, and this is continuous with retrotescal tissue. Now, this part has no nerve endings, while other parts have lots of nerve endings. This is how a TMJ look in a normal human being. Okay, this is the disc, this is the biconcave area, this is the anterior band, this is the posterior band, retrodiscal tissue. So biomechanics of normal TMJ, the posterior band lies at 12 o'clock position, the intermediate zone lies at 1 o'clock position. Sorry. Okay. नहीं मुझे उसका वीडियो ओके मुझे आदत नहीं है ना इसका ओके ठीक है So the first 20 degree of mouth opening occurs in a glenoid fossa itself. For the further mouth opening, this condyle has to come forward at the articular eminence. Okay, this is like this. क्यों नहीं जा रहा है आगे? ऐसे कर दो, चलेगा. चलेगा, मुझे कोई problem नहीं. So the first 20 degree occurs in a lower compartment, which is called rotational movement, and the later stage of mouth opening is called gliding or translation movements. Okay, so there are various ligaments which, there is a lateral ligaments. It's divided into oblique and transverse. This oblique ligament, it limits the 20 degree of condylar rotation, and transverse, it prevents over retraction. So there are lots of TMJ disorders. So the most common disorders I'm going to cover, which comes to our casualty, is jaw dislocation. So what exactly occurs in jaw dislocation is the condyle come forward to the articular eminence and it stays there. So there are types of jaw dislocation. There is an anterior jaw dislocation. Then there is a posterior jaw dislocation. There is a superior jaw dislocation. So what happens in a jaw dislocation is that the patient will have an inability to close mouth. There will be pain, emptiness, and malocclusion. So this is exactly what happens. Since the condyle has come forward, there will be a deviation on the opposite side, and there will be a malocclusion on the same side. Okay, there are various reduction methods. So the most common reduction method is our Hippocrates methods. What we do is we put a pressure downward and backward, and we reduce the. We normally do this. There are many other methods. Okay, there is something called wrist period method. In this, we keep a wrist on a chin and the fingers on the molars and give a pressure upward. Then an interdental block, you put a block in between the two teeth and give a pressure on the chin. All this procedure, there can be chances that your finger can be bitten. So we have, there is something called syringe technique. So the syringe is placed in between upper and a lower molar. The patient is asked to bite the syringe and roll. This syringe will roll back and forward. This syringe will act as a fulcrum. As the molar rolls over the syringe, the mandible condyles glides posteriorly. Boss. So we put a syringe and ask the patient to glide. And it goes back. So after care, you need to give a support to the chin while yawning, use of a circular fixation for first 24 hours, and limit mouth opening. What after that? After that, we are an ENT surgeon. We have to fix this. This is not the end of it. So there are various procedures which has been mentioned in a literature. We can do arthroscopic procedures like amnoplasties, lateral thyroid myotomies, muscle procedures like Botox injection. The most common things which we do is amnectomy. So what we do in an amnectomy is, since there is an eminence over here, we remove this eminence. So the dislocation is gonna happen, but it's gonna come back to the glenoid fossa. And there will be a free way. So let's see the surgery. Preauricular incision is taken. We'll find a superficial temporal vessel. This is the superficial temporal vessel. This is a temporalis fascia. We are palpating it for a base of zygoma, and we take a oblique incision on the temporalis fascia. So we are taking this oblique incision on the temporalis fascia. This is the articular eminence. Okay. So we have to remove this much part.
फिर से बंद करो
Patient is in a local.
अटक रहा है, पता है बेटा अटक रहा है. Okay.
हाँ बेटा. If the patient is having a problem or not. So we are drilling the articular eminence over here.
बंद करो, खोलो, बंद करो, खोलो,
Still the patient is
बंद
having
करो,
a problem.
पूरा खोलो और खोला करो, 10 बार करो, 10 बार.
एक बार भी ब्लॉक हो गया मुझे देखना.
हाँ.
करो
खोलो, बंद करो. हाँ,
बंद करो. नहीं अटकेगा, कभी नहीं अटकेगा, वही तो कर रहे हैं.
करो, करो. बंद करो. हाँ, बंद करो.
अटक गया
खोलो बंद करो. हाँ खोलो बंद करो. खोलो बंद करो. अटक रहा है अभी. नहीं ना. खोलो बंद करो. बंद करो. नहीं खोलो बंद करो.
थोड़ा अटकेगा लेकिन वापस आ जाएगा फटाक.
खोलो पूरा खोलो बंद करो अभी बेहतर लग रहा है पहले से खोलो एकदम अच्छा कुछ अटक नहीं रहा है
बंद करो अभी.
So on a table itself we can get a result.
बंद करो, खोलो.
अटकने वाले से
So this is a testimonial from the patient itself.
ट्रीटमेंट जारी था जब मेरे साथ फर्स्ट टाइम ये माउथ स्ट्रक की प्रॉब्लम हुई थी. उसके बाद
This small surgery can change the life of the patient.
मेरा एक छोटा सा एक्सीडेंट हुआ था जिसमें मुझे राइट साइड फेस पे चोट लगी थी, जिसके बाद से ही मुझे खाने पीने में काफ़ी दिक्कत होने लगी. माउथ ओपन और क्लोज करते वक्त दर्द और टंग ऐसी वॉइस आनी शुरू हुई. मैं कोई भी ऐसी चीज़ नहीं खा पाती थी जिसमें मुझे माउथ ज़्यादा ओपन करना पड़े. पानी पूरी खाना मैंने ऑलमोस्ट छोड़ दिया था. ऑपरेशन के बाद जो है मुझे कोई दर्द नहीं महसूस हो रहा, कोई वॉइस नहीं आ रही और मैं काफ़ी इजीली पानी पूरी अब खा सकती हूँ. इनफैक्ट मैं वो सारी चीज़ें खा सकती हूँ जो मुझे ज़्यादा माउथ ओपन करके खाना पड़ता था. और मुझे उस वक्त टेंशन होती थी कि मैं अगर खाऊंगी तो मेरा माउथ जो है वो स्टक हो जाएगा. पूरे 7 साल बाद जो है मैंने पानी पूरी फाइनली खा मेरा रूट कैनल का.
And she sends this video to us. पानी पूरी नहीं भेजा पर वीडियो भेजा. Okay. So this is a very simple procedure. We all can do it. It doesn't require a rocket science. This is a very, so we should, ENT surgeons should indulge in this. The another, this we are gonna talk about is this displacement. What occurs in this displacement? So you see this has displaced anteriorly and a retrodiscal tissue comes between the this has highly nerve endings. So whenever the moments occur, there will be a pain. Okay. As the disease progresses, you know, there will be a rubbing, there will be a swelling over here. And so because of this rubbing, there can be a click sound, which we hear normally. And when this joint repeatedly rubs over the disc, there will be a swelling. And because of the swelling, there will be a lock. So there is something called Wilkie's system. So stage 1, 2 is reducible disc displacement. Stage 3, 4 is this cannot be reduced, and stage 5 there will be a perforation. Okay, so in stage 1 and 2 there will be a click sound. In stage 2 there will be a pain. In stage 3 there will be a multiple episodes of pain, locking of joint, tenderness, restriction of movement, and in stage 5 there will be a total functional impairment. There is a dictum: a licking joint, a clicking joint don't lock, and a locking joint don't click. So you can So treatment is, you have to go for a conservative treatment. Okay, 80% of patient with conservative treatment, they get better. So we have to give a patient education, medical management by NSAIDs, muscle relaxation, steroids, physical exercise like isometric jaw exercise, TENS, dental rehabilitation. This is very much important. You have to give a splint, you have to take a help of your dental colleagues, and what does it? Does it unloads the joint, it increases the joint space, reduce the inflammation, increase the free jaw movement, and decrease the muscular activities. So there are so much options available for surgeries. Most commonly, just by doing a simple arthrosynthesis, 90% of the patient improves. And you should know how to do a arthrosynthesis. Okay, I'll show you the video of that. So we plot a line from a midpoint of a tragus to the lateral canthus of orbit. A line is
हाँ इसमें ना वीडियो में फिर वो आएगा ठीक है
There is a point A and point B. Okay, point A is point 1 centimeter and 0.2 mm below the line. And point B is 0.1 centimeter from point A and 1 centimeter from the line. You inject you put a needle there.
आया ब्लड फिर से
Okay, you put a needle there.
चलेगा देख
And if you're in the right place, if you give a wash,
नहीं ठीक है दे सिरिंज दे
the fluid is going to come out from the other needle. These are the drugs which we can give intraarticularly by arthrosynthesis. Okay, this is a video of a scopy arthrosynthesis.
Sorry, Doc, you're exceeding time. Please.
Okay, fine. This is a video of, if you want, I'll play. Otherwise, how to do a arthroscopy TM joint. Up to you. So this is, I'll show you the final picture, what we see through the arthroscopy. Lateral pterygoid shadow, intermediate zone, anterior recess, and other structures can see. So only take off messages. Please take TMJ very seriously. This is the domain of ENT surgeon. We should indulge into it. Thank you very much.
Thank you. Thank you. Sorry. We are overshooting with the time, please. No questions. You can chat with him in the tea time, please. Yeah.
I would like to invite the chairpersons to felicitate our speakers. Dr. Surinder Kumar, Dr. Rajesh Yadav. Dr. Neha Sood. I would like to invite all the faculty, which are speakers, to come on the dais for a group photo. Rajesh sir, for a group photo. Dr. Surinder. I would like to invite Dr. Surinder to felicitate our chairpersons. So with this, we come to the last session of the day. For that, I invite the chairpersons, Dr. Sanjay Sahi and Dr. Atul. Dr. Atul Vaikole. Dr. Atul Vaikole, sir. नहीं डाला, किसी ने नहीं डाला, पक्की बात है. As the first speaker, I would like to invite Dr. Umesh.
Yes, Dr. Umesh.
Yeah, good evening. First of all, I am most thankful to the organizers for inviting me to give my experience, share my experience over here. Good evening, chairpersons and my dear friends. My topic of presentation is recurrent deep neck space abscess, the diagnostic dilemma. This is actually a retrospective study over the last 30 years. This is a case, IT man, Mr. Akshay, a 25-year-old male, presented with left, to whom I have performed incision and drainage on 8th of April 22. There is a past history of similar illness at the age of 3 years, whereby incision and drainage IND has been done by myself. So he was symptom-free for last 22 years, over 22 years. The question struck to my mind, why he is developing this kind of abscess at the same site? So this is Akshay. So in past 30 years, I came across 6 of this kind of cases. 3-year-old Miss Surya, to whom I have done incision drainage 5 times, virtually every yearly, and 6th time at the age of 16 years. Since then, she is asymptomatic since last almost about 12 years, and she is being an IT person. She is settled in Cologne, Germany. A 22 years pregnant lady, Minal, on the first, when she was 6 months amenorrheic, I have done incision and drainage. I have to repeat it virtually every yearly for 3 times. A very, very unpleasant person, and I lost the follow-up. 9-year-old Manasi, to whom I have done incision and drainage virtually yearly for 4 times. Being a daughter of a RTO, she has been referred to a higher center to Mumbai, the ENT surgeon from Mumbai has referred her to the pulmonologist, where she has been thoroughly evaluated, and all kinds of investigation has been repeated, and then she, on empirical ground, nothing has been come positive, and then she has been treated with the anticox treatment on empirical ground. Again, after 6 months, she came with a 5th time with the same kind of abscess. A 4-year-old Saif, to whom I have done incision drainage after 2 times at the interval of 8 months, I lost the follow of this child. Pratik is the last case which I have done almost about 9 months. So far as he is a symptomatic child. Akshay has already been dealt with. So though my provisional diagnosis is suppurative lymphadenopathy, maybe a pyogenic or tubercular, or maybe a hematogenous spread of infection in the deep neck space, as if you are seeing in any of the immunocompromises to host. What else? So accordingly, we have done all kinds of investigation in these cases. That includes the routine blood investigation, ESR, MON2 test, TB PCR, TB IGRA, that is interferon gamma release assay, high resolution sonography, contrast enhancing CT scan neck, X-ray chest, pulse for gram stains, ZN stain, routine and AB culture, abscess wall for histopathology, evaluation for immunodeficiencies if any. And in recent cases, we are also introducing gadolinium contrast MRI in these cases. But all these tests remain unanswered. We could not able to reach to the conclusion why the patient has developing a recurrent deep neck space infection, the left paramedian or left medial supraclavicular space. So this Manasi, on 5th incision and drainage, she came for the sequential follow-up for dressings. She told that she has got a tea-like content which is dribbling to the incision site. So this made my suspicion of a pharyngo or esophagocutaneous fistula. So this is the barium study, where you can see extravasation of the barium in the deep neck space. Here you can see the extravasation into the cutaneous area also. Here in an empty stage, still you are getting a extravasation of the barium. Here also you can see the pyriform sinus which is dribbling down. This is a sinus tract which is coming right down. This is again a barium filled stage where you get a sinus tract here. And then in empty stage, you can see extravasation into the skin. In a lateral tomograph, you can see the same kind of situation with the extravasation of the barium in the lateral, deep neck space. A sonography, that high resolution sonography shows that there is a altered echogenicity on the left lobe of the thyroid. This is the left lobe of thyroid, right lobe, this is trachea, this is common carotid, this is internal jugular vein. And you can see a sinus tract which is just lateral to the lateral lobe of the thyroid, left lobe of the thyroid, and medial to the carotid artery. Here you can see it very clearly. Here you can see it very clearly. Here you can clearly mention this. You can clearly see this. A contrast enhancing CT scan, this is a plain study actually. This shows a breakdown area here with involvement of the left lobe of the thyroid. Here is a contrast study. Is the same picture which can be seen. On the lateral tomogram, you can see the breakdown area in the deep neck space. STAR protocol, that is fat suppression images, shows a gross enhancement of the fluid containing area of the deep neck space with a pneumatocyl here. In a heavily weighted T2 sequences and on a sagittal plane, you can see a tract which is, coming right lateral way. All these cases, after confirming, not all these cases, recent cases, after confirming about pharyngocutaneous fistula, has been subjected for upper GI endoscopy, but again, it came inconclusive. So the diagnosis that came in my mind is nothing but a congenital fourth branchial arch anomaly. So, the branchial apparatus is composed of arches that are separated by clefts on its external side and the pouches on the internal side. Both clefts and pouches develop into mature structures of the head and neck. In obliteration is incomplete, they may eventually develop cyst, sinuses, or fistula in later age. So this is the same diagram showing the endothelium from the endodermal side and the ectothelium from the ectodermal side. The structure which are derived from the branchial arches are thyroid, the laryngeal cartilage, that is thyroid, cricoid, corniculate, arytenoid, and cuneiform. Among the vessels, aortic arch and right subclavian artery. The muscles which are derived are cricothyroid, the levator palatini, all constrictors of the pharynx, and intrinsic musculature of the larynx. Apex of the pyriform sinuses, superior parathyroid gland, and among the nerves, vagus and superior laryngeal nerve. So the congenital fourth branchial arch anomaly is a rare entity. It comprises almost about 1 to 4%. The commonest being preauricular sinus, the microtia and anoxia, the branchial cyst and sinuses, type 1, type 2, type 3. Left side is affected in 96% of the cases. Why? I don't know. There is absolutely, it's deficient as far as literature is concerned. Often present as a recurrent medial supraclavicular deep neck space infection, need repeated incision drainage before reaching to the final diagnosis. Barium swallow, high resolution sonography, contrast enhancing CT scan, and T2, heavily weighted T2 MR with laryngoscopic evaluation that clinches the diagnosis. So here, this is the thyroid cartilage, cricothyroid membrane. This is the superior lobe of the, superior pole of the thyroid. Here you get an entry of the external branch of the superior laryngeal nerve. And here is the, this would be the area where you can get a cricothyroid joint. Here you get an entry of the recurrent laryngeal nerve. Therefore, the fourth branchial arch anomaly begins in the apex of the pyriform sinus, pierces the larynx near the cricothyroid ligament, and then passes between the superior and recurrent laryngeal nerve in the thyroid substance. So this would be the situation. Among the surgical management, the excision of the fistular tract along with the left hemithyroidectomy is the treatment of choice and to prevent the further recurrences. So this is the, we have to be more careful because the tissue is already fibrous and there is a lot of fragility there. So we have to be more meticulous about getting in the exposure. So this is the dissection being carried out here. This is the recurrent laryngeal nerve which is very vividly seen. And this thyroid gland, left thyroid lobe is being separated from the tracheal attachment, that is Bary's ligament. And the left lobe has already been removed along with the fistulous tract. So there are some intraoperative challenges that includes it has got a crowded anatomy associated with fibrosis and local fragility. There are chances of injury to the recurrent and external branch of the superior laryngeal nerve. Therefore, to summarize, fourth branchial arch anomaly is a rare entity, mainly occur on the left-hand side, presented with recurrent left medial supraclavicular deep neck space abscess, needs frequent drainage. Barium swallow findings are pathognomonic. Fistulous tract excision and left hemithyroidectomy is the gold standard. Thank you very much.
Thank you, Umesh, for this presentation. It was really very nice. And we have come to know that there is such type of anomaly we can face.
Thank you. I welcome Mr. Samir Deshmukh, who is going to give a talk on improving outcomes in ear surgery.
Everyone.
At the outset, congratulations, organizing team, and thank you, Nandu and Kaushal, for giving me the opportunity. Special thanks, dear friend Ritesh, for helping me out in this. Thank you so much. Today I'll be talking about improving outcomes in ear surgery. Actually, there's nothing new in whatever I'm going to speak today. But I feel sharing my views, sharing my experience of last 25 years will definitely help the budding ENT surgeons to improve their results in the ear surgery. So just to outline this, we are going to discuss out few things in which clinical assessment, treatment of comorbidities or underlying causes like tonsils, adenoids, and septal deviations, some allergies. There will be pre-operative investigations and planning, workup and consent for surgery, surgical protocols, guidelines and techniques, post-op protocols, and results and follow-up. Here I'll be discussing only about safe chronic suppurative otitis media. Because of the time constraint, it will be difficult to cover the unsafe CSOM. As everyone knows, patient comes to you with the ear discharge. There are different types of ear discharge, may be associated with URTIs, along with decreased hearing, sometimes otalgia, which is indicative of active stage, maybe otitis externa or along with fungus. And in CSOM with complications, patient may have headache, giddiness, or sometimes tinnitus too. So once you put the otoscope, you see a perforation along with a myringosclerosis or a tympanosclerosis. Always do the tuning fork test, which comprise of mainly Rennies and Webers, and confirm along with it. If the ear is not getting dried up in spite of your basic treatment, always do the swab, send the ear discharge for culture and sensitivity, find out which organism is responsible so that you can start specific antibiotics. Always get the pure tone audiometry, and it should be done by a qualified audiologist and not by an ENT surgeon, which will definitely bring you to the diagnosis whether it's a conductive hearing loss or a sensory neural, and which will help in deciding further plan. Why I mentioned it should be done by an audiologist and not by an ENT surgeon, I have come across a case where one patient was operated by an ENT surgeon, and the patient came to me with a residual perforation. Patient had severe sensory neural hearing loss, and there was no pre-operative audiometry done. And it was extremely difficult for me to convince the patient because it was just not possible to know whether the SN loss was pre-operative or post-operative. So pure tone audiometry is of immense importance. In selected cases, definitely get HRCT temporal bone done, particularly patient is having giddiness, tinnitus, or facial paresis. Secondary acquired cholesteatoma, hearing loss is more, or in revision cases too. But in normal, safe CSOM, HRCT can be avoided. You can get away without the HRCT. I always do a video endoscopy because it helps in preoperative documentation. It is easy to counsel the patient when the patient sees what is there, and sometimes otoscope doesn't give you clear view because of the narrow canal or the bony overhangs. Before treating or taking any decision to deal with the perforation, treat the comorbidities if at all. Age is very important. Because in pediatric cases, rule out tonsils and adenoids. In adults, even septal deviations, sinus infections, eustachian septum dysfunctions, or allergies. Then go ahead with the preoperative fitness and protocol. Once you confirm patient has a CSOM with a mild to moderate or severe conductive hearing loss, then you go decide the plan for surgery. Surgery will be either tympanoplasty or along with cortical mastoidectomy and or ossiculoplasties. So once you plan surgery, you have to counsel the patient. Always discuss the pros and cons of surgery. Don't give 100% guarantee, because few patients ask for 100% guarantee. My simple answer to them is, can you give me guarantee of your life in the next 4 hours, nothing is going to happen to you. That gives the very well signal and they accept. But of course, give them assurance that I'll be doing the best for you, and whatever it is, I'll give you solution. Always get a pre-operative GA fitness done for these patients, because sometimes even the patient is under local anesthesia, sometimes the BP may shoot up, patient may become anxious and hyper, you have to convert the patient under general anesthesia, so you should be prepared for that. See to that it's a dry ear, and before our surgery, I always prefer to give 5 to 7 days antibiotics and steroids and antihistamines. 1 day prior, head wash, proper shaving, and preparation. There is nothing new in this pre-surgery preparations. See to that your OT is fumigated well, instruments are autoclaved well, use a disposable microscope cover, and always follow the standard sterility protocol. Surgical approaches are variable, subject to surgeon's choice, either endoral, endomeatal, or postoral. I prefer either postoral or endoral approaches in most of the cases. As everyone knows, the grafting materials, we have temporalis fascia, fascia lata, tracheal cartilage, or perichondrium. But I have used all these three and come to this conclusion: temporalis fascia is by far a better choice than the fascia lata. Of course, if the temporalis fascia is not available, then think about fascia lata or the tracheal cartilage or perichondrium. So this short video I'll be playing where tympanoplasty with cortical mastectomy done. With the endomeatal approach, the tympanomeatal flap is being elevated. Once you enter the middle ear, you can see the ossicles. There was one tympanosclerotic plaque being removed. Once you confirm the ossicular mobility, and you are sure there is nothing else in the middle ear, open the eye. Particularly when I come across granulations or glue in the middle ear, I always open the mastoid antrum and look for the iritis patency. Only those very limited cases when the ear is absolutely dry, sometimes I may get away without opening the antrum. But it always gives me a good feeling that the mastoid antrum is, the iritis is patent and there is no disease in it. Somehow it gives good results. Then the graft is, temporalis fascia graft is placed, always underlay. I use an underlay technique. The specification and how the graft is placed, I'll be discussing in the next slides. So once the graft is placed, see to that it has been covering the perforation adequately. This is the second video where I had to do an ossiculoplasty where I use the tracheal cartilage. Two pieces of tracheal cartilage were used because there were no ossicles. After confirming there are no ossicles, this is the stapes you can see. One cartilage was placed on the head of the stapes, and another cartilage was used to reconstruct the superior attic wall, attic reconstruction, which you call. And later on, the graft is placed overlay of this. See, there's the reconstruction of the superior attic wall. And this is how the graft is placed. That will be the final picture. These are usual post-op protocols. I'll give a apply good topical ointment, give a mastoid bandage, give antibiotics and steroids for 1 week, follow-up suture removal 8 days, second follow-up 15 days, third follow-up 1 month, and audiogram, post-op audiogram after 3 months. This is the post-op audiogram after 3 months, which reasonably good improvement. What is more surprising is this high-frequency SN loss somehow is beyond explanation. Even I had a word with Dr. Vincent. He was also clueless and without any answer for this. So there are simple tricks. Take a big graft. Always take full cuff elevation. Choice is yours, underlay, overlay. But 360-degree graft has to be put, and see to that there is no raw bone exposed. There is a literature comparing results along with this. And to summarize, always operate in a dry area. Exposure is of immense importance. Canaloplasty is very essential if you can't see the annulus everywhere. 360-degree flap elevation on head of malleus is my choice. Preferably, underlay technique for me with graft always medial to the handle of malleus. Again, there are different schools of thoughts, but I prefer medial to the handle of malleus. And I always put antibiotic steroid soaked gel foam medial to the graft in the middle ear and near the eustachian tube opening. Good time with Minesh at Cos Clinic with Dr. Vincent and with Sir. Thank you so much for patient listening.
Thank you, Samir. It was a very nice presentation, especially for the beginners. And Samir, I would like to add one more thing for a great, good result. Suppose the graph folds inside, you have to.
Can I start, sir?
Yes.
I'm Dr. Rajbhai. Why to waste time, I think. Thanks all the patients hearing crowd in the last minutes of the conference. So I think I saw Dr. Deshmukh's ear surgery tips and tricks. So I just removed all my ear video slides, and I just kept only nose and thyroid. So just if you if you go for any distance and on the road, you get so many steps, so many turns, round, left or right. And the same thing is in any surgery, whether you are doing ear, nose, throat, you have to accept it because every step has its own advantages and disadvantages. You have to follow it. But all are the videos, nothing like theoretical. So I would like to recommend that never play with the patient after seeing the videos, the dummy videos provided by the companies for their promotion. Always, so after seeing these video clips, you feel that you are the best surgeon, but when you go for this patient, you do always some mistakes. So never follow, never, at least see the video, try and learn under someone's supervision and then go for the patients. So never follow it. Pre-op preparation, I think he has already explained all the cases, but in all ENT, we have no many protocols for all the things, but few things I would like to share that always have a good ambience in your operation theater, keep some light music, always ask your patient to go for this maneuver, means ask patient to go for the urination, because that full bladder is the cause of hypertension during surgery, and whether during the local or GA, it makes a difference. So, and no time limit. Never keep anything pending in your outpatient department, because if you have your theater and OPD together, so no time limit, no pending work, because you don't think that you have to finish surgery in 2 hours. You have to see the patient after. These things keeps in mind. And I'm skipped all the ear surgery cases. This is the nasal. So know your instrument. This is basic mistake which I have done in my past. Though I don't have that video recording, but I kept this video. Do not start the debrider, because it is a tool which I have seen 3 cases. And the newcomers or those who are under training, they damage the ala of the nose. So always try to take the debrider in and then start it. And always know the physics, biophysics of the microscope or whatever light source you are using. It is a video clip of 20 seconds. I just borrowed from my Facebook friend, and just because he was using that light source which warned the cauda, you can see over there. These things you have to keep in mind before taking the patient. Regarding the instrument, nasal instrument, whatever instrument you should have your own instrument. Never go to others' place and borrow the instrument from the other, because like this, you may be on table, you may be in trouble. He is trying, it is a non-cutting seizure, he is trying to cut the thing. So just check your instrument before starting any case in any field. We do lots of septoplasty, but detailed and nasal endoscopy, most of the patients comes to us with the nasal blockage, with recurrent post-nasal drip, etc., etc. And we just see the nasal cavity, we do the CT scan, and but in many cases, I think out of 10, we see 1 or 2 cases, we get such findings, and in spite of a wonderful septoplasty or surgery, you get these things later on because patient doesn't get improvement because he has recurrent, he developed almost same symptoms persist after like like throat like this because of PND. So accessory maxillary ostium, volume 1 is ka? And if you go in detail, you see the accessory maxillary ostium, frontal, so many things are there which you have to look before going for whether it is some because diathermy, septoplasty, whatever is your, but do the nasal endoscopy in advance so you can do the thing. This is a 3 times operated case. Follow the basic principle of any surgery because if you are doing any FAS, the basic is that same thing that accessory maxillary ostium, this patient been operated 2-3 times, but just see, still the ostium is there and the flow of mucosa is there, mucosa is there, and patient is the same symptom in spite of being operated 2-3 times. So make a big opening, try to just check whether there should be no recurrence or no synechia or nothing like that in the follow-up. So follow the CT scan. It is just recent CT scan, and we should check the CT scan on own. Don't go through the report as been discussed by Dr. Satish in the last 3 days. Now find each and every step, find each and every structure in your CT scan. In this case, it is an extensive AFRS, and we have a tendency to use our debrider, whatever instrument, and we try to clean it out as fast as possible. But these are the cases we get complications, like see, after the surgery, this anterior artery was hanging over there. And if you take out like a forceps or a debrider, you can damage it. Then it takes hardly 3 minutes to clean it out and also under vision, and you can cauterize it, whatever you want to do. But better to cauterize it because for the future cleaning, you can damage this artery. Follow the basic principle again. Follow the basic principle. What are the principles that do not play with the nasal mucosa as been told from the first day of our endoscopic sinus surgery? Be gentle with our nasal mucosa. Do not disturb ground lamella. That is the biggest region you can say sequelae or you can say complication. In our post-op cases after 6 months, you see everything is fine, but your lateralization of your middle terminate, which we have kept intact over there. And do not play with the axilla, which we have a tendency to roam around that area. So, and I would recommend, and I'm doing since so many years, either I'm trimming out the middle terminate or vulgarization is not working. This is my personal experience. So I always try to stitch the middle terminate, both the sides. It takes hardly 30 seconds or 1 minute. Now we have a bigger forceps for this. Stitch forceps is there. You can do it very fast. And to get such type, because we expect in our first post-op follow-up, we should have our nasal cavity like this. And if we have this, then we are the luckiest person, and even for the patient, all are very happy. Otherwise, if you do not do in proper way, you can get lots of synechia over there. And synechia, in spite of, once the synechia are there, it's very difficult to take it out because if you do, you have to put a stent over there. Again, you have to take the patient to put the nasal pack over there, and the compliance and the comfort of the patient gets down. And lateralization is one of the biggest, I think I would say. So keep this area because we have to, we should respect the ground lamella if we are doing something in that area. And recently, in last 2-3 years, this Denker approach has been very much popularized. And we have seen, many cases of this post-Denker complication. And I think it is a wonderful approach being propagated by our dear friends. So first of all, it should be bloodless. Do as much as hemostasis. Prefer to use drill to dissect the bone. We can use the gouge or hammer, but with due precaution. And never cut the lower end first attachment, especially if using the chisel or hammer. Take out the upper end, then take out the lower end, or take out the bone together. Otherwise, you will have this issue because you will have a hanging bone, and that can damage your frontal process maxilla or nasolacrimal. That is a very common finding, and you can develop some epiphora, etc., etc. And don't try to go very forward, because I have seen this, but this picture I have taken from Dr. Basir from his consent. There is a post-Denker complication because of the excessive removal of the bone and ella from this thing. So these are the few findings, and we see all the CT scan even on the table. If you find that you have done everything is perfect, always look in the adenoid area, take out in the same setting. It takes hardly 1 or 2 minutes under vision, and a targeted cleaning of the adenoid is must. Otherwise, you can have some complications. So try to do on the same setting to give a perfect comfort to the patient in follow-up and later on. And DCR, this is, I think we do, all are doing DCR over there. But this step I love, and I would like to share with all that when you see the bone, if you have a birth, that is well and good, but try to use this step to take out this bone in a single piece. See the hand movement and the pieces coming out, and the chances of post-operative synechia, and it would be a very healthy opening later on. That step you should use in your cases. Now in thyroid, I've taken out all the slides. Thyroid, this step, because we have seen so many surgeries done by our seniors, our colleagues, and the finger dissection is being recommended by them, but they are the expert. It looks very simple step, but it has many complications. Until you are in a very proper plane, never try to use your finger for the dissection, because you can damage your arteries and vein over there. So after seeing all the things, okay, and make a habit to use microscope. Since 3-4 years, I am using microscope. I'm very comfortable with. Always look for the recurrent laryngeal nerve. You just follow basic principle of the thyroid surgery. Look for the old triangle. Look for the middle thyroid artery. Look for your parathyroid gland, and then dissect it. इसमें आपका वीडियो कैसे आ गया? अच्छा, you can go up to the extent full length, then dissect it, then take it out. So you be sure that you have saved the recurrent. Don't try to play with it. Always try to find parathyroid gland, and as per the landmark, especially if you're doing bilateral thyroidectomy, and it is mandatory to preserve the superior laryngeal nerve. It is since we are dealing with all the type of patients. So, and when you put a drain, put your forceps from inside to outside. Never try to go from out in, otherwise you can damage the important structure. Unsaid complications, because we should take the cosmetic part also. Use a proper cosmetic thing. Never do such thing, and try to make an incision, whether you're doing the right side, left side, but the incision should be on both the sides with a cosmetic looking approach. Unsaid complication, again, use proper hemostasis before closure. If you're not comfortable, you can put the drain, but if you don't do this thing, you can get such complications. It takes a lot of time to get a normal skin if you have a hematoma inside your skin. Same thing is parotid. Try to go for cosmetically good looking incision, which nowadays we are taking for the behind the tragal. Always look for the post-auricular nerve and preserve its posterior branch, because loss of sensation in lobular area can be very uncomfortable for the patient. So always look for the nerve. Okay. Never forget to find a tragal point before facial nerve. Wide exposure is must for, and most important, avoid any cautery in parotid nerve plexus, because it can give a post-operative morbid as well as cosmetic effect, though it takes some time to heal up. And so nasal endoscopy under anesthesia is recommended if you're getting a patient of recurrent epistaxis. You not getting anything recurrent episode, always take the patient under anesthesia. You can find these cases. I have seen many cases, telangiectatic hemangiomatous lesions, which can be cauterized, and you can give a perfect result to the patient. Thank you very much for this guidance.
Very nice presentation, Mr. Rajiv Pachauri. Thank you.
Sudhir.
Sir, very nice presentation. But I will not agree with one point, basically, for that you said that we should have a light music in the OT. I'll tell, 1 minute. I'm coming to it. Let me finish first, okay? There have been many medical legal cases, okay, where the patients who have landed up in complications have proved that when the music is on, okay, the concentration of the doctor, the operating surgeon is divided. It has been proved in many. It has been
medical
proved.
legal expert is there.
Okay, it is. And I'm coming to it. You can play music in the OT, provided you have to take a separate consent of the patient that whether is it okay for you. And when the patient gives a consent that yes, the music is okay for it, then only it can be played.
If it is right, then we will add this point in our next.
Absolutely.
Any comment of Rupali is there?
No, I can. I have done. Yeah. I'm in the panel of medical legal, and we have come across to it. Absolutely. This is a very valid point, basically. Okay, and basically, see, it doesn't. Yeah, there is no problem. Okay, the problem comes when there are complications. And when the lawyer, he asks the patients, what are the things, kaisa tha OT mein kya hai? Are OT mein to music system hai. All these things. So this all comes to it. It's, there is a, बाकी कभी प्रॉब्लम नहीं आता है कॉम्प्लिकेशंस हुआ तभी प्रॉब्लम जरूर आता है यू कैन प्ले बट देन यू हैव टू टेक अ consent. See, recently I visited Italy, one Dr. Daniel Marchioni in his OT. They don't allow mobile phone also inside in their OT complex. Forget about music. Okay. The mobile phone is also not allowed. There is a, in the core OT complex, even mobile phones are not allowed. Absolutely. Yeah. Absolutely. That is also a valid point. But he can also say that since last so many years I'm operating, okay, I operate daily 10 cases. So no complications. So that point is gone then. Yeah. Okay. So then that means as the age advances, then you become an incompatible surgeon.
Excuse me, sir, I'm sorry to interrupt.
It doesn't say
but
that.
we have to continue with our session first, sir.
Yeah, thank you.
Thank you, sir.
Good evening, chairpersons, dear friends. Thank you, Aoicon, for giving me this opportunity to present my talk here. And today I'll be discussing upon the do's and don'ts of the tracheal stenosis. As we all know that the tracheal stenosis is a complex and a challenging problem, and because of its complexity, and no single treatment modality can solve its problem. So according to the nature of the problem, the variety of treatment options are available. Then we come to the investigation part. Investigation for the tracheal stenosis is the virtual 3D CT bronchoscopy, and this is the modality of choice. Virtual 3D CT bronchoscopy has enabled us to understand and plan our course of surgery. It allows us the direct visualization and the cross-section of the airway. It can determine size, extent, and the lesion, and it allows to plan our further surgical course. 3D CT bronchoscopy gives us the good visualization of the vocal cords. The cricoid evaluation is good with this, and the luminar caliber can be measured before we venture on any procedures. We can even calculate the length of the stenotic segment, length of the cricoid to carina, then cricoid to proximal end of the narrowing, and from distal end of the narrowing to the carina. So the relation to the tracheostomy site even can be assessed beforehand by doing a virtual 3D CT bronchoscopy. We can even assess the number of tracheal rings involved if the tracheostomy was performed, and any other measurements needed for the surgery. Then another important investigation for assessing the tracheal stenosis is the video bronchoscopy. So what do we look for? We look for the status of the vocal cord, whether cords are normal, paralyzed, the position of the arytenoids, whether arytenoid subluxation, dislocation, if it is there, Then the character of the stenosis, whether the stenosis is membranous, it's an anteroposterior, lateral stenosis, circumferential stenosis, and the cicatrice or the fibrous one. So this information we can get on the flexible video bronchoscopy. Medical treatment we won't discuss here. Then we have the different surgical modalities for the treatment of the tracheal stenosis. First is the rigid tracheal dilatation. Then second is the laser ablation, balloon tracheoplasty, T-tube tracheoplasty, and the tracheal resection and anastomosis. We'll see one by one. The rigid bronchoscopy and tracheal dilatation is a very handy tool. It is performed usually in the emergency if patient is not prepared, and to get into the access of the airway, we can perform this. But the rigid rigid bronchoscopy requires a repetition, and the repeated dilatation needs to be carried out. So this is the drawback of this procedure. Even the rigid tracheal dilatation can be performed for the intralesional use of the steroids, also for the application of mitomycin C to prevent the adhesions and the granulations at the stenotic site. Laser ablation is another tool, and laser ablation along with this, the dilatation can also be done. So indication for the laser ablation is the supraglottic lesion, and the contraindications are the circumferential scarring, the vertical scar more than 1 centimeter, posterior scarring with the arytenoid fixation, and loss of cartilage support. The lasers we have available these days is the CO2 laser, diode, holmium, and the argon plasma. The commonest used lasers are the CO2, and these days the holmium is being used very commonly. CO2 has its disadvantages because it cannot reach at the site of the stenosis. It works in the site of the eye, so we cannot divert the laser on any other side. Holmium is used by the fiber. It can be delivered at the stenotic site. Even it can be passed through the upper GI scope or the bronchoscope. And CO2 can cause fire. CO2 can cause more charring, and it's not a friendly laser to take a control of the bleeding. Whereas holmium works better in the water medium and has the advantage of taking hemostasis as at the control. So balloon tracheoplasty usually is done for the membranous type of the stenotic lesions, and in conjunction with the laser ablation. It is carried out using flexible fiber optic bronchoscopy or upper GI scope and the balloon dilatation catheter. It reaches a diameter of 15 millimeter at 4.5 atmospheric pressure and 18 millimeter at 7 atmospheric pressure. Near uniform distribution of radial force over the circumference of the stenosis to avoid the hourglass effect, and there is no risk of airway rupture or any mucosal trauma. The repetition can be done at the interval of 1 to 3 weeks. Then comes the tracheoplasty, the T-tube tracheoplasty. This is performed when the stenotic segment is long enough so that we cannot go for the resection and anastomosis, which is supposed to be the gold standard treatment. Here, what we do is, we have to open up the stenotic part of the trachea, and then after opening the trachea, and this is the stenotic part, as the stenotic cartilage has a recoil inside, the elastic action is broken along the sides of the tracheal cartilage, and then this tracheal cartilage, after breaking up the elastic action, is then sutured to the sternomastoid muscle in order to create the turf of the open tracheal turf. And in this turf, then we put the T-tube. So what are the do's and the don'ts of the T-tube tracheoplasty? If the laryngotracheal stenosis is more than 5 centimeter, this is definitive indication of doing a T-tube tracheoplasty. Multiple segment stenosis, failed tracheal resection and anastomosis. Patient, if it is not amenable for the resection and anastomosis because of neurological problems, patients with recurrent stenosis, patient with good laryngeal function and normal vocal cord mobility and good pulmonary reserve are the candidates for the tracheal T-tube T-plasty. T-tube tracheoplasty is not done in the malignancies of the neck. In pediatric cases, less than 12 years of age, burns of the neck, patients with poor general condition and poor pulmonary reserves, and also in the congenital stenosis. Another modality of treatment and the gold standard treatment modality for treating tracheal stenosis is the resection and anastomosis, where we have to find out the stenotic segment by doing a virtual 3D CT bronchoscopy and the video bronchoscopy. We have to assess the stenosis, resect the stenosis, and then we have to anastomose the two resected ends of the trachea. So this is how, this is the preoperative, and this is the post-op video virtual 3D CT bronchoscopy. This is the post-op video bronchoscopy. Here we can see the anastomotic line in the 3D CT bronchoscopy. So tracheal resection anastomosis has two things which needs to be done. First is the laryngeal drop and the second is the retrosternal mobilization. So laryngeal drop is done if our resected segment is more than 3 centimeter. So if you do the laryngeal drop, then you can get additional length of 3 centimeter from the above, from the laryngeal end. And then if you mobilize the trachea retrosternally, that gives you another 3 centimeter of a tracheal length. So to have the tension-free anastomotic suture, you can borrow this length from superiorly and from inferiorly by doing a laryngeal drop and the retrosternal tracheal mobilization. The role of T-tube is definitely there after you do the tracheal resection anastomosis in cases where your anastomotic site is below the suprasternal notch. So in case if you have to avoid any uneventuality in the form of dehiscence of the tracheal suture line, then on the safer side you have to put the T-tube that saves the patient from landing up into any catastrophe. Sternomental stitch and the neck scaffolds are mandatorily used in every patient where we go for the tracheal anastomosis. The role of intraoperative bronchoscopy. This is very important to assess the position of the upper end of the tube and the position of the lower end of the tube. The upper end of the tube should be below the level of the vocal cord, say for around 1 to 1.5 centimeter, and the lower end should be around 1.5 to 2 centimeter above the carina. Now, what is the advantage? Through the tube, if we do a bronchoscopy, we can even assess the positioning of the tube, the lower end, the upper end, and also if you have done any resection and anastomosis, you can see the suture line while coming out of the trachea. So this is the suture line where you can assess your healing also. Post-op follow-up duration, ideally these patients needs a follow-up of around 2 years. Every 3 months, patients either a bronchoscopy or 3D CT bronchoscopy needs to be done. But bronchoscopy being an invasive procedure, on that we prefer doing virtual 3D CT bronchoscopy. If your patient has any difficulty in breathing, dyspnea, crustaceans, coughing, then the check bronchoscopy, video bronchoscopy is indicated. Dilatation protocols, 3 to 4 weeks every time if you have done only the dilatation procedures by the balloon after doing a laser and balloon or after doing a rigid tracheal dilatation. Now we'll consider certain scenarios what to do in such cases. This patient met with an accident, craniotomy was done for the large EDH, prolonged intubation, so tracheostomy was performed. 1 month after the discharge, patient comes back with a stridor, intubation fails, and then crushed tracheostomy should be performed from the previous scar. Then what next? Still here we have not assessed the stenotic site. So we have to wait till the stoma is formed because you have secured the airway, and after 48 hours to 72 hours you have to remove the tracheostomy tube and get the patient's virtual 3D CT bronchoscopy done, assess the stenotic segment and then do the resection and anastomosis. In this case I have done the resection and the cricotracheal anastomosis. This is another scenario wherein a 38-year-old female came with the stridor since 3 days. Since 3 days, history of huge neck swelling was there for 30 years and there was no neck or tracheal lumen was 4 millimeter. This 3D CT bronchoscopy was suggestive of a narrow and the scabbard trachea. Patient underwent total thyroidectomy with preservation of bilateral recurrent laryngeal nerve, preservation and the parathyroids. Post-extubation, patient had a stridor. Ideally, we put an endotracheal tube for 48 hours. After that, we do the leak test and we remove the endotracheal tube. After doing so, patient also went into the stridor again. So what to do? Whether to do the tracheostomy or whether to put the T-tube. Tracheostomy in this case is not indicated because there are the collapsed walls of the trachea. If you put the tracheostomy tube, you will have again your bulb hitting to the scabbard walls of the trachea and there the stenosis will be ensuing. So put a T-tube in such cases. In third scenario, the 48-year-old female with the history of difficulty in breathing since last 2 years and increased recently since 1 month. She had a noisy breathing and past history of tuberculosis. For this, she took a 6 months AKT. There was a mild inspiratory stridor, use of accessory muscles were there, no neck scar, and she was able to speak, but with the efforts, and bilateral chest tronchi were there, and at rest, the saturation was 92. She had a past history of 3 bronchoscopic biopsies being taken, all were inconclusive, and the history of twice admission for the same symptoms in the last 1 month. So we subjected this patient for the virtual 3D CT bronchoscopy. which shows us the extraluminal homogeneously enhancing soft tissue density lesion in the cervical part of the trachea at D1 vertebral layer along the left lateral wall. This lesion was measuring 2 into 1.5 into 1.8 centimeter with the narrowest lumen dimension of 4 millimeter. Approximately 4 to 7 tracheal rings were involved, and the lesion was 3.7 centimeter distal to the cricoid cartilage and with the indistinct fat planes with the adjacent esophagus. So we did the video bronchoscopy wherein we could see a soft globular mass projecting out from the lateral wall and narrowing the lumen of the trachea. From the virtual 3D CT bronchoscopy, it was quite evident that this mass was the extraluminal pressing over the trachea and causing the tracheal narrowing. Please excuse me for 5-10 minutes. So, as the esophagus was having indistinct fat planes with the trachea, we did the esophagoscopy, which was apparently normal. And then whether this mass was a benign or malignant, that how to assess. Then we have to do the endosono-guided biopsy, and which was suggestive of the severe inflammation with the plasma cell. So here we got the diagnosis that this lesion was not a malignant one, but this was a benign lesion. And this patient underwent tracheal resection and anastomosis, and we had to put the T-tube as a safety measure because the anastomotic site was below the level of the suprasternal notch. So this patient of the G-base had a breathing difficulty. He had a failed decannulation, and on bronchoscopy we could see the infection and the granuloma at the tube site. So the culture swab was taken, sent for the culture and sensitivity, and it was treated with the antibiotics, steroids, and then the granuloma was excised. This patient is not for the balloon dilatation or for lasers. In further scenario, this patient had undergone tracheal resection and anastomosis somewhere else, and he landed with a stridor to us. And on video bronchoscopy, we could see that there were intraluminal sutures. So dear friends, the material also which was used for the anastomosis was not advised. Here the proline was used, whereas we have to use the vicryl as a suture material. Secondly, the suture line should be always buried. The sutures should be the burying sutures and not the sutures projecting into the lumen of the trachea. Now, every one of us does the tracheostomy. What we do, there are certain people who are doing the flap tracheostomy. They create the opening in the trachea and just put the tracheostomy tube inside. In this process, what happens is the tracheal flap created, it gets inwardly rotated, and that's how it causes the damage to the mucosa on the side walls and over the posterior wall. And this was the cause of the stenosis. This patient underwent resection and anastomosis. This patient had some intracranial problem for which he had undergone surgery, and the tracheostomy was done. After tracheostomy, T-tube was inserted, and this T-tube, the lower end, was at the just above the carina, and she developed the granulations. So here we had to use the laser. This is the holmium laser, wherein we have to buzz off these granulations, and after that we have to do the balloon dilatation in order to get into the normal lumen of the trachea. And this patient also had some surgery in the past. Patient developed, patient had a tracheostomy, followed by that decannulation, and the T-tube was placed. T-tube was removed after two months, and then patient again developed stridor. Again, one more attempt was made to put the T-tube, and then some chest physician came and he inserted this metallic stent. So dear friends, this is an absolute contraindication where the metallic stents are used. Metallic stents are used only for the, only for the palliative cases. And this is the video bronchoscopy of this patient. You can see the upper flanges and the lower flanges, they are almost buried in the mucosa. The lower flange is almost hitting the carina, and the mucosa has grown over it. Now, how to tackle this patient? We have to bypass his lung function by doing a AV ECMO, and then we have to remove the stent, give the time to mucosalize the trachea, and after that, he is a patient for the tracheal resection and anastomosis. So cuff pressure needs to be monitored. It has to be always lower than the normal arterial pressure. Intermittent cuff deflation and inflation should be performed. Mucosal injuries to be avoided. Flap tracheostomy should be avoided, and the appropriate size tube. That means one size lesser the size of the tube which is required to the patient is always kept. Either it is an endotracheal tube or a tracheostomy tube. So to conclude, numerous treatment modalities are available for endoscopic and open approaches which render the selection of the right patient for right type of a treatment is difficult. End-to-end resection anastomosis is the gold standard single-stage procedure. Rescue surgery in difficult situation is a tracheoplasty and the T-tube placement. Lasers, balloon tracheoplasty and rigid dilatation has limited role and require repetition. Thank you.
Thank you, Mr. Salesh. Very nice presentation.
Thank you all the speakers for such an interactive and informative session. Now I would like to call up the chairpersons to come on the dais and felicitate our speakers. The first I want to call Dr. Umesh. It's completely being a pleasure, sir, featuring all these informative ideas and things in the Jaipur Aoicon 2023. Sir. Next, Dr. Sameer Deshmukh, kindly come on the stage. Dr. Rajiv Pachauri. Dr. Sailesh. Dr. Sailesh. I would like to invite Dr. Rajiv Pachauri, sir, to come on the dais and felicitate our chairpersons. But now, and the last and not the least, I would like to call all the speakers to come on the stage for a group photo with the chairpersons. Thank you, sir. Thank you. Thank you all the chairpersons. It's for a good night. And it's at end of the day too. We'll meet on tomorrow.